Good morning, everyone. Am I audible?
Yes, sir.
Okay. So I welcome you all to the day two of the Osteo Integration Mastery Conference, where we'll be learning about basic to advanced implantology. Handing over to Khushi Bhandari, you may please introduce our first speaker.
Good morning, everyone. We are delighted to begin with our first lecture on the topic implant prosthodontics from single tooth to full mouth rehabilitation by Dr. Divij Khullar. Dr. Divij Khullar has completed his MDS in prosthodontics from Savita Dental College, Chennai. He is a fellow of Pierre Forcher Academy and a BPS specialist certified by Ivoclar, Switzerland. He is also a world record holder and extensive experience in full mouth rehabilitation. With his vast clinical expertise and dedication to his excellence, he has made significant contributions to the field of prosthodontics and implant dentistry. It is truly an honor to have you with us today, sir. We extend a warm welcome and look forward to an insightful and enriching session. Over to you, sir.
All right. Good morning, everyone. Is my audio clear to everybody?
Yes, sir, you are audible and you are visible also.
Perfect. So, can I just request all the participants to switch on their video cameras if it's okay for the first 2 minutes? Let's have a brief discussion and then I take the class from there on. So, what I want to ask everybody present here is that how many of you are placing implants regularly? If you're not comfortable with your cameras on, you can just unmute yourself and answer. How many of you are comfortable placing implants? Or how many of you are restoring your implants yourself? All right. So what we are going to do today is we are just going to have a brief discussion about the stage two of implant prosthodontics. We would just be discussing about the conventional approach of implant prosthodontics because, of course, scanners are there. They're always there to help and make your job easy. But we understand that not everybody has a scanner on itself. So what we are going to do now is, since this is about the prosthodontic aspect of implantology, we will not be discussing about how to place an implant, but I'll just be taking it from there. So let's assume we have placed an implant and now it's been 3 months or the time that you require to start loading the case, and it's time to start finally giving the crown on this particular restoration. So be it a single crown, be it a full mouth, the concept remains the same. What we are going to do over the next 1.5 hours is that we are first going to discuss how do you load an implant. Basically, how do you take these impressions with probably an open tray, a closed tray? What are the components of implant prosthodontics in a very brief manner, considering that most of us are new to this? Let's keep it small, brief, and interactive. Once that is done, we would come to the most important topic. Everybody can give implant crowns, be it a single crown or a full mouth, but the key to implant crown survival is the occlusion that you set on it. So once we have discussed how do you reach that crown, we would be discussing a lot in depth about the concepts of occlusion on dental implantology, which would remain the same for a single crown and go all the way to your full mouth as well. So without wasting any further time, we would start with the main feature presentation. What I want to request all of you is that during the course of the presentation, I would request you to keep your mics on mute because then the sound echoes for everybody. And also at the same time, if you have any doubts, the question answer box is there for that. Keep noting down your questions. We would stop right at the end of it to discuss anything and everything possible. At any point where you feel that my audio is not clear or the video or the screen presentation is not clear, you're more than welcome to just unmute yourself, stop me right there, and I would be happy to take it again. So when I talk about implant prosthodontics, the first and the foremost thing that you need to understand is that there are several components that are there on dental implantology stage 2. One of them being your healing abutments or healing caps, the others being your implant crowns, the third being your abutments, so on and so forth. So let's do one thing. Let's understand this with the help of a brief animation from the word go. So let's discuss implant stage 2, the conventional way of doing it. So let's assume that you have already placed your implants. It's been the set 3 months for your loading to begin, and now it's time for you to load. So the first thing that you do is what you see on your screen is basically a healing abutment or a healing cap or a gingival former, in other words. So what this does is that it makes sure that your gums have taken the shape of the implant, and it gives your implant crowns a emergence profile, something that is very natural to look at. Your crowns that are there, your natural teeth that are there, don't look like they have just been placed on the gum. They look like they are coming out of the gum, and that's exactly what this healing abutment helps us to achieve. So 3 months are done. The first thing that you do, you take an X-ray, you see that the implant has also integrated very well. You open the small flap from that end and you just place the healing abutments. So once the healing abutments are inside, that's how it looks. The implant has the healing abutment screwed, and you see this area around the gum. That's what takes the shape of the healing abutment. Now, these healing abutments are very well polished, as you can see on your screen as well. The reason they are polished is because anything that's extremely polished does not let gum adhere or stick to itself. So even though the gum will take the shape of this smooth, polished healing abutment, it will not stick on to this healing abutment. And thus, when after a week's time or a couple of days, when you have to remove this healing abutment, your gums are perfectly in the shape to take the crown that follows. So once the healing abutment's done, the usual wait time is that you place the healing abutments, you wait for about a week to start your stage two. Certain cases where you feel that the gum invasion has been minimum, you can probably start this in just about 3 to 4 days, depending upon how well the gums have healed. So once the healing abutment's done, it's time for you to now start taking impressions. Now, when you take an impression for a tooth, the material that you possibly would want is a C silicon or an A silicon putty light body impression for a final crown. The same holds true for a conventional implant impression as well. The only thing that changes is that since the implant is inside the bone and you absolutely have nothing on top for you to take an impression, you need to put something called as impression copings. Now, this is what an impression coping looks like. All you do is, again, you just unscrew the healing abutment, you screw this impression coping back in, and that's how it looks. It's actually this big. It comes out of the crown area of the adjacent tooth. The reason being that you see this fixature right on the top, this has to come out of the tray that you are taking your impression from. So what I'm going to do is right now I'm just going to explain you the various components that are there. Then we have live demo videos which are animated for you to see how an impression is taken both in an open tray and a closed tray. Once that is done, we would discuss where exactly do we need an open tray, where exactly do we need a closed tray as well. So in the first 5 to 10 odd minutes, all we have discussed is two components. One's the healing abutment, and second is this thing called as the impression coping. Now, once you have placed this impression coping, the next thing is that see, you need something called as an open tray. Now, what exactly is an open tray? An open tray is nothing but your own special tray that you fabricate with your denture base is. For your denture bases in your complete dentures, the same acrylic monomer polymer is used to fabricate a tray onto this impression, a tray that is open from this area that lets you take the impression of these implant crowns. Now, why do I need the tray open from this area? Let's assume this implant has been placed in the first molar and the second molar area. So your open tray impression would possibly be open from the area of your first and the second molar for this metal fixature to jut out of the tray. Why do I need to jut it out? The reason is that once I've taken the impression, I need to finally unscrew this impression coping for it to come out of the implant. So if it is enclosed in a closed tray setup, I will not know where this fixature is. I'll not be able to unscrew it, and thus the impression would not be perfect. So there are two types of impressions basically. One's an open tray impression, and the other is a closed tray impression. The open tray impression is something that we are just learning, something like this, where the tray is cut open from the area where the implant's present. We take the impression with the same putty light body, we unscrew it, get the whole fixature out. So let's understand what happens now. Once I have taken the impression with the help of any material, C silicon or A silicon, let's assume that this impression is placed on the implant. Now, what I'm going to do is right now I'm just going to unscrew this impression coping. stop here briefly and ask you all to just come back for a quick question and answer session. Let's just understand if everybody's on the same page and we will take it back from there. So, can I just request all of you to just switch on your video cameras for a second and let's have a brief discussion. So, we've just discussed about the implant open tray. We've just discussed about the implant closed tray. Is the video animation clear with everybody? Anybody has a doubt in the same? Perfect. So, is the concept of an open tray impression clear? Is the concept of a closed tray impression clear? Now, what's possibly the difference between an open tray and a closed tray? An open tray impression is basically something that is required to take for multiple crowns. Now, let's assume I'm placing, say, multiple crowns in a quadrant or I'm doing a full mouth impression. I would be using the open tray system where the tray is open from the top. I put the impression compounds, I unscrew them once the impressions are done so that there is absolutely no shift in the impression compound or the impression copings whatsoever. A closed tray impression, something that has less chances of giving me an accurate impression, is okay for a single or a double crown that is to be placed. But the minute I have to go beyond two crowns, the minute I have to do multiple crown placements or a full mouth, my job is to make sure that I'm giving a an open tray impression so that I get the utmost perfect impression whatsoever. So that's basically the difference between an open and a closed tray. The components remain the same. So till now we have discussed four components. One, the lab analog that is to be placed in the cast that will mimic the implant in the cast. Second, the impression coping with which you will take the impression. Now these impression copings are different for your closed tray and different for your open tray, something that you just saw. Third, we discussed something called as the healing abutments. Now, what were these healing abutments? A quick revision here. These healing abutments were nothing but just simple metallic large screws, you could call them, just to give the shape of your implant crown with the gums and give it that emergence profile for it to follow. Now, what we are going to do now is let's assume the impressions have been taken. We have gotten the cast ready. Let's take the workflow from there and understand what happens now finally in the lab. How are they going to fabricate your crown? What do I do on the chair side all the way till my implant crown is fixed? And then we come back to discuss the next set of doubts. So we've just discussed the impressions that have been taken. Now see what happens. Once the impressions are done, that's what's happening inside the impressions. So you've placed the impression copings, that's the lab analog that's there. They put a soft gum silicone, something that you just saw on the cast. There was a small amount of gum that was there. That's just to mimic the gum profile and give it an emergence profile there. The same emergence profile basically was given to your gums with the help of these healing abutments as well. Now, once that is done, they have poured this cast, and this cast is ready to finally be used to get your crowns made. So once the cast is poured, that's how something it's going to look like. The cast is there. They have the gum that they have just poured with the silicone. That's your lab analog inside the cast that acts as the implant in the patient's mouth. So you have gotten your master cast poured. Now is the time to use something called as a depth gauge. Now, this is something that the lab generally does, but since you are new to this and you're understanding every component required in stage two, let me explain what this does. Now, how deep is the implant placed inside the gum? The only way to find that out is with the help of your depth gauge. Now, what this depth gauge does is just have a look. This depth gauge is going to go and we're just going to put it all the way in the implant. We don't want to screw it. We just want to put it. Now, do you see these lines? Each of this line is 1 mm apart. So what this is going to do is it's going to get you the impression idea of these implant, that how deep is this implant placed inside. I take it back a few seconds and I show you once again. So all it does is it just puts the coping or the implant lab analog in contact with the depth gauge, and all we do is we see the measurements. We see that 1, 2, and 3. So basically the implant's 3 mm submerged in the gum area. So what this does basically is that it gives an idea of the abutment that we are going to use henceforth to give the implant. So your gingival height is an important factor of the abutment that you select for any restoration pertaining to implants. What that does is that I would get an idea that my gingival height of the abutment that I want to select is supposed to be 1, 2, and 3. So what I'll do is I'll get an abutment that has a gingival height of 3 mm. So that's what an abutment looks like. The gingival height basically means that once the implant is screwed onto with the healing or with the abutment, my collar of the abutment should be 3 mm away from my impression that I have taken. Basically, if I just go back a few steps, just to show you what's happening, with the help of your depth gauge, we realize that, okay, we need an abutment that is 3 mm in height from the collar to the level of the implant. We use a similar abutment, fix it back inside the patient's mouth, and we get an idea that, okay, 3 mm distance from the implant, we get the collar of the abutment. Once that is done, we get the crowns fabricated in the lab, and it's time for us to finally mimic the same in the patient's mouth. So once the lab's work is done, what they're going to send you is probably they're going to send you an abutment that they have trimmed to perfection and the crowns, or they're going to screw these abutments or cement these abutments to the crowns and give you the total fixature altogether. So what you're going to do is you're probably going to just place it back in the patient's mouth and do something called as a jig trial. Now see what a jig trial is. It's basically something that helps me get an idea of whether my cast has been poured perfectly or not. Now, what this small video is going to show you is that let's go a few steps back. Let's assume that after the cast is poured, my abutments are here. Now, what these abutments do is before they get the crowns made, if the lab has any idea that or they feel that the impression is not up to the mark and there might be some amount of discrepancy there, what they'll do is they'll just use some pattern resin and cement or stick these together. So when they do that, they give you something like this. This is called a jig trial. So all you do is you put this jig trial in the implant in the patient's mouth. You screw it in the patient's mouth and you see whether the jig trial is perfectly seating onto the adjacent teeth as well. If it is, what you do is you go ahead with the abutment fixature. You get the abutment fixed in the patient's mouth and your crown's ready. You either cement it or you screw it as per your convenience. Cement versus screw retained implant crown we would discuss shortly, but that's what the whole lab workflow is. So I can understand that it gets a bit daunting sometimes. So let's just understand the whole process once again. Once the impressions taken, the lab would put some soft gum silicone. They would get your mastercast ready. They will put the depth gauge, get the height of your gingival height. They will use a similar abutment height on the gingival height of the abutment, get the abutments fixed. If they have doubt, they'll give you a jig trial. If they don't, they'll just finally go ahead with the crowns. They'll give you the crowns either cement retained or screw retained, how you have asked them for. And once that is done, you place that in the patient's mouth and you finally give them the crown. So just a quick understanding with the help of a case. Now that is the master cast, something that we've just discussed. That's the gum that's been poured. The implant kind of a thing that you see inside the cast is basically the lab analog that was sent. Now, with the lab analog, what they do is they have the whole implant that's been placed inside the patient's mouth, the whole paraphernalia system mimicked on a cast. They'll put an abutment onto it. Abutment could be different types, could be n number of materials required to get the abutment. Some other day we discuss that, get the abutment in shape, they'll trim it, accordingly get the crown placed, and they will send you this crown back. So if I have to show you the whole thick case on a patient, that's what a gingival profile looks like once you have placed the healing cap. Once you've done that, you have your impressions taken, the impressions done. That's your impression with the abutment inside the patient's mouth. So once the abutment's ready, you get the crown fixed, and that is your implant crown. So keeping it simple, before we come to the next topic, which is implant prosthetic occlusion, let's discuss a couple of things back on video. So what I would request you all to do is let's have a quick discussion. Let's come back on the videos Can you switch your videos on and have a brief discussion with the concepts that we have learned? Let's understand if anybody is stuck anywhere. So I'll just do a quick revision of everything that we have discussed. Right now, we have spoken about the components. We have discussed about what an impression is, what are the different types of impression, is there an open tray, is there a closed tray, so on and so forth. We have discussed something called as your depth gauge. We have discussed various materials that are required to use or do a stage 2 of an implant, and finally reached the implant. Anybody has any questions in the stage 2 conventional part, the either the components used or the open tray system or the closed tray system or what happens in the lab? Any questions whatsoever? Perfect. So what we are going to do now is we are just going to finally understand the last topic that is there. One being, when do I give a screw retained crown and when do I give a cement retained crown, and which one would I prefer as a prosthodontist? So both of them have their advantages. But what I would absolutely prefer is giving a screw retained crown for one reason, that the screw retained crown has absolutely no cement that is being placed inside the patient's mouth, number one, which means there's absolutely no chance of any cement going inside the gums, any extra cement being left behind, and later causing something called as peri-implantitis, which means nothing but inflammation around the implant area, leading to failure eventually because of bone loss. Now, if I don't want to go for a cement retained crown, can I always give a screw retained crown? What about cases that are angled and they are in the front? What do I do then? Anterior cases, I can't give a cement retained screw retained crown. So in such cases where I have to absolutely opt for a cement retained crown, what I preferably do is that I keep this minimal, which means if I have to load 10 implant crowns, I would really see if I really need to give a cement retained crown for reasons that, number one, it would always lead to some amount of extra cement seep into the gums. No matter what you do, it's always going to go in. Number two, your screw retained crown, eventually any crown or any prosthesis that you give requires some amount of, I would say, checking a couple of years later. Basically, something that is just to make sure that everything's okay. Now, there are certain failures that can happen with implant crown. One of them being your screw loosening, your screw fracture, your abutment fracture. Once you have cemented a crown onto the abutment and any of these failures happen, you have no choice but to completely remove that crown, sacrifice the crown, and somehow try to keep the implant safe. Whereas in the case of your screw retained crowns, if any of these things go for a toss, say your screw loosening happens, your abutment fracture happens, or your screw fracture happens, or you just need to get a basic servicing of the implant components after a couple of years, all you need to do is unscrew the implant, get the crown out, take care of whatever's to be done, and put the whole fixature back in. So two reasons why I absolutely prefer screw retained crown, and that's just not just me, but throughout the world, most of the leading dentists now and papers that are being published are preferring screw retained crowns over cement retained for these two reasons. Number one, no cement whatsoever inside the patient's mouth, thus no chance of any failure because of peri-implantitis. Number two, absolutely easy approach to get the implant serviced anytime in the future that anything goes wrong. Now, we have almost reached halfway. We have done the implant stage 2, we have done the components, we have done everything whatsoever. The next topic that we have to discuss is something called as implant occlusion. But before I do that, I would really request everybody to just switch on their video cameras if possible and let's have a brief discussion. How many of you are placing implant crowns? Even if you don't want to switch on your video cameras, all you can do is just type in the comment section. Let's have a brief discussion. How many of you are giving your implant crowns? So I get Dr. Rajshri. So I guess you are giving implant crowns regularly. So what
Yes,
are
sir.
you basically using to check the occlusion on your implant crown?
Sir, I'm been using the Bausch articulating paper.
Excellent.
Yeah.
And what's the
And
thickness
the
of that
shim
paper?
stock, sometimes a shim stock that is RT foil,
Okay, excellent.
and
Very good.
it has 8 to 12 microns of the thickness or the
Okay,
implants, and for the
perfect.
D it is more than 40 or 40 around.
Around 40 microns is what you're
Yes,
using.
yes, yes,
All right. Anybody else? Now, be honest, I'm not going to see who's answering. I just want to know how many of you are checking your implant crown restorations with the help of a carbon paper. Just type in or raise your hands. Carbon paper. How many of us are using that? So let's understand a brief concept here. Every time you bite, even though you don't realize, your teeth have some amount of micro movement that happens. There is something called as perineum. That's basically the shock absorber of your teeth. You bite, one tooth goes roughly about 20 to 25 microns up, and the lower one goes 20 to 25 microns down. So that's roughly a space of about 40 to 50 microns. Your carbon paper, if anybody is using that to check the occlusion on any restoration, how is that such a big blunder? The carbon paper is basically 150 to 200 micron thick, and that's one sided. So, what you do is you double it and you put it in the patient's mouth, making it 400 microns. You put a 400 micron or a 300 micron thing that is that thick inside the patient's mouth, where a space of just about 40 microns was present. That's why you get smudge marks all over your restoration. That's why you get your restoration giving you false marks. You end up trimming them completely and getting the occlusion out completely whatsoever. Now, when I talk about an implant, what's the problem? Your implant crowns are absolutely devoid of any kind of PDL movements because they're just osseointegrated directly into the patient's mouth. So if a natural tooth moves roughly about, say, 20 microns, your implant crown just moves about 3 to 5 microns, which means that even though somebody is using a good articulating paper, they have invested, Dr. Raj, you've invested well in the paper, you're using the best in the market called the Bausch, but the thickness is what is important as well. An implant crown, when it just moves about 3 to 5 microns, even if the upper one is an implant crown, it will also move just about 3 to 5 microns. That gives you a space of roughly what, 6 to 12 microns? If you're
yes.
putting a 40 micron paper in between a 12 micron space, you are again doing the same mistake as somebody is doing with the carbon paper in the patient's mouth. So all you need to do is, whenever you are checking the occlusion for an implant prosthesis, I want all of you to note this down. You need to use something that is extremely thin, something that is 8 to 12 microns in thickness. Now, let me make you understand what micron is. If you pluck a strand of hair and you just see how thick it is, that's 100 microns for you. Now, when I talk about 8 to 12 microns, just imagine that's basically 1/10 of your hair strand. So that's how thin that paper would be. That's how thin you need something to go in between your implant crowns to check the occlusion. So without wasting any further time, let's just go to the second half of this our presentation, something that's called as the implant protected occlusion. Because okay, we understand that you've given an implant crown, but unless you set the occlusion properly, the implant is bent to fail eventually. So before we discuss anything, there is something called as an implant protected occlusion, which basically means that the occlusion that you give to any restoration on an implant needs to be really protected so that the implant has minimal load because it has no PDL whatsoever and no shock absorption thus. So it has minimal load and thus finally survives the occlusal wear and tear. So before I talk about implant prosthetics, I want to ask how many of you watch movies? How many of you have watched Hindi movies before? Can I have your hands up? You can just give me a head up there. How many of you have watched this movie called Dhamal, the Bollywood movie called Dhamal? So what I'm going to do now is I'm going to play a screen, a one short video of that movie called Dhamal on the screen for you to understand one small concept. I come back and we discuss about implant prosthetic occlusion from there. So now this is a scene basically where there are four friends that are running away from the police. I'll give you a backdrop for those who haven't seen this movie. The police finally finds these four friends. They ask these people who wants to die first. Now, what they do is they say, whoever wants to die first, you come forward, we'll shoot you first. Now, what three friends do is they just move a little back, whereas one friend keeps staying exactly where he is. So when the policeman opens his eyes, he realizes that one guy is ahead of the other and thus asked him that, do you want to die? He said, no, I didn't move in front. But what happened was when his friends who were adjacent to him moved a little backwards, he was the one who, even though standing at its own position, came in front of everybody else. So let's just have a look at this first and we take it from there. So that's the police officer. All he's doing is he's asking, whoever wants to die first, come in front. So four friends standing, three of them go back. One who's standing right where he was, he's asked, why did you come in front? Do you want to die first? So he said, I didn't come in front, I didn't move ahead. But when he realized, he saw around himself three people who were standing with him, because they moved back, they ended up making him the one in front. So let's understand what this does. Now, when I talk about your implant restoration, your implant has no PDL whatsoever. So let's assume a hypothetical scenario where you have given a crown on a dental implant in 3.6. 3.5 and 3.7 are natural teeth. Let's understand what happens. 3.5 and 3.7 have PDL and they will move about 20 to 25 microns when subjected to occlusal load. Your implant crown, which has no PDL, which is on 3.6, because of no PDL, whenever subjected to occlusal load, it was only move roughly about 3 microns down. So let's understand what this does. Whenever a patient bites, whenever you bite with an implant crown in your patient's or your mouth, the natural teeth go a little further down as compared to your implant crown, making your implant crown rise above the maximum and bear the occlusal load fully. So if I have to show you with the help of this scene, the other three actors standing behind are your natural teeth. They have gone back, whereas this actor in the front, who was standing right where he was, but he didn't move, still he came in front because others went back, is the implant crown. So what I'm going to do is I'm just going to come back and just ask, is this reference clear? Before we go ahead with implant prosthetic occlusion, can you just type and tell me if you've understood this concept? That the implant crown will not move further bit as compared to your other teeth. Upon biting, let's assume that's your implant crown, that's your natural tooth. Upon biting under the same occlusal load, the natural tooth, which is my right hand, the natural tooth is going to go a further bit down, and the implant crown is going to stay right there. So all the occlusal load inevitably will come onto this implant crown. But what did we discuss? We need to protect this. So what we do is, let's assume my left hand, this hand is the implant, and this hand is the right hand is a natural tooth. What we will do is we will very smartly place the implant crown a little out of occlusion as compared to your natural teeth. Now, when I talk about little out of occlusion, I'm not saying it's visible to your naked eye. We are talking about micro mm. Now, I'm not saying it would be 1 centimeter smaller. I'm saying micro mm, which would only be seen with the help of your articulating papers. So what we do is say that that's your natural tooth. This is your implant. What we do is when we are giving the implant crown, we naturally just place it a little below. So whenever the patient bites, the natural tooth moves and comes to the level of this implant, and the load on these two teeth is finally shared. That's concept number one of your implant prosthetics, basically your implant protected occlusion. The concept number one that states give load sharing on the implant crown, which means the load that would be put under the occlusal pressure would be shared with your implant crown as well as your natural tooth by keeping your implant crown a further bit lesser in occlusion, so that when the natural tooth goes a further down because of your PDL movement, it just keeps them on the same level and the occlusal forces are distributed evenly. Is this concept clear to everybody? Is there anybody who didn't understand this reference? I'm more than happy to explain the same once again. So can you just type on the group chat for me to understand that everybody is on the same page? Implant protected occlusion has five principles. I'm just discussing principle number one, which is load sharing. So I see a lot of yes there. So let's hope that everybody's understood this. So let's just go to the feature presentation, and I see you once the entire implant protected occlusion is done for the final bit of Q&A. So that's literally the last segment of our presentation today, where we would be discussing about implant prosthetic occlusion in depth. Let's just take it from there, and we see you shortly. So, like I discussed, whenever you have to give your implant crowns need to be protected because they have no PDL. Now, when they have no PDL, there are five basic things that are to be taken into consideration whenever you're giving an implant protected occlusion. The first being that I need to share the load of my implant crown, something that we just discussed, by keeping the implant crown a little under occlusion so that there is absolutely no amount of load that comes only on the implant crown because of the PDL movement of the adjacent teeth. So that's basically what we just discussed. Point number one. Point number two, we will discuss all these remaining five in depth as well, but let's just understand one by one. Point number two is modification of the occlusal table. Your implant crown cannot be as bulky as your natural tooth. We will discuss this in depth when the slide comes, but for now, let's just understand one thing. The implant crown has to be 30 to 40% smaller than your natural tooth so that the load is less on the crown. The third is increase in the implant surface area, which basically means that I need to do something and get the implant a little more surface area so that more the surface area, the more is the load distribution, and thus I'm able to get lesser off center load on my implant. The fourth is elimination of any unfavorable contacts, which means that I definitely, like other prostheses, I do not want my implant crowns to have any form of high points. Anything that goes wrong with the implant crown because of a high point will only lead to one thing, which is the failure of the implant, because the implant has no PDL whatsoever and thus no shock absorption. The last and the foremost is correction of load directions, which means that I need to make sure that my implant has the load placed in the correct directions. Any off-center load is only going to break my implant further bit more. So we have the five things. We have just given you a teaser of the implant protected occlusion. Let's discuss each one of them in depth now. Point number one, provision of load sharing on your implants. So that's what I mean. Because of lack of any PDL, your implants don't sink under the occlusal loads. They only have roughly about 3 to 4 micron movement as compared to the 25 micron movement with your teeth. And thus, when you are giving an implant crown, it subtly has to be out of occlusion as compared to your natural tooth. Thus, the key here is that when the patient is doing rapid light movements, which is under light contact, something just like this, your implant crown is supposed to have no occlusion marks whatsoever. But under heavy load, which is basically when the patient's been asked to bite and clench, under heavy loads, your occlusal markings on the crown should just barely be visible, that too just with an 8 or a 12 micron articulating paper. If you can achieve this, which means under light occlusion, light tap, 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 no marks whatsoever, under heavy load, there are slight light marks, you have attained load sharing or you have attained the first point of your implant protected occlusion. The second point being modifications in the occlusal table. So there are two implant crowns that are placed in front of your screen. One on your left is a smaller implant crown. On your right is a thick, bulbous, bulky crown. Now, unlike your crown on a natural tooth, your implant crowns cannot be thick, bulbous, or bulky. The reason your implants have no PDL. So the only load that they can take is from the top. The only load that they can take is a compressive load. They cannot take any off-center load because there is no PDL whatsoever. So if they have a small, thin crown, a crown that is roughly 30 to 40% smaller, as compared to a normal tooth crown, a normal bulbous crown, the entire load of the implant crown is going to fall and dissipate along the long axis of your implant. And what that is going to do, it will directly pass the load onto the long axis of your implant crown, go into the bone, and that's all, because there is no PDL. If you give them a bulky crown, what's going to happen is the minute the patient is going to bite on one side, the crown is going to tilt to that side, micro movements. Other side, again, it's going to tilt, and the shake is eventually going to cause the implant to cause bone loss around it and thus eventually fail. So, what you want to do is you want to keep your occlusal table on an implant crown smaller as compared to your normal bulbous tooth. The third is correction of load direction, something we just discussed. That bone is strongest in compressive force, and on an implant, the only force that we can place is a compressive force, something on the left hand side. The first photo that you're seeing, load directly along the long axis of your implant crown. Any off center load, left, right, will just cause micro movements, shakes in the implant, and thus eventually cause your implant to fail. Just imagine one thing. You have put a nail in the wall. If you start wiggling that nail, eventually that nail becomes loose and come out. But if you are just hammering that nail one after the other, all it is doing is it's getting more sturdier into the wall. So any kind of an implant crown that you give, you absolutely cannot have any off-center load, because that would mean you are holding the implant and wiggling it. And the minute you wiggle out anything like that, it tends to loosen itself. The fourth thing that you want to do is increase in the implant surface area. Now, this brings me to this one concept which states that there are different diameters of your implant. We start with 3.6, we go to 4, 4.5, 5. Some companies have 6. The more the diameter of an implant, the better it is to hold inside the bone. Now, understand this. Your implant crown has basically the only possible way to hold inside the bone is when the bone osseointegrates to the implant crown. Now, the more the surface area, the more will be the osseointegration. So 1 mm of width, basically, if you choose an implant that is, say, 5 mm instead of 4 mm, provided you have that much space, you are increasing roughly about 30% of the surface area of the implant. Now, when 30% more implant is available for the bone to hold on to, the more the merrier. The bone will be a lot better. The implant would be able to osseointegrate a lot more and thus be able to take occlusal loads a lot better. But that does not mean that you use an 8 mm or a 7 mm implant. It is not recommended to use an implant wider than 6 mm in diameter. Some other day we will discuss why that is there. But to start with, because I understand a lot of us are freshers here, use as much of a diameter that you can use, provided you are well within the safe zone of 6 millimeter diameter of an implant selection. The last and the foremost thing is elimination of unfavorable contacts. Now, understand one concept. Now, that's an implant crown. I want you to just focus on the X-ray. So there are two implant crowns placed. One implant crown is, like we discussed, a small implant crown, 30% smaller as compared to the adjacent tooth. Now, can you see? Even though both these implants are placed at an angle, they are tilted, they both do not have the perfect compressive occlusal load. Still, there is so much bone loss that's happening in the implant that is here, but absolutely no bone loss in the first implant. The reason, a smaller crown lets the entire occlusal load dissipate along the long axis of the implant. A wider bulbous crown gives you nothing but a cantilever on the implant. Now, any occlusal load that's come to the distal end of this crown has only tilted the implant. And when it's tilting the implant, it's wiggling the implant, micro movements are happening every day, eventually causing bone loss and so on, so forth. The implant's going to fail. So if I have to just quickly discuss about implant protected occlusion in 5 brief parts, number one would be you want to make sure that the load is shared. Remember this concept. Absolutely no occlusal markings on light contact, but some occlusal markings on heavy contact. Very, very mild. Second, you want to give smaller crowns to the implant, as you can see in the image in front of you. You don't want to give them huge bulbous implant crowns because you have an X-ray that shows the failure when you're giving a bulbous crown. 3, you want to place all load along the long axis, nothing that is a cantilever, again showing in the image in front of you. Fourth, you want to make sure that your implants are as wide in diameter, well within the 6 mm gap of the safe zone. The reason, more the implant diameter, more will be the surface area, more will be the bone that can hold onto the implant, and so on and so forth, would be the osseointegration. The last thing, you want to make sure that your implant crowns are checked with the perfect articulating paper. I request everybody, please understand 8 to 12 micron articulating paper for your implants, 40 microns to be used for anything with a natural tooth. Your crowns, bridges, veneers, your inlays, onlays, class 1 fillings, class 2 fillings, 40 microns, because your teeth move that much. Whereas in the case of an implant, that's just about it. So that's all I have from my end. We have just discussed about the implant components. We have discussed about the stage two components. We have discussed about your different areas that are to be taken care when you have to use an implant protected occlusion. My name is Dr. Divij Kular. I will be coming back for question answers. The class does not end there. My name is Dr. Divij Kular. That's my Instagram profile on the left of your screen. That's my personal number there. In case you have any questions, even after the lecture, you're more than happy to drop in a message and I will be there to help you with that. The Instagram profile that is there has these tips and tricks on prosthodontics frequently coming up. Every now and then I keep posting live clinical tips for you to understand and make your prosthodontics easier, not just for implants, but veneers, complete dentures, full mouths, everything and anything possible. So anyone wants to reach out to me, the best possible way is to message me on Instagram. The next possible would be to message on that number there. We would be more than helpful to see you and help you with whatever doubts that are there. So before I bid farewell to this class, I would like to just come back and discuss questions, if any. So now we have a couple of minutes open for question answer session. Any questions that you have regarding and related to implant prosthetics, something that we've just discussed, please feel free to join in the group discussion. Either you can message on the group or you can directly unmute yourself and ask. Yes, so any questions that are there?
Good morning, sir.
Yes, please ask.
Sir, I had a doubt. Like,
Yes, ma'am.
whenever we give a joint implant crown, like implant prosthesis, and
Okay,
it is of one system comprising of two connections. Like
okay.
one system, example, Eden, and
Mm-hmm.
it has a close fit connection and an internal hex connection. And we have given a joint crown. Like
Okay.
they have a different impression coping, and we are doing open tray impression only. But
Mm-hmm.
till the impression stage, we are finding that everything is okay. We have given the correct analogs also. But when we are on the jig trial step, we find that most of the cases, close fit is having a perfect jig. But
Close
there are
fit as
some
in?
kind perfect jig. Like there is no error in the jig trial of the close fit.
You mean to
But
say close tray impression?
no, sir, close fit implants of Eden.
Okay. Okay.
And the normal implant of Eden, that is the
Hmm.
what we do in a internal hex connection Eden, we find some error. Like, is there error in the impression part or is there error in the analog part?
See, a close fit abutment is nothing. It's just a very precise and very snugly fit of the implant abutment. Am I correct? That's what you mean.
Yes, sir. Yes, sir. Yes, sir.
So that has absolutely no role to play with the impression or the accuracy of the impression. What I feel is that the other thing that could possibly go wrong is when you're using the normal abutments, you're probably not screwing them well, number one, or the fit is not proper. So after every time that you place an impression coping, are you taking an X-ray?
Yes, sir. Yes, sir. After the impression
Perfect.
copings are placed, we take the X-rays, and the X-rays are okay. And sir, it mostly happens when we are rehabilitating six, seven together.
Okay, so
Like,
here I ask once again. So are you doing a jig trial?
yes, sir, we are doing the jig trial.
So you're doing a jig trial as well. Jig trial is fine.
Yes, sir. And mostly it happens in cases with a poor, like oral hygiene is not that perfect, like not fair. It is not good oral hygiene, it is fair. Like,
So
I've
if
seen,
I can, Doc, just ask this question once again.
yes,
Your
sir.
jig trial is perfect. So where is the fit that is going wrong in the final crowns?
No, sir. In the jig trial crown of the internal hex connection.
Basically, a jig trial is not accurate. That's what you're saying,
Yes,
right?
sir. Yes, sir. Yes, sir.
The reason
So,
is, ma'am,
sir,
yes.
yes, sir. So one doubt I had. So
Hmm.
is it necessary that we give individual crowns for both the implants, not a joint crown?
See, it has nothing to do with being an individual crown or a joint crown. The jig trial not being fine only states one thing, that the impression was not accurate. Or when they were pouring it in the lab, there was some discrepancy there. That's the only thing that goes wrong. In a two implant case, that should really not happen. It can happen, say, in six implants, seven implants, when, like you said, there are multiple implants being placed. Sometimes that can go wrong. But in a two implant case, you actually don't need to worry so much about it. It's probably just the way you're taking an impression.
Okay, sir. Okay, sir. Like, sir, I
So,
had a doubt because two implants are there and both are having a different type of impression coping. Is there any
mhm.
problem with the hex copings or non-hex copings
No,
or
nothing like that.
something?
But yes, yes, yes. See, now your question's a lot more clear. If you are giving two crowns and you are splinting these crowns, you need to make sure that either you're using hex copings on both of them
Non. Yes, sir.
or non-hex copings on both of them.
Yes, sir.
I got a little confused in your question. See, the question now I understand. You're saying that you're using hex on one, non-hex on the other.
Non-hex,
That's a
sir.
problem.
Yes, sir. Yes, sir.
So either, ma'am, when you are splinting multiple crowns, the best possible thing is you give non-hex copings to the lab.
Okay, sir.
What this does is whenever you're splinting multiple crowns, the way the crown is sitting inside the patient's mouth would exactly be
Okay.
the same as on the cast, only if the hex is not present. Otherwise,
Yes.
on the cast, everything will sit, but in the patient's mouth, it might not sit even if there
Yes.
is a discrepancy of 1 mm. So the answer is just use non-hex copings. You should be fine with it.
Okay, sir. Thank you.
Most welcome. Any other questions?
If any of the participant have any question, please feel free to ask.
So we've discussed about the
Sir,
various
I
components.
wanted to
Yes.
ask that, like, good morning, sir.
Good morning. Good morning, doctor.
Yes, sir. I actually wanted to ask about the implant angulation. Like, is it more critical in the anterior part or in the like posterior part?
See, implant angulation is critical in both anterior and posterior. I'll be honest with you. Your implant should never be at an angle that will cause any off-center force. Now, understand one thing. If that's your implant, the load should exactly be like this. If you have an angulated implant and you're putting occlusal load, it already is getting a connection here, and that also one here. So try keeping your implants as parallel both in anterior and posterior. I understand sometimes it's not possible. So in such cases, use a multi-unit abutment to get the parallelism back. The key to success of an implant restoration is to make sure that the parallelism of your implant restoration or the parallelism of your implants is maintained as much as possible.
Yes, sir.
Most welcome. Any other questions? So, Dr. Smriti, I have a question from you on the chat box which says, how can we decide the angulation of the abutments? The simple way. Once your lab has the cast code, you remember the depth gauge that they checked? All they do is they have this depth gauge similar in different angulations as well to check what the angle of your abutment is required to be. Like they gave you the gingival height with the same depth gauge in the lab, they will be able to get an idea of the angle of your implant placement. And any abutment that you open tomorrow, just check. It has something written as GH, which is gingival height, and then it has an A, which says the angle. There are 5 degree, 10 degree, 15 degree, so on and so forth for different companies. But the only way you can check for the angulation of the abutments required is with the help of this depth gauge that the lab has. Any other questions?
Other participants, if you're not feeling comfortable in speaking, you can also text in the chat box. We can answer them it from there. Sir, we have a question like what all are the systemic disease or complications which we need to figure it out while doing a FMR?
See, there's nothing like systemic disease for an FMR. The systemic diseases that you need to take care remain the same for a single implant and full mouth implant as well. So understand it like that. An FMR that is there is just a combination of multiple crowns. The problem is we think it's too much of in-depth required, but consider an FMR just as multiple implants being placed.
Mm-hmm.
Now, understand one thing, any systemic disease that is contraindicated or any contraindications for an implant is simple. Number one, any patient that has had a history of any chemotherapy or radiotherapy done, which means you may have sometimes a patient who says that, Doc, I was treated with for cancer a couple of months ago, I'm still under radiotherapy, or I
Mm-hmm.
have finished my radiotherapy. You need to wait for at least a year and a half post the last dose of your radiotherapy or chemotherapy for you to do anything to the bone. So, first and foremost, would be number one, you need to make sure that there is no history of any therapy in the form of radiation or chemo done. The second, uncontrolled diabetes. Now, when I talk about uncontrolled diabetes, diabetes is something that prevents your wound healing from
Mm-hmm.
immunocompromised. When I talk about immunocompromise, it basically means we need to get make sure that the patient has absolutely no bleeding disorders, no hemophilia that is there. Just simple, easy terms. The patient needs to be completely healthy in terms of wound healing for you to get an implant placed. There are other contraindications as well, small ones that are there that the patient should not have osteoarthritis. Osteoarthritis basically prevents your bone from remodeling. So when you place an implant, you need to get the bone remodeled. So that's about it. The
Mm-hmm.
last thing would be excessive smoking. Now, if a patient excessively smokes, that again is a contraindication. So smoking also, what does it do? It makes sure that the healing of your wound is not there, the bone's not properly healed, and that causes problems as well. So if I have to just list them down, number one would be chemo or radio. Number two would be uncontrolled diabetes. Any systemic conditions like bleeding disorders or osteoarthritis or areas where the wound healing is compromised. And last most, uncontrolled smoking habits. That's pretty much it.
Okay. Any of the participants? I think so. We are done here.
So it was wonderful interacting with all of you in the morning. I hope that Sunday morning, 9 o'clock, waking up to listen to something as boring as prosthetics. I hope it was worth your time. Any other questions that you have, even after the presentation's done, you please feel free to get in touch with me on my Instagram. I would be more than happy to answer these questions. And if everybody is okay with it, we can probably end the session. Dr. Shubham?
Yeah, sure.
Perfect. Thank you so much. Have a good day, guys.
Thank you, sir.
Most welcome.
I request everyone to please stay back. We're gonna start with our second lecture. There is a technical glitch with the speaker's network. We're gonna start it in 5 to 10 minutes. सर आप माइक अनम्यूट कर लीजिए सर, माइक म्यूट है।
Hello.
Yes sir, good morning, can we
Good
start?
morning. Good. No, let me share the PPT first.
Sir, yeah, sure. Parnika, you can just start.
Good
Yes.
morning, everyone. We are delighted to begin with our second lecture of day 2 on the topic Management of Implant Complications by Professor Dr. Amit Bhardwaj. Dr. Amit Bhardwaj holds BDS, MDS, and PhD degrees and is a fellow of International College of Dentists and Orchard Academy. He is currently serving as the director of PhD programs and professor in the Department of Periodontology at the Faculty of Dental Sciences, SGT University, Gurugram. With his vast academic experiences and clinical expertise, he has made significant contributions to the field of periodontology and implant dentistry. It is truly an honor to have you with us today. Sir, we extend a warm welcome and look forward to an insightful and enriching session.
Hello.
Yes sir, you are audible.
But I think my screen is visible, Doctor.
No sir, only your video is visible.
So, share. Just wait.
Yeah, sure sir.
No, so I have to go to so then I have to click share. Allow share window. Allow share screen.
Sir,
Allow
allow
share.
share screen. Yes sir.
But then it's showing this meeting is being recorded. No,
Yes sir, it's being recorded.
that is okay. But how screen will come? My PPT is on.
Sir, you can just shift that window to window option. You can try that one.
Okay. Wait. Okay. Window option. Okay. That is the problem. Can I email you? Is it possible?
Yeah, sure. You can email or WhatsApp me. I can play it.
Okay.
I'll just text you the email address. Just a second.
करने के पहले वो करना चाहिए everything got stopped here.
Sir, you can share the PPT with me. I'll play it, not an issue.
Yeah, wait. I have sent.
Okay, sir. Just sir, give me 2 minutes.
Have you received it?
Yes, sir. I have received it.
Yeah, please, please, please. Thank you.
Sir, is it visible?
Yes, yes, it's visible. Yeah. Shall we start?
Yes, sir.
Yeah. So good morning, everyone. First of all, I thank Team Cynodent with Pere Foucault Academy for giving me opportunity to present my this lecture on Osseointegration Mastery Conference. I thank Team Cynodent, Dr. Anmol, Dr. Ashish, Dr. Shubham for having me here. So I welcome all the delegates, all the participants who are available with me this morning. I am here to discuss the topic which is known as complication of implants, management of implant. That is very important nowadays because we are placing implants day in, day out, but we are not taking care of follow-ups. We are not taking care of preventive protocols. We are not taking care of what patient will feel if his expectation doesn't meet his our delivery. We have given good implant, we have given good processes, we have given everything very cautiously. But later, after 5 years, after 10 years, or say after 2 years also, if he feels that he is not getting that much satisfactory result from our treatment, then it will be our liability, because as a dentist, we must take care of these things. So when it comes to management of implant complication, there are four major aspects. Four major aspect means whenever disease progress, it progresses from soft tissue. So once it is in soft tissue, it is known as peri-implant mucositis. As we have gingivitis in natural tooth, we have peri-implant mucositis in implant related tooth. Terminology is different, but I will say that features are more or less same, clinical features. So second, once it goes to bone, then as in natural, it is periodontitis. In this, it is peri-implantitis. But what will happen next? Ultimately, tooth will lose, implant will lose. We will see implant failure. Then we have to apply management strategies. Management strategy means either stage wise or in the last, but preferably in my presentation, you will see that I have taken care of management strategy as and when required. So we will not wait till patient will say कि now mobile tooth is mobile, kindly take care. It is our duty to take care in very first step, that is peri-implant mucositis. So today's lecture comprises of a clinical overview of peri-implant mucositis, peri-implantitis, implant failure with evidence-based strategies for diagnosis. As a dentist, we must diagnose it at early stage. Before patient will come, we should see the clinical situation and tell him that kindly take care it properly. There are chances that you will have problem in this tooth because of lack of maintenance. Then if there is already a loss, then intervention. What all we can do at right step. Then long-term preventive. As I said, we need to take care of long-term prevention, like 10 years, 10, 15 years. So today's lecture is designed like this. The next slide. What is peri-implant mucositis? Only three words. Peri means around, implant, and mucositis means when there is inflammation of soft tissue. Peri-implant mucositis is defined as, mind my words, reversible inflammatory condition. As gingivitis is reversible, peri-implant mucositis is also reversible. Confined to soft tissues surrounding a functioning implant with no evidence of supporting bone loss. This is very important point. There is no evidence of bone loss. It is widely recognized as precursor of peri-implantitis and is analogous to gingivitis around natural tooth. As I have already explained, जैसे natural tooth में gingivitis होता है, इसमें mucositis. Now, early identification and intervention are critical to prevent these diseases. Reversible inflammation. So don't get disheartened. Agar patient comes with bleeding around the tooth, around the implant, don't get disheartened. This is reversible inflammation. The inflammatory response is limited to peri-implant mucosa and is fully reversible with appropriate plaque control and professional intervention. Soft tissue involvement only. By definition, mucositis does not extend to supporting crestal bone. Radiographic bone loss remains stable compared to baseline. जैसे आपने implant डाला था, you must have taken radiographs. So you will find again, if you take radiograph, the level of crestal bone will be same as that of earlier. Distinguish mucositis and implantitis. Basically, there is a bone loss. If you feel there is. Now, this is a picture. Next picture, please. Yeah, you can see patient will come up like this. There may be inflammation. There may be bleeding on probing. There may be pus discharge, purulent discharge. Any of single feature can also be present, or all three may be present. Don't get confused. If there is slight redness over the margin where the crown and the implant meets, then there are chances that patient is having mucositis. If there is bleeding on probing, then definitely there is mucositis. The more dangerous thing is when there is pus discharge also, purulent. So How to diagnose? As I mentioned, always use defined instruments as by companies, prescribed companies. Don't use your metallic probe to do this. Use a plastic probe. Good companies like Hufredi, so many companies are presenting, selling their products. Kindly take good probe so that it will not scratch the implant surface. As mentioned in this picture, there is only plastic probe which is advisable too. But nowadays, companies are coming up with titanium probes also. So you can invest in that also. That will be of for long run. Plastic probe you need to change. So there is a probe known as Implacare. It comes with two tips. You can use and throw the tips. It is known as Implacare. You can use the probe. Next slide, please. Now, what will be the clinical features? The clinical presentation of peri-implant mucositis is often subtle but consistent. Clinicians systematically around all implant at every maintenance visit to detect early sign of inflammation. The main point is, suppose you have placed 5, 6, 7 implants in same patient, and patient is just complaining of problem with adjacent to single tooth. Make it a habit that when you are examining the diseased tooth implant, kindly make a habit to examine others implant also, where you have placed your dental implants. So what you will see erythema, which is redness. The peri-implant mucosa appears visibly red and may have glazed or edematous texture, indicating active vascular inflammation in the sulcular tissue. Then edema, there will be swelling. Soft tissue swelling around implant collar is hallmark sign. The tissue may appear puffy and rolled out, reflecting fluid accumulation within the inflamed mucosa. As I mentioned, there must be some discharge. Bleeding on probing. Once you press gentle pressure in mostly reliable reproducible indicator. Because if you are placing and other dentist is placing, so definitely it will give the same readings. A positive bleeding on probing scores support of diagnosis of mucositis. So these three signs must be present if patient is coming with mucositis. Next slide, please. Now, what will be the management? The primary goal in treating peri-implant mucositis is biofilm disruption. As in natural tooth, we have plaque biofilm formation. It is similar that in implant also we have biofilm formation. So disruption of that biofilm and restoration of mucosal health is primary focus. Treatment is non-surgical. Non-surgical means you will not give any incision, you will not reflect any flap, you will not place any bone graft, membrane, any other thing. It will be purely non-surgical and highly effective when initiated promptly. Means you need to judge the situation at initial stage. Then only you can give good results to your patient. Resolution of signs of inflammation is achievable in most patients within 4 to 8 weeks of consistent intervention. There are few things which you as a dentist will do, and there are few things which patient will do at his home. So oral hygiene optimization, reinforce and demonstrate effective plaque removal technique, including interdental brushes. Very important because there is a food lodgement between the crown and the implant. So kindly make your patient aware that अगर food वहाँ पे regularly lodge होता है, make it a habit to use interdental brush. Flossing can be a good tool. The best is irrigators. Water irrigation devices are very commonly available. You can buy it from any good portal or from Colgate or from Philips or any company. And oral irrigation devices are very important in these type of conditions. Then professional debridement. Obviously, it has no match. Professional debridement has no match with any other care. Supramucosal and sulcular debridement using titanium curettes, ultrasonic tips, and air polishing devices removes biofilm without damaging implant surface. सबसे ज्यादा केयर करने की बात ये होती है, you need to protect your surface of implant, means threads of implant. So kindly make sure जब आप क्लीन कर रहे हैं तो उसको बहुत अच्छे से करना है आपको. Then what patient will do? Patient will do क्लोरेक्सिडिन माउथ वॉश. द बेस्ट इज क्लोरेक्सिडिन. कोई भी कंसंट्रेशन एडवाइस कर सकते हैं. 0.2% भी अवेलेबल है, 0.12% भी अवेलेबल है. Daily for minimum 2 weeks or maximum 4 weeks. By the time patient will report to you back. So it will help in the improvement of condition. Next slide, please. Now coming to peri-implantitis. This is the second stage. This is very challenging stage because now there is involvement of underlying bone. Peri-implantitis is a plaque-associated pathologic condition characterized by inflammation of peri-implant mucosa and progressive loss of supporting bone beyond biological bone remodeling threshold. It means now there are chances that you need to intervene surgically because it will not form on its own. जो bone loss हो चुका है, that will not regain on its own. So you need to intervene bone remodeling. Like mucositis, the process is not self-limiting and will advance without active clinical management. अगर इसका मतलब ये है म्यूकोसाइटिस अगर आप अच्छे से मेंटेन करें, क्लीन करें, there are chances it will stop on its own. But once there is peri-implantitis, bone starts resorbing. It will not stop. Believe me, it will not stop. It will be a continuous process until unless professional need is taken care properly. It represents one of the most challenging long-term complications. As I mentioned, peri-implantitis is really a challenging condition for dentist also and for patient also. So what is the epidemiology? Earlier, we used to commit to patient that once implant is placed, nothing will happen for next 10 years, 15 years. My dear fellow colleagues, don't ever commit these kind of big statements to patient. Always take him in confidence that, sir, ma'am, I am doing best out of my knowledge, but your cooperation is highly required because if he or she is not maintaining, so definitely implant will suffer. And the problem with implant is, my opinion is, when patient is not properly maintaining the natural tooth, that's why he lost natural tooth and we have placed implant. So it is very challenging for him or her also to maintain implant. So kindly reinforce, उनको बोलिए सर अगर आपके नेचुरल टूथ कम एज में निकले हैं तो ये भी ससेप्टेबल हैं निकलने के लिए. So don't give false promise कि अब मैंने लगा दिया अब कुछ नहीं होगा. जब नेचुरल टूथ निकला है इसका मतलब there is either genetic problem, either conditional problem or patient's behavior. So kindly remold time to time कि सर ऐसा कीजिए, मैडम ऐसा कीजिए, मेंटेन कीजिए, मुझे बार बार दिखाइए. So that is the key important. Now let's have a look on the statistics. Prevalence estimate vary widely, but systematic reviews suggest peri-implantitis affects approximately 22% of implants and up to 43% of implant patient over 5 to 10 years. तो जो हम commit करते हैं 10 years, 15 years, statistics से, evidence से that 5 से 10 साल में ही नुकसान होना शुरू हो जाता है. So kindly make it a habit to explain patient. Risk factors include poor oral hygiene, obviously history of periodontitis. Earlier I also mentioned जिस patient को पहले से ही इतने natural tooth loss है, वो implant को कैसे maintain करेगा? So kindly take care. Diabetes, any other systemic disease in female patients, sometimes they are on some medications which affects bone quality. So kindly take care of all those things. Smoking and residual cements. Residual cement we will talk once we talk about prosthesis challenges. Now, key distinguishing features from peri-implantitis and mucositis is inflammation extends into supporting bone, progressive and non-reversible. As that was reversible, this is not reversible. Pocket 6 millimeter with bleeding on probing, radiographic evidence of alveolar bone loss or crestal bone loss. ये सब कुछ present मिलेगा जब आप patient को examine करेंगे. Next slide, please. ठीक है. Peri-implantitis represent with characteristic cluster of signs that distinguish it from mucositis. Diagnosis requires a combination of clinical probing, visual assessment and radiographic evaluation. रेडियोग्राफ से पता चलेगा, आंख से देख के पता चलेगा और प्लास्टिक प्रोब से पता चलेगा. पता क्या चलेगा? एक तो ब्लीडिंग जरूर होगी, प्रोफ्यूज ब्लीडिंग. often accompanied by suppuration, pus discharge हो सकता है. Probing typically 5 to 6 millimeter around the affected implant, but make it a habit to probe other implants also. But main challenge is don't transfer your infection from one implant to other implant. Kindly sterilize your instrument or keep two sets, one for already diseased implant and one for healthy implants which you have placed and patient is not having problem, and you will also not finding any visual assessment problem. So एक प्रोब को दूसरी प्रोब साइट में मत डालिए सो डेट ऐसा ना हो इधर का इन्फेक्शन आप खुद ही दूसरे इम्प्लांट में ट्रांसफर कर दें. रेडियोग्राफिक बोन लॉस, प्रोग्रेसिव क्रेस्टल बोन लॉस विजिबल ऑन पेरियपाइकल रेडियोग्राफ. नो नीड टू टेक हाई-फाई सीबीसीटी. सिंपल आईओपीए लीजिए आरवीजी से अपने क्लिनिक में एंड यू विल सी दैट देयर इज अ क्रेस्टल बोन लॉस. Suppuration already mentioned will be, and pockets 6 मिलीमीटर की पॉकेट हो सकती है, उससे ज्यादा है तो इम्प्लांट विल गो टू फेल्योर, फिर उसको सेव करना बहुत मुश्किल है. बट अगर 6 मिलीमीटर एंड लेस है देन देयर आर ट्रीटमेंट मोडालिटीज, because usually implant we place of 10 say 11, not more than that in endosseous implant category. 13 is very rare, but 8.5 to 10.5 or say 11 12 millimeter is the highest. and अगर 6 मिलीमीटर से ज्यादा बोन लॉस है so फिर कितना बचेगा उसमें. so 6 millimeter is ideal situation to intervene. Next slide please. You can see कुछ इस तरह की कंडीशन दिखेगी. suppuration, bleeding, bone loss. You can see the comparison of initially placed implant bone radiograph and the implant with infection. If you can see distal implant has infection, bone loss, whereas mesial implant has no problem. Bone level is more or less same as that of the stage of placement. तो अब इस कंडीशन में if we place same probe in the distal implant and transfer the same bacterial load to anterior implant, उसमें भी आगे चल के नुकसान होगा. So as I mentioned, kindly don't use same instrument for probing. Next slide please. अब there is a lot many procedures which you can do to manage the peri-implantitis. Peri-implantitis management is staged according to disease severity. मतलब you need to check carefully कितना नुकसान हो चुका है बोन का, टिश्यू का, whether you need to do soft tissue grafting, whether you need to do alveolar graft, bone grafting, whether you need to do GTR membrane placement. ये सब clinicians wisdom पे rely करता है. The primary objective is decontamination of implant surface, resolution of inflammation, and arrest of bone loss. No single treatment modalities has demonstrated universal superiority, and a stepwise approach is required. तो एज आई मेंशन जिंजिवाइटिस में भी हम सबसे पहले क्या करते हैं, नॉन सर्जिकल करते हैं. तो म्यूकोसाइटिस में भी हम नॉन सर्जिकल करेंगे. उसके बाद हम एंटीबायोटिक थेरेपी देंगे, पूरा सिस्टेमिक थेरेपी देंगे. अगर वो भी सक्सेसफुल नहीं होगा तब सर्जिकल केयर पे जाएंगे. अब सर्जिकल केयर दो तरह की हो सकती है, रिसेक्टिव भी हो सकती है, रीजनरेटिव भी हो सकती है. मतलब हमें वी कैन चेंज द बोन anatomy, morphology around the tooth implant, or we can place the bone graft also. So kindly make sure whether you want to go for resective osseous surgeries or you wish to go for regenerative. But as per my experience, 99% regenerative is more useful. So surgical access is indicated when non-surgical therapy fails to achieve probing depth reduction and cessation of bleeding on probing, obviously. Resective surgery is performed for predominantly horizontal bone loss. Regenerative procedures like bone grafts membrane are considered for intrabony. Or as far as my experience goes, mostly defects are intrabony. So regeneration is the treatment of choice. Next slide, please. When non-surgical therapy is insufficient, surgical access allows direct visualization and thorough debridement. अब उसमें you need to reflect the flap. You need to reflect the implant site again. और तब आपको क्लियरली दिखेगा कि कितने थ्रेड्स एक्सपोज्ड हैं, कितना नीचे बोन है, कितना बोन आपको ऑगमेंट करना है या रीजनरेट करना है. For resective osseous surgery, apically reposition flap with or without osteotomy or osteoplasty, indicated for horizontal bone loss and suprabony defect, reduces pocket depth, improve access to oral hygiene. Regenerative कब करेंगे? Regenerative करेंगे bone grafting, autogenous allograft, xenograft, DFDBA, any graft of your choice, your experience, combined with GTR membranes. GTR membranes will allow good bone regeneration over a period of time. So kindly make a habit to place GTR membranes whenever required. Implant surface decontamination. Obviously, there are various local drug delivery agents. लोकल ड्रग डिलीवरी एजेंट्स जो हम यूज कर सकते हैं, ईडीटीए, सिट्रिक एसिड और लेजर. Laser is very good treatment of choice nowadays. Laser, photodynamic therapy, you can place one dye and then activate the dye with the laser tip and it will decontaminate the tissue. तो ऐसा हम कर सकते हैं. That is a good choice. Next, please. अब the most challenging part and most, I can say, matlab, most negative part for dentists to say to patient that your implant is failed. We need to either replace it or we need to have a wait and watch policy. So let's see to it. Implant failure is defined as loss of osseointegration. Means as 6 millimeter wala jo formula tha, that is will go more deeper to a degree that necessitate removal of implant. That is a challenging situation. And believe me, agar implant is, the problem is if it loses its osseointegration from all four sides, then it is easy to retrieve. If suppose you are facing problem in retrieval, it means there is osseointegration maybe on lingual side, maybe on buccal side, maybe on mesial side, maybe on distal side, but two or three sides are have lost their bone. So उसको retrieve करना और challenging हो जाता है dentist के लिए, क्योंकि again you need to put good pressure और good force और good torque to remove the implant. तो बड़ा उसमें challenging होता है पेश dentist के लिए कि यार अगर थोड़ा सा ध्यान देते तो ये बच जाता दांत. तो now coming to next. Understanding the distinguish between early and late failures is essential for identifying etiology and guiding management. अब अर्ली फेल्योर और लेट फेल्योर का मतलब क्या होता है? इसका मतलब ये होता है, अर्ली फेल्योर मींस जैसे ही इम्प्लांट प्लेस किया था तभी क्लिनिशियन कैन जज कि देयर इज समथिंग रॉन्ग विद द बोन लेवल्स. So it occurs before or during osseointegration, typically within first 3 to 4 months. जब पेशेंट का osseointegration हो जाता है और आप उसको क्राउन प्लेसमेंट के लिए बुलाते हैं, some dentists can feel यार ये this will not prolonged. उनको पता चल जाता है कि ये ठीक नहीं हुआ है, इसमें कुछ ना कुछ बोन लॉस हो रहा है और अभी हो रहा है तो 6-7 साल में 5 साल में तो पक्का ये निकल ही जाएगा. एक तो वो स्टेज है. Then something is associated with surgeries also. Sometimes what we do, we don't take proper saline irrigation, proper speed, proper torque, proper angulation. और sometimes क्या होता है, हमारी ड्रिल्स अच्छी नहीं होती, ड्रिल्स वियर हो चुकी होती हैं. So उससे क्या होता है, लोकल बोन ओवरहीटिंग ऑफ द बोन होता है, वो डे 1 से ही प्रॉब्लमेटिक हो जाता है. और वहां पे कई बार क्या होता है, नियर बाय टूथ में इन्फेक्शन होता है एंड टू जस्ट सेव द टाइम वी प्लेस इम्प्लांट, तो वो इन्फेक्शन उस टूथ से एंडोडोंटिकली ट्रीटेड से या समथिंग और इन्फेक्शन से पेरिडोंटली कॉम्प्रोमाइज से वो ट्रेवल करके हमारी इम्प्लांट साइट पे भी आ जाता है. अब hello, am I audible?
Yes, sir, you are audible.
अच्छा सॉरी, आई थिंक वो क्लिक हो गया उस पे। सो व्हाट आई वाज टेलिंग इज अर्ली फेल्योर एंड लेट फेल्योर। अर्ली फेल्योर में क्या होता है? अर्ली फेल्योर इज अ स्टेज व्हेन डेंटिस्ट विल कम टू नो on the stage of crown placement that patient is having bone loss. मतलब once patient come for after 3 months or 4 months and he can vouch for it के bone loss होना शुरू हो गया है, इसका मतलब implant will not stay for long. So the most common reason is faulty placement of implant. Faulty placement of implant means either the bone was compromised, proper height was not there, proper width was not there, implant size was not taken carefully. सब कुछ ठीक था, if everything was fine, there was no proper setting of implant motor. या तो टॉर्क ज्यादा था, वाटर का सप्लाई लेस था, और द मोस्ट चैलेंजिंग पार्ट इज आपकी जो इम्प्लांट किट है उसके कंपोनेंट्स वियर ऑफ थे. If you have placed 1,000 implant from same drill, then you will place, so definitely it will wear the bone. वो बोन को तो खराब करेगा. तो ओवरहीटिंग इज द मेन कॉज ऑफ implant failure while after placing of implant. And site selection, you need to select site properly and accordingly dental implant site. Width उसकी कितनी लगेगी implant की, diameter and length of the implant should be taken care properly. Then late failures तब होते हैं when there is occlusal overloads, overhangings, margins are not proper, patient is having faulty parafunctional habits. Faulty parafunctional habit means patient will not take care of hard food chewing from that particular side. Obviously, as a dentist, you need to explain him, okay, sir, this is not natural tooth, and don't ever try strong eating, heavy biting from this side. But patient will definitely eat and then come to you that, sir, ये कुछ problem हो गया. So kindly avoid all these things. Systemic disease. Sometimes patient is all right while placing the implant. Later he develops some systemic disease. So it will also show its effect on implant also. तो patient को बता दीजिए कि अगर आपके blood parameter, sugar, diabetes, hypertension अगर in future भी अकर होता है, kindly visit to you so that you can intervene with the help of his physician. फिर bone loss तो आपको एक्सरे में दिख ही जाएगा. That is again a good sign कि भाई if you are able to judge the situation on the right time, you will give the good treatment to your patient. Next slide, please. Now, what will be the situations which patient will come up? Failed implant present with constellation of signs that may develop gradually or appear acutely. Clinicians must differentiate true osteogenic failure from other complications such as prosthetic component fracture or peri-implant pathology that may still be treatable. Sometimes patients will come to you or calls you कि sir दांत हिल रहा है. Don't get panic. Call him and you will see that there is only mobility in the crown part. Implant is fixed very nicely. So as mentioned in the above paragraph, prosthetically भी कई बार challenges आ जाते हैं. If you have given screw retain, if you have given cement retain, तो implant crown हाथ में भी आ सकता है. Abutment रहेगा, crown patient will come, sir मेरा तो crown बाहर आ गया दांत में. तो what you will think on phone that implant बाहर आ गया. But once patient will visit to you, you will see only crown part is there. So उसको आप re-lute कर सकते हैं या re-impression लेके नया crown दे सकते हैं. Same is with the स्क्रू, अबटमेंट स्क्रू. कई बार क्या होता है, अबटमेंट स्क्रू लूज हो जाता है. यू कैन टाइट इट प्रॉपरली. और चैलेंजिंग सिचुएशन तब आती है अगर अबटमेंट स्क्रू फ्रैक्चर हो जाए. दैट इज द मोस्ट चैलेंजिंग सिचुएशन टू रिट्रीव द remaining part of the screw within the well of the implant. So let's see. Mobility. Any clinical detectable implant mobility, even minimal, is pathognomic of osseointegration failure. Use a torque wrench or 2 instrument handles to assess. जैसे as I mentioned, kindly assess कि implant is moving or only the prosthetic or abutment part is moving. Mobility is an absolute indication of implant removal. Pain on percussion. As you do in natural tooth, kindly try to tap your implant with the probe or any instrument from back end. Persistent pain during chewing. Sometime patient will come to you and he or she will say कि ये जो implant लगा था इसके बक्कल साइड पे और लिंगो साइड पे मुझे पेन रहता है. So there are chances that there is either fenestration or dehiscence, means there is a loss of alveolar bone from that particular surface of the implant. When patient is having a soft tissue directly in contact with the screw part of the implant, he or she will face pain. तो ये एक चेक कर लीजिए, अगर पेशेंट आपको कह रहा है कि मुझे उंगली से दबाने पे या खाना खाने पे पेन है, तो देयर आर चांसेस दैट देयर इज एक्सपोजर ऑफ threads as dehiscence or as fenestration or complete also. So persistent pain during chewing and upon lateral or vertical pressure, it indicates incomplete osseointegration, peri-implant infection और nerve impingement. Sometime कई बार क्या होता है, कोई nerve भी implant के pressure से pain कर रही होती है. So kindly check the condition thoroughly and do the good to your patient. Radiographic evidence, progressive periapical radiolucency, circumferential bone loss or visible implant threads exposure on radiographs are indicator of failing or failed osseointegration. So standard periapical radiograph is a gold standard. No need to every time go for CBCT. Next slide, please. Now, what will be the management of implant failure? Once implant failure is confirmed, kindly don't panic and don't panic your patient also कि अब पता नहीं क्या होगा, कुछ नहीं होगा. Either you will be able to manage the condition or maximum you have to build the site again and place the new implant at that site. Hardly matters, but it will be just a time consuming process. There is no need to panic absolutely. हम क्या करेंगे, या तो वही मेंटेन करेंगे या उसको निकाल के नया इम्प्लांट लगाएंगे, इससे ज्यादा कुछ नहीं है. बट मैक्सिमम 6 महीने लग जाएंगे, 8 महीने लग जाएंगे, इससे ज्यादा कुछ नहीं है. तो डोंट गेट पैनिक योरसेल्फ एंड गिव रॉन्ग इंटरप्रिटेशन टू योर पेशेंट आल्सो. So once it is confirmed, a structured 3-phase protocol guides the clinician pathway from removal through a potential reimplantation. Bas, that is the only last treatment. Timing and sequencing depends on extent of bone loss. As I mentioned, अगर bone loss सिर्फ supracrustal है तो बहुत less bone grafting से काम चल जाएगा और patient will recover soon. अगर there is a much loss of alveolar bone around the implant तो ज़्यादा graft लगेगा, ज़्यादा time लगेगा. और if totally implant is out in the oral cavity, then you need to properly graft the socket and wait for the socket augmentation. So बस टाइम लगेगा, पेशेंट लगेगा, पैसे लगेगा और थोड़ा सा आपको अच्छे से उसको वॉच करना पड़ेगा कि अगेन देयर आर चांसेस ऑफ फेल्योर या नहीं. रिमूवल ऑफ इम्प्लांट, फेल्ड इम्प्लांट यूजिंग रिवर्स स्टॉक रिमूवल और ट्रिफाइन बर. सो डोंट ट्राई कि हम उसको प्लायर से निकाल लेंगे या फोर्स लगा के निकाल लेंगे. बिलीव मी, ये बहुत टफ होता है रिवर्स स्टॉक लगाना, इतना आसान से नहीं निकलता अनटिल अनलेस वो बिल्कुल ही तीनों चारों तरफ से इन्फेक्टेड हो. तो अगर वो एक भी साइड से ऑस्टियो इंटीग्रेटेड है और 2-3 साइड से बोन लॉस है, वंस यू प्लेस रिवर्स स्टॉक, इट विल गिव, यू नीड टू यूज गुड अमाउंट ऑफ force, but don't try pulling with the help of any plier or any other non-recommended retrieval kits, so that you can minimize trauma to surrounding bone. क्योंकि आपने पेशेंट को कमिट किया है कि हम दोबारा डालेंगे, अगर और निकालेंगे तो देयर आर चांसेस ऑफ फ्रैक्चर ऑफ रिमेनिंग बोन ऑल्सो. जो इम्प्लांट के सरफेस पे लगी हुई थी वो भी टूट के बाहर आ जाएगी. सो काइंडली डू इट वेरी जेंटली विद प्रॉपर प्रेशर एंड विद प्रॉपर डायरेक्शन. उसको बस ऐसे ऐसे एक्सट्रैक्शन की तरह नहीं करना है. मेक इट अ जेंटल रिवर्सल टॉक. Site rehabilitation. There are various methods for site rehabilitation. Following removal, the defected site may be assessed with bone volume, socket preservation or GBR, guided bone regeneration, with xenograft or allograft, or a resorbable membrane is performed to resorb ridge. जैसे हम natural tooth में ridge augmentation के लिए procedure करते हैं, same is to do with implant, nothing new. Reimplantation. This is the last resort which we have. रीइम्प्लांटेशन करना भी कोई मुश्किल नहीं है. 5-6 महीने वेट करेंगे, बोन बन जाएगी, एक अच्छा इम्प्लांट दोबारा डाल देंगे. एंड बिलीव मी, आई माई सेल्फ हैव प्लेस्ड एंड इट गिव्स गुड रिजल्ट. ऐसा होता है कि पहले वाला फेल हो गया और सेकंड वाला बहुत अच्छा चल रहा है. सो इट हार्डली मैटर्स. पेशेंट उसको बाद थोड़ा अवेयर भी हो जाता है कि भाई मुझे मेंटेन करना है. सो दिस हैपेंस. सो लाइक दिस, रीइम्प्लांटेशन इज द लास्ट ऑप्शन. नेक्स्ट स्लाइड प्लीज. Ridge preservation following implant removal is a critical step in maintaining bone volume for future reimplantation. The type of graft material and membrane selection should be based on defect site, morphology and available donor site. ये तो ऑब्वियसली है, कितना बोन लगेगा, कहाँ से लोगे, कहाँ रखना है, कैसे उसको स्टेबलाइज करना है, whether you need fixation screws for membrane tagging or not. That is totally clinician's choice and situation based. You can use autograft, you can use allograft, you can use xenograft, alloplast. Guided bone regeneration is a treatment of choice. Barrier membrane is placed over the graft to exclude fast proliferation epithelial cells and connective tissue cells, allowing osteoprogenitor cells to repopulate the defect. ये तो simple procedure है GBR का, which you need to taken care of, है ना? So try. You can use non-resorbable membranes also and resorbable membrane also as per clinician's choice. As per clinician's choice, and वो. Prevention is the foundation of long-term implant success. The most effective management strategies for implant complication is preventing them from occurring in the first place. So as I mentioned, सबसे पहले हमें कोशिश करनी चाहिए कि ऐसा कुछ हो ना, by motivating your patient and motivating them to visit you regularly. Then a rigorous prevention protocol, beginning at patient selection, continuing thorough life plan, and dramatically reduce the incidence. Means you need to, मतलब हर पेशेंट को आपको ये नहीं कहना कि आपके इम्प्लांट लग जाएगा. काइंडली चेक कीजिए अगर उसका कंप्लीट पेरियोडोंटाइटिस की हिस्ट्री है और बहुत कम एज में सारे दांत निकल गए थे, सो देयर आर लेस चांसेस कि उसमें इम्प्लांट सक्सेसफुल हो. सो डोंट कमिट यू टू योर पेशेंट कि मैं कर दूंगा तो सब कुछ हो जाएगा. So this needs to be taken care at very early stage during ट्रीटमेंट प्लानिंग फेस है ना. ट्रीटमेंट प्लानिंग में प्रॉपर उसका रेडियोग्राफ लीजिए, प्रॉपर मेडिकल हिस्ट्री लीजिए, प्रॉपर फैमिली हिस्ट्री लीजिए, उनकी अपनी हिस्ट्री लीजिए, डेंटल हिस्ट्री कितना है, क्या नुकसान है, कब से कब तक है, ये सब कुछ आपको चेक करना है. और सेकेंडली सर्जिकल साइट्स जो होती हैं उसको भी अच्छे से एग्जामिन करना है आफ्टर एलिवेटिंग द फ्लैप. कई बार क्या होता है, रेडियोग्राफ कुछ और पिक्चर दे रहा होता है, वंस यू रिफ्लेक्ट द फ्लैप यू विल थिंक कि यार इसमें इम्प्लांट का साइज तो गलत हो गया, we need to change the size. So kindly take your decision on spot. Okay, if radiograph CBCT person has given you wrong implant size, it is your wisdom to choose good size. अगर आपको लग रहा है कि मुझे नहीं लग रहा इसमें ये diameter set होगा, kindly use the smaller diameter or larger diameter as per your own clinical skills, है ना? Next slide please. Next slide please. Case selection and risk assessment. Appropriate patient selection is the first and most impactful preventive step in implant therapy. Identifying and modifying risk factor before implant placement reduces the probability. As I mentioned in my earlier slide, key to success वही है, अगर आप पेशेंट को पहले से ही अच्छे से एग्जामिन करके उसको सारी गाइडलाइंस देके, स्मोकिंग करते हैं तो रोकनी पड़ेगी, कितने दिन तक रोकनी पड़ेगी, कम करनी है, बिल्कुल रोकनी है. There are certain medications which you need to change with the help of their physician. Some medications are, so there are two type of complications, absolute complications and relative complications. So if patient is identified under absolute contraindication, don't go for implant placement. Don't go for implant. It will be a trouble for you in future. Medical history review. What needs to be taken care is HbA1c level. पहले तो 5.5 था, 6 हुआ, नाउ अमेरिकन एसोसिएशन ने उसको 7 तक भी कर दिया है. Bisphosphonates therapy, mostly female patient, immunosuppressions, bleeding disorders, and active smoking. These are the 4-5 medical history which you need to take care while placing implant. These conditions significantly elevate complication risk and may constitute relative or absolute contraindication. Periodontal status. Patient with the history of periodontitis are always at high risk. जैसा मैंने मेंशन किया, अगर पेशेंट के पहले ही 25 दांत निकल चुके हैं नेचुरल, so it is very difficult to maintain implant in that patient, है ना? Active periodontal disease must be fully treated and stabilized. अगर you feel that you are placing implant and adjacent tooth has still periodontitis, that to active periodontitis, it needs to be addressed immediately. ऐसा नहीं है कि पेशेंट के मुंह में इन्फेक्शन है, पेरोडोंटाइटिस है, एंडोडोंटिक इन्फेक्शन है और आप उसमें इम्प्लांट लगा देंगे। उससे होगा क्या, वो इम्प्लांट साइट पे वो इन्फेक्शन ट्रेवल करेगा समहाउ, सूनर और लेटर वो उसको भी खराब करेगा। Ongoing supportive periodontal therapy is mandatory post implantation also. Suppose आप टाइम टू टाइम पेशेंट की कोई लोकल ड्रग डिलीवरी कर रहे हैं, लेजर ट्रीटमेंट कर रहे हैं, सो काइंडली कंटिन्यू। अगर इम्प्लांट लग गया उसके बाद भी उसको कंटिन्यू कीजिए टू गिव गुड हेल्थ टू द रिमेनिंग टूथ एज वेल एज इम्प्लांट। Bone volume assessment. This is very crucial. Don't ever rely purely on CBCT. Don't ever rely purely on IOPA, RBG. Always think twice before selecting the implant size as per the volume of bone available. कितनी हाइट है, कितनी विड्थ है, उस हिसाब से अपना इम्प्लांट दीजिए। और as given in MISH classification, which type of bone you are having in that particular area, D1, D2, it depends on the density which is measured in Hounsfield unit. So nowadays these CBCT machines have the feature which will tell you what is the Hounsfield unit of that particular area. Only thing, you have to run the cursor of the your laptop to the CBCT report. It will show कि इतना कितना Hounsfield unit है, if bone is D1, D2, D3 or D4, है ना? So kindly avoid D4 bone because that will have a poor mineralization quality. और if there is maxilla में sinus close है, mandible में nerve close है, so ये सारे जो factors है ना, इनको आप day 1 पे जज कीजिए। Don't rely कि जब करेंगे इम्प्लांट उस दिन देखेंगे, नहीं नहीं नहीं, then it will be a problem. इम्प्लांट साइज आपको बहुत आराम से चुनना है, एनाटॉमिकल लैंडमार्क्स को ध्यान रखना है, मैक्सिला में मैक्सिलरी साइनस को बहुत रिस्पेक्ट करना है, लोअर में आपको नर्व को रिस्पेक्ट करना है, एनी फोरामेन एनी अदर, तो वो सब चीजें देखनी पड़ेंगी। नेक्स्ट स्लाइड प्लीज। नाउ प्रिवेंशन इज ईदर ओरल केयर, प्रोस्थेटिक डिजाइन एंड ऑक्लूजल मैनेजमेंट। तीन तरह की प्रॉब्लम आती है और तीन तरह को हम तीन तरीके से इसको रिजॉल्व करेंगे। Long term implant survival depends heavily on patient's ability to maintain effective plaque control, obviously, and on clinicians' design on cleaning, biological compatibility, prosthetic restoration. As I mentioned, कई बार we decide कि whether we need to give cement retained or screw retained. तो कई बार क्या होता है, cement retained will give more problem to patient for maintenance. So kindly use your wisdom to check cement retained चलेगा, स्क्रू रिटेन चलेगा, एक्स्ट्रा सीमेंट तो नहीं है। एक्स्ट्रा सीमेंट होगा तो वो इन्फ्लेमेशन करेगा सॉफ्ट टिश्यू अराउंड इम्प्लांट का। सो होम केयर इंस्ट्रक्शन, इंडिविजुअलाइज होम केयर हाइजीन मींस पेशेंट, ईच पेशेंट इज डिफरेंट, काइंडली इंडिविजुअलाइज द होम केयर टेक्निक। किसी को फ्लॉसिंग चाहिए, किसी को फ्लॉसिंग नहीं चाहिए, किसी को इंटरडेंटल एड चाहिए, किसी को इंटरडेंटल एड नहीं चाहिए। मींस इंटरडेंटल ब्रश, तो ऐसा नहीं है कि अगर मैंने पढ़ाया कि इंटरडेंटल ब्रश आपको देना है तो आप हर पेशेंट में लिख रहे हैं, जरूरत ही नहीं है तो मत दीजिए, इंडिविजुअलाइज कीजिए, उसको पर्सनलाइज केयर कीजिए ना। वेदर सर्कुलर ब्रशिंग इज रिक्वायर्ड, वेदर इंटरडेंटल ब्रश इज रिक्वायर्ड, वाटर फ्लॉसर इज रिक्वायर्ड, इम्प्लांट फ्लॉस इज रिक्वायर्ड, तो वो सब देख लीजिए कि चाहिए कि नहीं चाहिए। प्रोस्थेटिक डिजाइन प्रिंसिपल्स, restoration should be designed with convex emergence profile to facilitate plaque removal. Adequate interproximal cleaning should be there. No residual cement in the sulcus. ऐसा ना हो जब आप सल्कस सीमेंट प्लेस करें तो उसमें आ जाए, वो सब आपको ध्यान देना है। ऑक्लूजल मैनेजमेंट, whenever you place crown, kindly wait for some time. Ask patient कि whether you are feeling any discomfort while closing the mouth. अगर उसको ट्रिम करना है, ऑक्लूजन को आपको सेटल करना है, वेदर विद नेचुरल, एक मिनट बंद छोड़। हेलो,
यस सर।
हाँ सुन रहा है ना?
यस सर, इट्स ऑडिबल।
हाँ ठीक है। देन कम्स ऑक्लूजल मैनेजमेंट, काइंडली मेक इट प्रॉपर के पैराफंक्शनल हैबिट है, ब्रक्सिज्म है, स्प्लिंट चाहिए। कई बार क्या होता है फुल माउथ की केस में, व्हेन वी आर प्लेसिंग फुल माउथ इम्प्लांट वी नीड टू गिव प्लेट्स, स्पेशली नाइट गार्ड्स, वो जरूरी होता है, तो उसको उन सब चीजों को अवॉइड मत कीजिए। नेक्स्ट स्लाइड प्लीज। स्ट्रक्चर्ड प्रोटोकॉल फॉर इम्प्लांट मेंटेनेंस एनालॉगस टू सपोर्टिव पेरिडोंटल थेरेपी। जैसे हमारे पास नेचुरल टूथ में एसपीटी होता है, वैसे इसमें भी स्ट्रक्चर्ड पेरी इम्प्लांट मेंटेनेंस थेरेपी होता है, एंड इट डिपेंड्स ऑन वेरियस स्टेजेस। सपोज 1 to 3 months post loading, initial prosthetic review, occlusal adjustment, oral hygiene reinforcement, baseline probing depth and radiographic। मीन्स जब क्राउन लगने के बाद 3 महीने बाद, 1 महीने बाद आप पेशेंट को बुलाएंगे, 4-5 चीजें यू नीड टू चेक। यू नीड टू चेक proper maintenance of oral hygiene. You need to take one radiograph to see crestal bone loss if any. You can do probing also at base, तो वो आपको बेसलाइन से 3 months बाद तक का एक इवेल्युएशन दे देगा। इफ दैट इज चैलेंजिंग देन काइंडली मेक इट कॉशियस के पेशेंट को आप री इन्फोर्स करें बार बार। देन सेकेंड स्टेप इज 6 month क्लिनिकल असेसमेंट इंक्लूडिंग बीओपी इंडेक्स, ब्लीडिंग ऑन प्रोबिंग का कोई इंडेक्स यूज कीजिए, प्रोबिंग डेप्थ, प्लाक स्कोर, पेरीअपाइकल रेडियोग्राफ, रीइंफोर्स होम केयर एंड एड्रेस एनी अर्ली साइन ऑफ म्यूकोसाइटिस। अगर आपको 6 month पे भी लगता है कि पेशेंट कैन गो फॉर सम नेगेटिव थिंग, काइंडली रीइंफोर्स इट। 1 साल 1 year एनुअल रिव्यू, फुल क्लिनिकल एंड रेडियोग्राफिक असेसमेंट, कंपेयर टू बेसलाइन, assess prosthetic component integrity, occlusion and soft tissue health। ये सब चीजें चेक कीजिए 1 साल के बाद भी। हाई रिस्क पेशेंट का मतलब होता है जो, एज आई मेंशन यू, विद हैविंग सिस्टेमिक डिजीज, इम्यूनो सप्रेसेंट, एनी अदर मेडिकेशन, उन पेशेंट्स को थोड़ा स्पेशल केयर आपको देना पड़ेगा। अर्ली डिटेक्शन इज क्रिटिकल टू प्रिवेंट प्रोग्रेशन इन पेरी इम्प्लांटाइटिस। हाई रिस्क पेशेंट, स्मोकिंग वाले, स्ट्रेस वाले, बिहेवियर जिनका ठीक नहीं है टुवर्ड्स ओरल हाइजीन, उन सबको हाई रिस्क पोटेंशियल पेशेंट्स में रखना पड़ेगा। नेक्स्ट स्लाइड प्लीज। सो हेल्दी इम्प्लांट में ब्लीडिंग ऑन प्रोबिंग एब्सेंट होगा, म्यूकोसाइटिस में प्रेजेंट होगा, पेरी इम्प्लांटाइटिस में प्रेजेंट होगा, ऑफन प्रोफ्यूज। सुपरेशन एब्सेंट होगा, दूसरे में भी एब्सेंट होगा, मे बी प्रेजेंट। सुपरेशन इज जरूरी नहीं है कि कंडीशन हो भी सकती है। प्रोबिंग डेप्थ लेस देन इक्वल टू 4 millimeter, इंक्रीज नो चेंज फ्रॉम बेसलाइन। पेरी इम्प्लांटाइटिस अगर 6 millimeter से ज्यादा बोन लॉस है, डेफिनेटली इट इज अ केस ऑफ पेरी इम्प्लांट। बोन लॉस का क्या होगा? नो बोन लॉस, नन प्रोग्रेसिव क्रेस्टल बोन लॉस। मोबिलिटी हेल्दी में बिल्कुल नहीं होगी, पेरी म्यूकोसाइटिस में भी नहीं होगी, इम्प्लांटाइटिस में भी नहीं होगी। रीजन इज क्योंकि हाफ द इम्प्लांट इज फिक्स्ड इन द बोन। रिवर्सिबिलिटी हेल्दी में नहीं होगी, उसमें होगी दूसरे में, और उसमें नो एक्शन रिक्वायर्ड हो, तो फिर निकालना ही पड़ेगा आपको लास्ट वाले में। की क्लिनिकल टेक होम्स। Effective management of implant complication requires early recognition, evidence-based intervention, and a commitment to long-term supportive care. The following principles should guide clinician decision-making across all implant patients. Peri-implant mucositis is fully reversible. Intervene early with non-surgical debridement and oral hygiene optimization. Begin with non-surgical therapy. Escalate to surgical intervention only when conservative measures fail. Match surgical approach of defective morphology. Address all risks before reimplantation. अगर आपको रीइम्प्लांटेशन करना है, काइंडली मेक श्योर कि ऐसा ना हो वो फिर फेल हो जाए। इम्प्लांट फेल्योर recurrence is preventable. Ensure systemic conditions are controlled, periodontitis is stabilized and patient compliance is confirmed before placing a new implant. पेशेंट को आपको रीइंफोर्स करना पड़ेगा कि पिछली बार ये 2-4 गलतियां हुई, अब के मत कीजिएगा, ये हमसे नहीं होंगी, सो डेट आगे अच्छा चले। Prevention is the highest value intervention. So case selection, prosthetic design, structured maintenance are the most powerful tool for prevention of. Every patient should have individualized maintenance protocol. As I mentioned, सबको interdental brush नहीं देना, सबको flossing नहीं देनी, सबको water flosser नहीं देना। हर patient को उसके हिसाब से advise करना है कि कितना उसको maintenance रखना है। Next slide please. ऑस्टियो इंटीग्रेशन इज नॉट अ डेस्टिनेशन। इसका मतलब ये है इस सेंटेंस का कि अगर 3 महीने में यू हैव अचीव ऑस्टियो इंटीग्रेशन, इसका मतलब ये नहीं है कि यू हैव अचीव द सक्सेस ऑफ द इम्प्लांट। फ्यूचर में भी ऑस्टियो इंटीग्रेशन फेल हो सकती है। So osseointegration is not a destination, it is ongoing biological relationship that demands consistent clinical vigilance and patient engagement. When peri-implant complications are identified early and managed systemically, the vast majority of implants can be preserved and patients can maintain excellent function and aesthetics for decades. The clinician's role extends far beyond surgical placement. It encompasses lifelong partnership with patient in protecting their investment. जैसा कि सब कहते हैं कि अगर एक बार इम्प्लांट लगाया तो पेशेंट का फोन आपको ऐसे आएगा जैसे बस सर क्या कर दिया आपने, ऐसा हो गया वैसा हो गया। सो उसको अवॉइड करने के लिए आप ये काम कीजिए, अच्छे से उसको मेंटेन कीजिए, अच्छे से उसको गाइड कीजिए, अच्छे से उसको कीजिए। नेक्स्ट स्लाइड प्लीज। Now, to summarize, diagnose accurately, intervene promptly, individualize maintenance, document and monitor. Ab, the most challenging part nowadays is documentation of your record. Kindly try to document from the placement stage till the reimplantation stage, because patient can go to court anytime. इससे क्या होगा, पेशेंट का एक कॉन्फिडेंस रहेगा कि डॉक्टर के पास सारे रिकॉर्ड्स हैं, तो he or she will feel कि yes, I am in good hands. You will also feel confident कि patient will not challenge you legally, because you have all document records कि when I have placed, I have monitored it 6 months, 7 months, 1 year, 10 year, 5 year. Patient was absolutely all right. Now later in the life he developed the problem which has effect on this implant which I have placed. So monitoring and documentation is very much required. Next slide, please. For future reading, as a periodontist, as a author of this article, Indian Society of Periodontology has given GCPs, means good clinical practice recommendation for peri-implant care. This has published in 2024 in Journal of Indian Society of Periodontology. This is around 29-page article, and around 24 authors, 26 authors have given their contribution. So believe me, this article will be eye-opener for you, and this has been accepted by international standard also, and this has good citations in international journals also. So this is a future reading which I am recommending from Indian Society of Periodontology, GCPs for peri-implant care, specifically for peri-implant care. Now next slide is. I thank you all. Thank you participants. Thank you organizer for giving me opportunity. Hope this session will have must given you some basic knowledge, basic information of basic do's and don'ts in management of implant complication. Thank you.
Thank you, sir.
Thank you, sir.
The
Thank
practical
you, sir, for the
insight.
wonderful lecture.
Thank you.
Thank you, sir.
Good morning.
Thank you, sir. The practical insights you shared will certainly help us enhance our clinical understanding and decision making. Thank you once again, sir, for such a wonderful and enriching session.
Thank you,
Thank
doctor.
you.
Thank you. Thank you, team.
Moving
Have a
on to
nice
our
day.
third lecture.
Thank you.
Dr. Radhika, you may please introduce our speaker.
Good morning, everyone. We are delighted to begin with our third lecture of day 2 on the topic of bone augmentation and sinus lift procedure by the Dr. Jasneet Singh Kalra. Sir is an accomplished clinician with over 14 years of experience in implant dentistry. He is a key opinion leader for Dentinum and CSM implant system and has been actively involved in teaching implant dentistry through various academies and CD programs. Sir is the founder of South Delhi Dental Center, Implant Academy, and runs a premium dental clinics in South Delhi. He has successfully conducted numerous implant workshops across India, covering topics such as guided bone regeneration, implant prosthetics, and advanced surgical procedure. It is a truly an honor to have you with us today, sir. We extended a warm welcome and look forward to an insightful and enriching session. Welcome, sir.
Sir, you are not audible.
Wait,
No, sir.
am
Yeah.
I audible now?
Yes, sir, you are audible.
Yeah, I just want to help how I'm unable to share the screen.
Sir, there will be a option in the bottom toolbar to share the screen.
I've been clicking that. It says caption, whiteboard, settings, reset to default, and chat video. Is that the one?
Because, sir, we are having your two videos coming up. Maybe you have shared the video screen right now.
Just a second. Should I rejoin again? Give me a second.
Yes, sir, sure, not an issue.
Yeah. Hello, am I audible?
Yes, sir, you are audible.
Yeah, but still I'm stuck at the same point wherein it doesn't shows where to share the screen. It says mute, video, participants, chat, react, AI companion, and more. In the toolbar, video settings, participants, AI companion.
Sir, are you clicking that arrow on the share screen?
I'm not, I cannot, I mean, there's nothing like share screen option popping up. There's one option, see, that's mute, video, participants, chat, react, AI companion, and more.
Sir, in more, there may be because I think so you are using the Mac.
Yes.
Yeah,
So,
in Mac, there is no direct options for sharing. So I'll
all right.
just guide you just a second, sir.
So in the more, it is caption, whiteboard, settings. There's something like screen sharing, general audio, stats, about, set to default.
Is there anything like meeting control?
Meeting control. No, yeah, in more, I'm getting captions, whiteboards. Whiteboard says existing whiteboards and new whiteboards, settings, and reset to default. So I've
Sir,
joined through a browser.
sir, just do one thing. You share me the PPT. I'll play the PPT. You just tell me when to change the slide. That will be better then.
Just a second. I'll do one thing. I'll just once again try through the Zoom workplace. Maybe it works.
Yeah, sure,
But
sir,
currently,
sure.
I've joined through the browser.
Okay,
Maybe
sir.
that,
Yeah, maybe that will be the issue. Okay,
yeah.
sir.
But
We'll wait.
again, I don't want any glitch in between. Just a second.
Sir, I have made you co-host right now. Is there no any option available? Sir, you are, please can you unmute yourself?
Yeah. Now
Yeah.
I'm audible, right?
Yes, sir.
So, option as view. Show chat, react, and move. Documents, record. Still somehow I'm unable to get the share screen option.
So just a second, I'll see to it.
Sir, in more, you will find the share option.
In more, I have record, then transcript, captions, documents, notes, whiteboard. Has it got something to do with whiteboards? No.
No, 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 no.
No, sir, whiteboard is something else.
Something else, exactly. So in more also, I'm not getting any options as such. Share, just a second. Wait. Set, yeah, I guess now that's my screen.
Yes, sir. It's
Yes, sir,
visible.
it's visible now.
Okay. Should I start?
Yes, sir, you can start.
All right. A very good morning, everyone. It has been a glitch for 5 minutes, but I am on my time at 11:30. I hope you guys must be having a good, wonderful educational session so far by plethora of speakers. We started this webinar from yesterday onwards. Firstly, all thanks and regards to Cynodent International for always having me on board, and so that I can share my clinical knowledge as well as my clinical skill and try to add on to the dental fraternity. Above all, it is the same fraternity which has given us so much. So my today's topic is I'll be speaking on predictability of guided bone regeneration in different clinical scenario. So I'm an implantologist, prosthodontist by degree, but implantologist by profession today. So one thing I can tell you, implants are for beginners and seasoned everyone. Now implants are no more just a luxurious option. It is more a mandatory option. So patients walk into our practice every day, and for missing teeth, the first line of treatment has been implants now. So we all know, I mean, the bone undergoes remodeling. Because of that remodeling, we do not get the conducive bone conditions every now and then, and we need to modulate the bone accordingly. So that is why we have to understand what all bone grafts are available in the commercially in the market, how to decide what kind of bone grafts in what clinical scenario. And I'll start with my clinical cases, and step by step I'll tell you how to decide a bone graft, how to decide when to place membrane, what are different kinds of membrane, and then I'll touch upon sinus lift, direct and indirect both. So sneak peek into my professional life, what we do in and around the globe today. So we have been training dental professionals for the past 3 years now. We hold basic and advanced implantology courses all across the country. Our main center is in Delhi. And me along with Cynodent, we are coming up with a fellowship workshop very soon. And this fellowship course is going to be a certificate course, wherein we are going to touch upon the basics in implantology up to advanced, and we will give you live demonstration, and you get to place implants on real patients. So it's a great opportunity for each one of you. So you can get in touch with Dr. Ashish and Dr. Anmol regarding the fellowship course in dental implantology. So my co-mentor will be Dr. Athre in this. So me and Dr. Athre, both of us would be conducting that course. All right. So my name is Dr. Jasneet Singh Kalra. I've done my graduation from Saraswati Dental College, Lucknow. I'm indebted to ITS Dental College, Greater Noida, or whatever prosthetics I have today. I'm diplomat with World Congress of Oral Implantology, mentor and fellow of Dentium Academy course, key opinion leader with multiple implant brands. So I run exclusively two courses, which is foundation course in implantology and Let's Crown Implant. I've been extensively trained in hard and soft tissue grafting. So the contents of my workshop, of my lecture today is I'll be talking about socket grafting, the rationale of it, what kind of extraction sockets and various types of grafting techniques, what are the principles of bone grafting, that is very, very important, on what principle it is based and how do we cater it. How do you decide a bone graft? How to determine whether do you need a membrane in a particular case? What is the principle of guided bone regeneration? Harvesting units, very, very important. We need to harvest autograft from the patients and take home aways. So we all are living in the beautiful world and we need all beautiful things around us with cases like these. This case reported to my clinic with 3-6 missing tooth. We got a CBCT done, a healthy good bone, opened up a flap. So I do freehand surgery because I want to feel the tactile sensation of my bone. After opening up a flap, we've seen a good amount of bone, went ahead, started a drilling protocol. I usually use Densa drill to densify the site with osteodensification, moved ahead and placed the implant. We generally submerge the implant by 1.5 to 2 millimeters so that whatever remodeling has to take place, even then there should not be major bone loss happening, and sutured the site. Post 3 to 4 months loading, we went ahead, customized the socket and prosthesis, jig trial, crown. This is day in and out practice for each one of us. But do we really get this patient every day? I mean, I wonder if I get these patients, I'll be the lucky dentist on this earth. But the scenario is whenever we expect a chicken or mutton biryani, this is what we are served on the platter at times. Because in clinical scenario, each and every case is different. A case like this, wherein you end up seeing a perforation in the labial bone, or maybe a case like this. After placing implant, few months to years, you see this grayish hue or tattoo, which is visible. That means there was thin labial or buccal bone, because of which you see implant is completely exposed, or maybe a case like this, wherein aesthetic disaster is there. Guys, one thing before sharing my knowledge in implantology, let me tell you one thing. Please do not get obsessed placing an implant. You should know when not to place an implant. I understand fundamentally we all are trained enough to place implant. That doesn't mean we have right placing implant anywhere and everywhere. So, cases like these, somewhere or the other, it haunts our patient of not getting the implants done in future. So please think prosthetic first before placing implants. Or a case like this, wherein you have loss of interdental or interradicular bone, you need to find a solution to it. That means maybe grafting or delayed placement or ridge augmentation or something like that. So starting with the first topic, what is the rationale of socket grafting? So socket grafting is very simple. It is the placement of bone graft and extraction socket, usually at the time of extraction. Whenever you're doing extraction, you have to keep few things in your mind. If you see it has been a traumatic extraction, it is always better you should be placing a bone graft so that you get a decent amount of bone when you are moving ahead with placement of implant. Or rather, I should put it this way. If today you're extracting any tooth and not planning immediate implants, that's okay. You should prepare your patient mentally that we are going to place implant after a few months. For that, you need some amount of bone. If you don't want to see major loss in the dimensions of bone, it is always better you place implant on the day of surgery. So a case wherein we place a graft and suture the site, or maybe in anterior cases. So anterior cases, if I talk to you about 1-1, 1-2, 1-3, that means lateral incisors, canines, and central incisors. We generally see the bundle bone is as thin as 0.3 to 0.5 millimeters. So as soon as you extract a tooth, there is massive loss of bone, and you even know what is dehiscence and fenestrations are. So all these terminology generally happens in anterior region. So in anterior region, you need to take that precise decision of placing bone graft on the day of implant, on the day of extraction. So why do we need this bone graft? Firstly, it enables us to place implant and gives us a decent stability of implants at the time of placements. It even reduces the loss of bone volume. So we see if the bone remodeling has to happen per se by 60 to 80, by 50 to 60%. If you place a graft, that remodeling might happen by 30 to 40%. It even reduces the need to additional bone grafting. At times, just a single time bone grafting on the day of extraction can prevent you placing graft again at the time of implant placement. It even provides quality bone at times, and it provides aesthetics that is very, very important. It is not only important to cover up the bone graft to so that you can take care of the hard tissue, but at times if you see any kind of fenestration is there or labial bone loss is there, you place graft so that aesthetics can also be taken care of. I'll show you the same with one of my case. And to regenerate bone faster, that's very important. We are in 2026, an era when each and every patient of us, they're looking for quick fix option. You need regeneration as fast as possible and to protect adjacent teeth. So these cases are very common wherein you see these horizontal and vertical bone loss happening, or maybe a periapical pathology. So this periapical pathology due to endodontic failure, due to trauma, or infection in the socket, which is exceeding the socket in the periapical bone. And we know we are going to get the breach in the bone in these cases. So straight away, these are not the cases of implant placement as a regular day-to-day case. You have to do something extra than implant placement. So before understanding about graft, we need to understand what are the extraction socket. The latest classification given by Kim et al. So he classified extraction socket into these four sub-classification. He classified as class 1, which is a 4-wall defect. So this 4-wall defect means you have all the 4 surrounding walls which are intact in the extraction socket. So you have 4 intact bony housing. There is no wall involvement. When you have a 3-wall defect, that means 3 walls are intact and that 1 wall defect is there. Generally, it's a buccal bone defect. At times, you see a palatal or lingual wall defect. Otherwise, most of the time, it is labial or buccal bone defect. Then you have type 1 and type 2, wherein in type 1, we see adequate height. That means you have a good height and inadequate width. In type 2, both the height and width are compromised. Here, I would like to add one more point. It is always easier and predictable to have a horizontal augmentation. Whereas if you see the vertical augmentation, it is not so predictable as the horizontal augmentation is. And learning curve is also more steep when you go and augment the vertical dehiscence or the vertical length of the bone. And finally, you have a 1-wall defect wherein you have inadequate width, height, width, and everything. So this is how do you classify the extraction sockets as 4-wall, 3-wall, 2-wall, and 1-wall defect. So what are these 10 keys to successful aesthetics? We all know a patient comes to us not just for getting an implant placed. They do not come with a titanium deficiency. They always come with one thing in mind. We want a good replacement of prostheses or teeth, right? So we need to understand these 10 successful keys, starting with aesthetic risk assessment. So what is this aesthetic risk assessment? You need to see the smile line. You need to see the zenith. You need to see that pink is to white ratio. Then you move ahead and do a CBCT or an OPG, depending upon what is your tomographic plan. You move ahead. If it's an immediate extraction, you go in for atraumatic tooth extraction. Nowadays, we're not using straight away forceps and giving a buccolingual tilt. Rather, we're using something known as periotomes, luxators, to luxate or root extractors. And then we extract the tooth just by a rotation. No buccolingual or labiolingual movements. 3D implant placement. So this basic 3D placement was explained by Mesh long back, but still I feel some other way we are getting diverted, seeing the bone and placing implant wherever we feel like. So I understand bone is important, but you have to place implant prosthetically. That is very, very important. Narrower versus wider implant. Try to place narrower implant in maxillary or mandibular anteriors. so that you give enough time or enough space to your ceramist, so that the labial contouring or the kind of aesthetic outcome we're looking for, a lab guy can give you. We need to understand what is the jumping distance, that is a bone gap versus bone graft. If that jumping distance is anywhere less than 2 millimeters, we need not to graft that site. So guys, what is that jumping distance? That jumping distance is the distance from the implant, from the socket wall to the implant. That is the jumping distance. So if it is more than 2 millimeters, it is always better you should be grafting the site. Next is facial gingival grafting. After almost, I would say, 12 years of practice, and especially in implants, we have understood the importance of soft tissue. You need to have good keratinized, healthy soft tissue. So at times we move in for free gingival grafting, connective tissue grafting. So wherein we have, we deal with Asian population. We have thin phenotype, so it is always imperative to have a healthy keratinized soft tissue, wherein you have to go in for facial gingival grafting. Immediate contour management. If you guys are following me on Instagram and Facebook, in my social media, I've been posting cases. So you see my cases of immediate extraction and implant placement. We do contour management, because we know in immediate extraction placement, it is very difficult to close the flap or approximate the flap. You cannot just suture the site and come out of it. So there's something known as customizing the extraction socket with the help of either gingival former or abutment. And composites. This is how do we do. And custom impression coping technique. If you have customized the socket, you have to customize the impression coping as well. And wherever possible, try achieving screw retained processes if you're getting that passive outcome. So starting with my first clinical case, I want you guys to understand what is a socket shield technique, which has been a paradigm shift now. So meet my patient Nitesh with ailing 2-1 and endodontically failing tooth again and again. We went ahead and we have first segmented the root. So in a socket shield technique, we generally segment the root from buccopalatally, and we remove the palatal root. And this is how do we do. Okay. After this, we go ahead and start our osteotomy site. The apical bone is the bone we need to engage first to have a good primary stability. Post that, after the implant place, this usually we do after the implant placement, we basically trim the labial part of the root. So basically what we are trying to do in this technique is we're trying to fool the bone by giving a signal that still the root is present. So that means a bundle bone 0.3 to 0.8, depending upon the case, that is not going to resolve over the period of time. Because we know if you have a root stump lying there, the bone is always going to hold on to that, right? So this technique has its emergence from something known as partial extraction therapy or root submergence technique, which was given by Salama et al. In 2003. So this is the basis of socket shield technique. So after conditioning the labial root and trimming it by 1.5 to 2 millimeters below the free gingival margin, we go ahead and place implant in the correct three-dimensional position, and that is the final smile of the patient. If I would widen the picture, you see a beautiful, thick, keratinized, soft tissue. So here, I mean, if I have a live audience, I would always love to ask this question. If you can tell me what kind of a crown is this? Maybe after my presentation, we can have a Q&A session, and this would be my first question. What material of crown have I used in 2-1? Is it Emax? Is it PFM? Is it zirconia? Or what it is? Okay. So yes, there is a difference between ridge preservation and ridge augmentation. These two ladies are the perfect example of it. So what is the secret of growing bone? It is basically strategic planning. You need to sit with your team. You need to sit with all the pre-operative data, that is your pre-operative images, your tomographic plan, your models, and patient clinical condition. And then depending upon these factors, you plan how to go about with the case. Firstly, you need to see the type of extraction socket. You need to see what are the materials and type of graft available in the market, and you can catch hold of it. And what is the technique you're going to apply in this, but in any particular case? So what are the kind of bone grafts or the types of bone grafts which are available in the market? How do we classify that? This we basically classify bone graft as autografts, allografts. In allografts, we have DFDBs and FDBs, xenografts and alloplasts. So what is this autograft? Autograft is a graft which is harvested from a patient's own body, from host body. If we are taking any bone graft, that is the gold standard, we call it as autograft. Allograft is the graft taken from the same species but different individual. Correct. So now in most of the countries it is banned because of any genetic variation, and we have seen a lot of diseases getting transmitted because of that genetic variation. Then the most popular graft today is xenograft. So it has a coralline, bovine, and porcine origin. The major shortcoming of xenograft is a religious sentiment. So you need to understand that, talk to your patient before selecting one. And finally, you have alloplasts. Alloplasts are basically the synthetic grafts. It can be beta TCPs, alpha TCPs, composite grafts, ceramic grafts. There's so many grafts in the markets which are available. So these are the sources or origin of bone grafts. So before understanding guided bone regeneration, we need to understand what are the significance in bone grafts. So this grafting technique has how you are looking at predictable, successful results in grafting technique. Everything depends upon these three significance. That is, does your graft has an osteogenic potential? मतलब क्या इससे bone बनेगी? Osteoinductive, it is going to initiate the bone formation. Two, and osteoconduction, whether it is going to give that signal to rest of the bone forming cells, and it is going to lay down a matrix. So guys, understand one thing: bone graft is not a magic powder. You place a graft and get a bone. ऐसा नहीं होता. अगर ऐसा होता तो हम हर केस में ग्राफ्टिंग करके इजीली बोन रिजनरेट कर देते और आज नेचुरल टूथ को बचा पाते. But it doesn't work this way. So what does a bone graft do? Bone graft acts like a scaffold. It is just a scaffolding holding there so that it gives you a medium or a matrix wherein all the progenitor cells, osteocytes, osteoclasts, osteoblasts, they're going to come, invade, and they will start their own function. So like in our Indian team, when we were facing the downfall of the Indian team, we saw Dada coming into the team and giving that osteogenic potential and telling us, yes, we can do that. So similarly, that osteogenic potential is generally given by the autograft. That means patient or the growth factors and the immune bone. Then Sachin, we know the little master, he has been showing us, giving us results. Similarly, your graft has to have osteoinductive property. If there is an osteoinductive property, then predictably it is going to convert it into a healthy bone. And finally, we won World Cup when we had the master MS Dhoni in our team. That means osteoconduction. Now we want someone who will give you that manifestation. Yes, we can do this, and we'll do that together. That is osteoconduction. So you need a graft which will have that osteoconductive properties as well. So it is osteogenic potential, autograft, osteoinduction or conduction given by rest of the graft. So it has to be a hybrid grafting. It is not just one single graft is going to work. It has to be synergy in almost combination of graft which is going to work in the clinical scenario. So these are the different pros and cons of different various grafts. If you want to take the picture of this slide, you can take this. So if you see, there are live osteogenic cells only in autograft which are present. In allograft is generally osteoinductive and osteoconductive, and xenograft in itself is it is only osteoconductive. It has got no osteoinductive function or feature. And then we have osteoblast, that is my synthetic bone graft, which is again osteoconductive. So what are the keys to predictable socket grafting? We have to understand how does it works. So there are 4 S principles: surface stability, space maintenance, and submergence. Or I would say better would be the PASS principle. Understand what is this PASS principle. आपने implant place किया, उसके बाद क्या करते हैं? So first thing is you need a good wound coverage. First thing, tension-free wound coverage. For that, you need to expose the site as much as possible. Then you need to have a space maintenance. You don't need unwanted cell. That means जब भी आप grafting करोगे, you just want hard tissue cells to be there. That means the osteoblasts. You don't need fibroblasts. So there's something known as barrier membranes you have to place in between, which would separate both the cells. Then you need angiogenesis, which is adequate blood supply. I need growth factors. Without these growth factors, clot formation, and rest of the inflammatory mediators, I'll not going to have a decent amount of bone surrounding my implant. And finally, stability of wound and implants. I need to have a tension-free closure one and stability of the entire site. So this is the PAS principle we have to follow during the surgery. So we have already understood what is basic socket grafting. You extract a tooth, you place a graft, you just do the suturing, and post 8 weeks, you see a decent amount of bone formation wherein you can go ahead and place implant. Now, before that, we need to understand for how. So after placing of graft in the extraction socket, so after how many weeks we can go ahead and place an implant. So what literature says, after 10 to 12 weeks, that means approximately 3 months, 3 to 4 months, you will have a decent amount of bone wherein you can go ahead and place your implant. And in this case, we have first extracted the site. We have extracted the tooth. Post that, can you see this buccal dehiscence or the buccal bone fracture? That means I cannot go ahead and do an immediate implant. We have placed Osteon 3 collagen, which is approximately 90% bone and 10% collagen. So whenever we talk about collagen only help in soft tissue. The bone graft itself acts like a scaffold. So you need a graft which has 90% bone graft and 10% collagen. Only then it is a bone graft. If it is pure collagen, it is not a bone graft. It is only a soft tissue substitute. And healing after 10 weeks. We got a decent amount of bone. So I have approached the site approximately after 16 weeks. That means 4 months. We have a good bone. We went ahead, started our drilling protocol, densified the site. And this is after healing. Then second stage surgery after gingival former. If you can see that buccal dehiscence has been taken care of and we have a good soft tissue surrounding it. So this is what we are looking at. It is not only about implant getting osseointegrated. If I talk about osseointegration, that is the topic of our webinar. Osseointegration has been very predictable. A good titanium implant with a beautiful surface conditioning. You are placing implant in a correct three-dimensional position. It is bound to osseointegrate. One thing I tell in my lecture is implant doesn't fail. We as dentists fail. We have to understand the right clinical scenario, patient condition. Skill is one thing which we have to adopt. I always say talent is inherent or a God-gifted thing. But by discipline, you attain and achieve skill. Please look at skill rather than talent. And furthermore, we went ahead and gave a good processes. This is how we ended this case. That means delayed implant placement followed. First we have done the grafting, and then we went ahead and we placed a implant and completed the case. So when do we need to, place collagen membrane? That's the biggest question today. So if we know it's a 4-wall defect, that means you have walls all surrounding it. You don't have to place membrane at all. Again, I'm repeating this. If it is a 4-wall defect, that means you have extracted the tooth, all the 4 bony housings are intact. You're just placing implant inside. Your implant is surrounded from all the 4 sides with the bone. You don't have to place collagen membrane at all. Because this membrane is expensive and there's always a dilemma when to place membrane. Any case which is other than 4-wall defect, you have to place membrane no matter what. Either it's a 3-wall defect, 2-wall defect, or 1-wall defect. So how we were taught to place a membrane, we were taught as if it's a bed sheet. You're going to tug in, you're going to pull, and then it is it. Guys, that easy. My first case, when I started doing this, this is what happened. I placed in, I tried to tuck it, the entire thing fall off. So people who have actually, you have tried placing bone graft and membrane, they know the reality of it. What seems simple in social media pictures, in literature, it is not when you go into your clinical cases. So before telling you what are the best ways to stabilize membrane, I want you to first introduce what the barrier membranes are. So generally we have two types of barrier membrane. One is a resorbable membrane and second one is non-resorbable membranes. So what are we looking at? I don't want on in the second stage surgery, I need to remove, I know we have to just remove the cover screw. That is one thing which is simpler. But if I have to retrieve a membrane also, so that surgery becomes elaborate. That means I have to release a full thickness flap for that. So I would look at something which is an absorbable membrane. Nowadays, we're using majorly collagen membrane, which resorbs by 4 to 6 weeks. But the cases wherein you have to go in for an extensive bone graft, especially in a 2-wall defect or a 1-wall defect, you need a sturdy membrane. That means a membrane which is non-flexible. So whenever I'm talking about a membrane which is non-flexible, I'm talking in terms of titanium membranes. So if you see on the left side, there are three types of non-absorbable membrane. Metallic, which is like titanium foil or titanium mesh. Nowadays, we have 3D printed titanium mesh also. Or you look at synthetic polymeric membrane, I'll show you in the pictures as well, which are EPTFEs, polytetrafluoroethylenes expanded, or dense PTFEs. Or you have the reinforced EPTFE with titanium and DPTFEs with titanium. So membrane, how do we choose membrane? We choose membrane depending upon the clinical case. If you end up fracturing the buccal bone by say 3 to 4 threads, you don't need something like a sturdy membrane or titanium membrane there. You just have to cover it up with a collagen membrane and let it be there for 4 to 6 months. Post that, you see a decent amount of bone creation, or it's a 3-wall defect. But yes, if it is more than that, you have to use a non-resorbable membranes. Moving ahead, a case wherein you can see there was a narrow ridge. We went ahead, we gave a mid-crestal incision. So one more thing, what kind of incision or what kind of approach, surgical approach we have when we are moving into grafting. We go on with the mid-crestal incisions, firstly clavicular incision and then the releasing incision. You have to give a releasing incision in a bone grafting case. Why do we need that? I need to expose a full thickness flap and it should be as loose so that once I'm closing it, the closure should be tension free. That is one. My flap should be capable enough to hold on the membrane and graft properly. The biological, the biological assembly, what I'm going to create, it should not have something like a tension flap because of which we'll end up in a mess. So you have to give a releasing incision in your grafting cases. We opened up a flap. You can see the narrow ridge. It was hardly 3 millimeters in width, but the length was still conducive. First thing is flattening the platform, then the drilling protocol, densifying, placement of implant. If you see here the placement of implant in both the cases, on the left, I can see that titanium hue. That means I have approximately 0.3 to 0.5 millimeters of buccal bone remaining. And in the right image, I can see my 4 to 5 threads are exposed. That means I need to graft this site. So my first principle of grafting is something known as decortication. Can you see the holes surrounding my grafting area? So what we need to do is we use generally number 8 round burr, which you can attach with a physio dispenser, or you can use the pilot drill, or you can use aerotors, the tapered or the straight fisher burrs. Go in and you just have to ditch the side or create these holes. So this is known as decortication. I'll tell you why we have done that. Post that, I would go and scrape the bone from the patient's own site. I'm not going to move in for a second site. I would just open a full thickness flap, undermine the periosteum. Beneath the implant side, I will just scrape with the help of scrapers and I would collect the autograft or the patient's bone. First, whenever my implant threads are exposed, my first graft getting in touch with the implant has to be a autograft. It cannot be a synthetic graft. So whenever I'm talking about artificial synthetic graft, it can be alloplast, it can be xenograft, even it can be an allograft. So these three grafts should not be the first point of contact. The first point of contact has to be an autograft. After that, we will overfill the site with the help of alloplast, allograft, or xenograft. In this case, I've used xenograft. Secondly, you need to over contour or over graft the site, because approximately 20 to 30% resorption is going to happen no matter what. Okay, that is a biological process. Body is going to take its own sweet time, its own sweet remodeling. So you have to overgraft. You cannot go miser with grafting. Post that, I have a membrane. I would stabilize the wrap around it within the body of my residual alveolar ridge. And then if you see those metallic studs there, those are known as membrane tacks. I have stabilized my membrane with the help of these membrane tacks. So these are tiny board pins, I would say. They are more or less similar like board pins. The length of these membrane tacks are ranging between 3 millimeters to 8 millimeters. In this case, I have used 4 to 5 millimeters of the membrane tacks. You just place them, tap, it goes in, and it stabilizes the membrane. This is the best way of doing it. Second way of stabilizing your membrane is through suturing. You go ahead and do suturing. In the next case, I'll show you that as well. And this is how you stabilize the membrane. And finally, you close the site with resorbable suture. Mark my words, please use most of the time resorbable sutures when you are stabilizing the membrane. Or you can use resorbable sutures stabilizing the membrane. Rest of the flap, you can still use non-resorbable sutures. So what is the principle of GTR, that is guided tissue regeneration? You basically need to exclude epithelial and connective cells from each other. Epithelial and connective cells, which are going to be the part of your soft tissue, from the osteoblasts and osteocytes. You need to exclude them. How you can do this? By these barrier membranes, placing them in between. And how does it function? This picture in itself can show you. If you see that thin barrier membrane and then the periosteum, and on the other side you see soft tissue, this is how it excludes both the structures apart. And that's the reason how it does. So one part of the membrane is corrugated, or I would say rough. That rough or corrugated part should be towards the bone. Other part is smooth. That smooth part should be towards the soft tissue. That means the rough part, the bone cells or the bone graft is going to hold on to, and the tissue, the fibroblasts are going to be contained within that smooth part. So here you're segregating both the surfaces. That is how you need to place your barrier membrane. Coming on to the next clinical case, or from here on, I'm going to just talk clinical cases only. So immediate extraction, after extracting the site, we have opened up a full thickness flap. I always open up the flap no matter what. I need to see the bone first. I've seen that labial or the buccal bone fracture happening, place my implant, and that is the amount of bone you see surrounding my implant. So if you close the site like this and you end up a titanium tattoo after a few months, do not get that surprise, guys. That means you have done something wrong here. This kind of a bone is not going to heal of its own. First thing is decortication. You place the combination of auto and xenograft and stabilize the membrane. So first I have scraped the autograft, covered my implant surface and my thin shell of buccal bone with the help of autograft, xeno or alloplast, and you can see the membrane. So first we hold on to the membrane, place the graft, and then wrap around the membrane like this. And then if you see the most inferior suture, which is right sitting there at the bottom, that is basically a membrane stabilizing suture. So it is something, a modified, I would say it is a modified H-shaped suture, which will hold on to the membrane. And then I would add up the rest of the site. So collagen membrane has enough data to show us today. It is very much conducive and reliable membrane in bone grafting techniques. These are commercially available membrane in the market with different brands. Non-resorbable membrane, as I have already discussed this, we use these membranes whenever there is more drastic bone loss, or the bone loss is major. So these are non-resorbable membranes. The regular membranes what we are using in our clinical setup is EPTFEs and DPTFEs. If you see that white color sheet is made up of collagen, and whatever the structure, something like a cavity preparation in class 1, what you see there, that is basically made up of titanium. That metal inside is titanium. And on the right side image is dense PTFE membranes. So the collagen part is going to resorb. Rest of the part will be titanium, which will hold on there. When you will enter in the second stage surgery, you have to just retrieve that much part of titanium. And this is how it is. In the center, you see that titanium strong reinforcement, and on both the sides there is collagen membrane. The main disadvantage of a non-resorbable membrane is wound dehiscence. At times, because of the sharp nature of this membrane, it protrudes from the soft tissue, and you see secondary infection happenings over the period of time. So guys, in the next case, what do you see? If I ask you to diagnose this case, how would you diagnose? So I would see, obviously, it's a first premolar missing, young female with the white smile line. 2. Second thing, do you see that buccal dehiscence happening? That is very, very important. I need to counter that. I want you guys to see that buccal dehiscence happening. That means this part is almost something like this. Okay. So when the patient is going to smile, there will be depression. So obviously, if you end up giving a fixed dental processor, that is FPD, you cannot cover up this dehiscence. If you give RPD, only then the plate is going to cover it. But here in implant, we have to function as FPD and RPD both. That means we'll cover up the hard tissue, the tooth, with the help of a crown, and soft tissue dehiscence has also to be addressed. Secondly, can you see that frenum, which is right sitting there in my surgical site? So if I open up the flap, there can be a pull because of that frenum muscle. So I need to relieve that muscle as well. This is how we plan surgical, and everything is going to fall in its place if your planning is bang on. So you can see the C-shaped buccal dehiscence. We went ahead, we got a guide fabricated. So this guide was fabricated just for initial punch. So the guided surgery wasn't the purely guided surgery going ahead with all the drills. I would just go with the pilot drill, take the right punch because of the narrow ridge. Rest, I would be going freehand. We just took a punch. We came out of the surgical site. We removed the guide, opened up a full thickness flap. You can see the bone, started densification with the help of specialized densa drills, and final implant placement. And you can see that grayish hue. That means the buccal bone is too thin here. And I even have to counter that C-shaped bony concavity which is there. First thing is decortication. So why do we need to decorticate the site? Basically, I want the progenitor cells to go there to the GBR site, and they will start, the formation of bone will be faster. Secondly, I need prompt angiogenesis. That means I need bleeding points to be there because blood in itself has growth factors. Thirdly, it even gives me a physical connection between a recipient site and a graft. So you need that physical connection because, see, bone graft should not act like a dead bone, white color, dead bone sitting there. And when you open up the flap, you see all the powder, all the crystals, all the granules sitting there, and they're not converted into a host bone. This is not the basic idea of just, you are just going in for a contour management. No, you need the non-living bone graft to be converted into a live living bone. For that, you need all the steps to be followed. And we do it with number 8 round drills, pilot drills. You can use your aerator burst in a slow speed and copious irrigation. And that's a membrane we have used. You can see on the left upper side, it's a smoother side of the membrane. On the lower side is the corrugated side. We would just stabilize the membrane first, place the graft along with autograft and xenograft, and I would do extra grafting, as I have already told you, overgraft the site, and then stabilize the membrane. Place a stabilizing suture and suture the site. Now on the left upper was pre-operative picture, then this picture is after 4 months. Now if you can see the entire frenum which was released, it was there. Now it is in the attached gingiva. One. Secondly, the entire dehiscence has been taken care of. This is at the second stage. Now there is no buccal, concavity or dehiscence. Everything has been taken care of. Once my patient will be smiling, you cannot see that concavity happening now. And this is how we completed the case. Here again, the question, what kind of crown material have I used? Because I've seen, after seeing my cases, most of the people ask me, sir, which lab, what material? So I'll answer this question after the webinar. Next is, now how do you approach any anterior case? We have talked about premolars. Let us come to anterior. Any and every anterior case, you have to plan bone graft. That is a thumb rule. You cannot go in 1-1-1-2 even if it's in delayed side without any bone graft. And if you're doing that, you will end up in a mess in most of the cases. So bone graft is not only needed to cover up the buccal or labial bone, it is also needed to give aesthetic results. So in this case, you can see the dehiscence is there, and then the bone, the CBCT says it's all. There is the complete loss of labial bone, and until 11.3 from the crestal, there is very thin bone. And from there, you have a 9.5 mm of bone in the width. So the coronal section also shows you there is a good bony deformity. Opened up a flap. That's the bony deformity. Started with our drilling protocol, apical bone anchorage. And if you see that whitish color concavity or whitish color, osteotomy bed, that is because I use denser drill and I've been moving the bone. Guys, nowadays, we're not just using excavating drills given by the companies to just remove the bone. We even, try to move the bone with the help of magnetic mallet, with the help of osteotomes, or with the help of specialized denser drills. Place the implant. This much amount of implant is exposed. Now, the second question would be, why haven't I taken my implant inside the bone, right? Most of the surgeons would do that. But I've seen one thing. There is a principle which says, whenever you're dealing in the aesthetic zone, the implant placement should be 3 to 5 millimeters from the adjacent CEJ. If you are not adhering to this principle, you will not have interdental papilla forming at all. Rather, the gingiva is going to recede of its own, and then you will have that black triangle. You will have an aesthetic result. So this is why we adhere to the 3-dimensional implant placement and the golden principles. And then the combination of autograft, xenograft. Here I've used the safe scrapers to scrape the autograft, and the combination of allografts and autograft has been used, and then I've covered it up with membrane and sutures. Okay, coming on to harvesting units. So what all autograft harvesting units can I use? The simplest unit I would say is bone scrapers, which are readily available in the market. Second is refined drills. Refined drills are basically the bone excavating drills. I'll talk about this. Piezoelectric unit and bone rongers, which are readily available in your clinic. So what are these bone scrapers? Bone scrapers are generally available in 2 different material. One is the plastic ones, which is disposable. You can just use it in one patient and then dispose the scraper. So the best part of these scrapers are they have got sharp, the metallic blade is very sharp, and it is very easy to excavate the bone. Second, the metallic one, it becomes dull after second or third use. You need to sharpen it up with the help of Arkansas stone, or you can change the blade. So these are 2 bone scrapers. Easily you can scrape the bone from the host side. Refined drills. These refined drills are generally used to excavate the bone surrounding the implant, so that when you are going ahead for implant removal due to any XYZ reasons, we use these refined drills. So these refined drills starts from 2 millimeters, goes up to 8 millimeters. You can use these drills just to go punch the bone and remove the bone, and then you can crush the bone with the help of bone crushers or bone millers and use that autograft. Third is piezoelectric unit. We have these piezo units in the clinic, which are generally used just to cut the bone. You use them in disimpactions also, or you can use them to retrieve the bone or bone rongers. After extraction, we know there are very thin plate, or I would say there are bony exostosis present. You can easily go and extract the bone from those exostosis or thin plate with the help of bone rongers. Crush it, mill it, use it as bone grafts. Okay. From bone graft to sinus lift. So there are two. So sinus lift is basically when we have pneumatized sinus or less bone, in terms of height, because in terms of width in maxillary posterior region, we always have a decent amount of bone. When it comes to height, generally we have less bone. So whenever you have less bone, you lift the sinus, which is very predictable. Indirect sinus lift or crestal approach, we go from the crest. Second is direct sinus lift. We have a lateral window approach. We go through window and lift the sinus. I'll show you both the approaches. So in indirect sinus lift, you go ahead, you are short 2 millimeters from the sinus floor. Okay. With the help of a specialized instrument, either osteotome, Densa drills, or magnetic mallet, you go and you intentionally give a green stick fracture at the sinus floor, and you start lifting the sinus along with that cortical bone which is there, which you can see in the picture. Post that, once you have lifted the sinus along with that bone, you will first place the bone graft, let the bone graft go and seat there. With the help of implant, you are going to lift rest of the sinus membrane. So now, wherein you had a bone per se of 4 to 5 millimeters, now you can easily place a implant ranging 10 millimeters by lifting the sinus, placing the graft, and easily your implant will be surrounded with the bone. Clinical case, a case wherein this first molar was missing. You can see we have hardly 4.8 millimeters of bone, and I was ought to place 10 implant in this case. So this was IOPA of it. We went ahead, opened up a flap with the help of Lindemann drill. Lindemann is the initial drill when we are entering the site. 1 to 2 short of sinus floor, first thing. Second, with the help of Densa drills. Now, Densa drills in the counterclockwise direction, that means reverse direction, move in and start, pushing the sinus floor in this way. Go, come back, hit, come back, hit, come back. So that you are trying to, you're trying to give a green stick fracture, and you're going to lift the sinus along with that cortical bone. This is where I cross the sinus floor. Okay. Furthermore, you can just cross the sinus floor by 3 millimeters. That's it. You don't have to go by 10 millimeters. Then there are very high chances of perforating the Schneiderian membrane. This is the final Densa drill. Then I have placed the bone graft. You can see that radio opacity and the tenting or umbrella effect inside the socket. What it shows that my Schneiderian membrane or sinus membrane is intact. That is why hollowing or that tenting is there. The graft which I have used here is Novabone putty, which is an alloplast. The best thing of this graft is the dispensing gun. Easily it can go in and it can flow the entire bone graft inside. Other alternative you can use is Bios pen with the help of, again, it has got a good dispensing unit. And then you place your implant. And if you see, it has got a bicortical anchorage. It is inside the sinus, and I've placed a cover screw. This is what is indirect sinus lift. Next is direct sinus lift. In direct sinus lift, what we do, we create a lateral window. If there is a sinus floor here, 2 to 3 millimeters above the sinus floor, we start creating a window, and then we, with the specialized curates, we go ahead and we start separating the Schneiderian membrane. Through a video, I'm going to show you next how do we separate the Schneiderian membrane. Then we place graft. Post that, we place implant and let the implant hold on to the graft, and then we suture the site. I'll show you a small video showing the direct sinus lift. And this is a diagrammatic representation. Direct sinus lift is generally done when you have RBH, residual bone height, of less than 3 millimeters. This video is going to show you how do we do a direct sinus lift. Important thing is you open up a good full thickness flap with maximum exposure. The blade here, what I'm using is a 15C blade. And this is the releasing incision. I would release the entire periosteum. This is a specialized burr which is present in the sinus lift drill made up of diamond. This is not going to perforate the membrane. Specialized curate to separate the membrane. Slowly you go in and start separating the membrane from all the four sides. And I'll show you next is Valsalva technique. This. That means my membrane is intact. There is no breach in the membrane. If you guys are interested in the sinus lift workshop on 2nd of May, 2nd or 3rd of May, I'm going to have a workshop with IDS South Delhi, which is dedicated to sinus lift only. So we go ahead and we are going to separate the Schneiderian membrane in this way until my membrane is too free. First, just the drilling. And drilling is always under drill. We are not going to perforate the cortical bone. You can enjoy the music also. It's a Nepalese music. You need to use stoppers in these cases. You cannot go beyond it. And this is my technique wherein I'm using a collagen membrane to be on a very safer side. I go in the window and from there I'm going to push my membrane more, and then I will start grafting the side and push the membrane simultaneously. So now the chances of membrane perforation is reduced by more than 70%. Final drilling, placing the active implant from dentium, and you see how much torque I'm going to achieve with that residual bone of 3 to 4 mm. 45 Newton centimeter of torque, which is a decent torque at the sinus side. Placing 2 implants in the perfect 3-dimensional position. Getting a very good torque, very high torque. You can even place gingival former if you want that former to hold on to the implant, especially in cases of sinus. And this is how you complete your direct sinus lift. Cover screw, and the window which you have created, you have to cover it up with bone graft and membrane, or what I'm using here is my collagen graft, which has got 90% graft, 10% membrane, 10% collagen. So this is going to cover up the entire window. So now I have bone in all the sides. So the window which I have created, I have excavated the bone. I have covered it up with the bone graft. And this is how we complete direct sinus lift. Very predictable technique today. We do it in our day-to-day practice. Here I've used a bright implant, which is a sharp, which is an active implant. A case of internal resorption, wherein first we have extracted the tooth. There was hardly interdental bone present. We went ahead for a delayed. We have placed graft. We went ahead for delayed placement. This was still, I can see the bone is not sufficient for a decent implant placement. That means we have to do grafting. The implant was exposed, autograft, combination of xenograft, covered up with membrane and sutured. Another case, aesthetic case, I'll show you the results straight away. This was the breach. Implant in the palatal side. That is very, very important. I generally use BioGuide as my membrane. The smooth surface towards the my soft tissue and the corrugated towards the hard tissue, and sutured the site. Post suturing after 5 months, I have given a temporary processes first. Because of that temporary, you can see a good emergence profile. And after impression, Zik trial, we have given a customized abutment made up of titanium and Emax crown in this case. This was the final finish line of the processes, and I'll show you a video of final smile of the patient. So these kind of results are what our patients are expecting, not just the implant placement. So our patient should go with a good, healthy teeth and aesthetically driven. That is important. A case in mandibular incisor, we have extracted two incisor. One was traumatically, it got avulsed, and the second one was again fractured. We have extracted it. We went ahead and did one implant placement because I have planned to give one cantilever in this case, and the bone was less, so I cannot take my implant more, inferior. Otherwise, I would have lost the interdental papilla. Place the membrane, place the graft, sutured the site. The final case, something known as Khori's technique. So see, GBR is predictable if you are taking care of all the clinical scenario. But there are cases wherein I have to do both vertical and horizontal grafting. Therein, just the membrane, just the graft is not going to work. In this Khori's technique, what we do, from the second site, we are going to harvest the Khori's plate. We will harvest, place it on the side where we are going to place implant, stabilize it with the help of titanium screws, what we use it in bone plates, and then wait at least for 6 to 8 months, then go ahead and do the implant placement. So this technique is literally a technique sensitive Khori's technique. You need to master the bone graft first and then move ahead with surgeries like these, complex surgeries like these. So just enjoy the video. At least you should know the protocol in this case. This is the last video of the day. The important thing is the vertical release of lingual flap. I'll show you the vertical, and I have to release the buccal and lingual flap as much as possible in this case. Yeah. All these surgeries are done by me. So I can tell you what are the major complications and challenges we feel during these surgeries. Now see, it's a split thickness flap what I'm giving. The split thickness incision what I'm giving to raise the flap vertically. Because if I'm doing a vertical augmentation, I need to close it tension free. This is how do we harvest the entire plate from the ramus region. Generally, we go below the premolar, that is the most safest side. And the side where we have retrieved the bone blocks, we just have to cover it up with bone graft. After that, the bone block was approximately 1.5 mm in thickness. We separate it into two plates of less than 1 millimeter each. And then I'm going to attach these plates on the labial side with the help of these screws. So you need to punch. First, you need to check the site. It is going to engage. Then you will punch it first. Like this. And then stabilize the plate. After stabilization, there is a jumping distance. That jumping distance will be covered up with the autograft, remaining autograft, and Xeno or alloplast, whatever, or allograft, whatever you want to place, and then suture the site. Yeah. This is how do we take care of vertical and horizontal augmentation simultaneously. So every ending has a new beginning. It's a learning curve. It's a learning. It's a journey from breaking up to moving on. You can contact me on social media. I'm already available, and I try posting different cases, different ways, different techniques. I do implants, full mouth implants regularly, and try changing the life of patient. Thank you so much once again for your patient hearing. All up to Dr. Ashish now. Thank you.
Thank you, sir, for the very informative and a very amazing lecture, sir.
Thank you so much, Ashish.
Yes.
And I had a question in between. What is the prosthetic material I have used? Can we have some answers by even if someone can type? Is it possible, Ashish? We can have answers.
Yes, sir. Yes, sir. If anyone have any questions, they can ask.
You can ask
They
questions.
can
At the
unmute
meantime, I'm asking a
themselves and they
question.
can ask.
Yeah.
Yes, sir. They can answer.
So
there is
basically,
already an
if you
answer in the chat box.
Okay. If you remember the case I've shown socket shield technique, I have placed a crown and I've even showed you the soft tissue. Which crown material is it? Is it zirconia? Is it Emax? Is it PFM or anything else?
So we have two answers. One is zirconia, then another one is Emax from
Okay.
two, then another one on Emax.
Okay. Should I reveal the answer? It's a screw retained porcelain fused to metal. It was never a metal-free crown. The only thing is that the best part is soft tissue. You need to take care of soft tissue. Prosthetic material is always secondary. So if you are placing implant in the right position, you don't have to spend much on the prosthetic and biomaterial. Everything falls in its place. So in most of the cases, I've used screw retained PFM. Any other questions if any of the participants have? I'll be more than happy to answer.
Any questions? Anyone, you can write in the chat box also. I think so. There is no question, sir.
All right, all right. Thank you so much.
Jasneet, you are presenting so well. Myself, Amit Gupta.
Hi, sir. How are you?
How are you? How are you?
Good.
Jasneet, you are presenting so well. There is no doubt at all.
But sir, I mean, I still believe, we all are beginners. I have, I have my own ways of learning it. So we might have few beginners there because bone graft as a technique is not, day-to-day practice. So things, which we try to simplify that is still, it is sometimes difficult to grasp. So that is why I feel, if the questions are there, nothing better than interactive sessions.
Correct. So that's why the interactive section are more important.
Yes, exactly.
So other than Zoom, Ashish, next time onward, go for the physical conference.
Surely, sir. We are having soon, sir, in
Yes.
Maharashtra.
Yes.
All right. Thank you, Dr. Ashish, for having me. Pleasure meeting you, sir.
Thank you so much. Thank you, Ashish.
Most welcome. Okay.
Thank you so much, sir. The session was extremely informative and engaging. We are confident that everyone has gained valuable and learning from your expertise. We sincerely appreciate the time and effort you have taken to be with us today and share your valuable experience. Thank you so much, sir.
Most welcome. Thank you.
And now we're going to start with our fourth lecture of the day. Dr. Mittal, please introduce our fourth speaker.
We are delighted to continue with our fourth lecture of day 2 on the topic immediate implant placement and immediate loading by Dr. Amit Gupta. Dr. Amit Gupta is serving as professor and head in the Department of Oral and Maxillofacial Surgery at ITS Dental College, Ghaziabad. With his extensive clinical expertise and academic experience, he has made a significant contributions to the field of oral surgery and implant dentistry. His profound knowledge and hands-on experience in advanced implant procedures make him an authority on immediate implant placement and loading protocols. It is truly an honor to have you with us today, sir. We extend a warm welcome and look forward to insightful and enriching session.
Thank you so much, Radhika, for such a nice introduction about me. And thank you, first of all, thank you to all the organizing committee and especially Dr. Ashish to give me this opportunity to present a lecture and on this such a good platform. And the topic which is given to me is actually the two topics combination of one, and immediate implants and immediate loading. And I tried my best to give you some insights and clear your doubts about the immediate implants and the immediate loading. And first of all, so myself, Dr. Amit, is already informed you about the Radhika. Dr. Amit and the professor and head in the Department of Maxillofacial Surgery, ITS Dental College, Ghaziabad. And first of all, the greetings to my workplace. So I passed out from Rajiv Gandhi University of Health Sciences. After that, I was working as assistant professor and senior lecturer in Department of Dental and Oral Surgery, Lady Hardinge Medical College for 5 years. And right now I'm working in this such a beautiful college, the ITS Dental College, and almost 26-year-old college. A few university tie-up. I work with the University of Yonsei, South Korea, and get good exposure there about the their concept regarding the implant and regarding the soft tissue augmentation and the soft tissue management. Recently, I went to the UPenn University for the digital workflow and immediate implant placement. Few mentors from we get few points, the some points, because of all these mentors, I am sitting there and presenting a lecture in front of you. So before starting my topic regarding the immediate implant and the immediate loading, the most of the speaker in last 2 days basically give you the general idea about the implants. What is implant? How you place it? What is the conventional implant placement? What are the criteria? So criteria for the immediate as well as for the conventional implant is almost same, but few criteria we have to learn and see which is different from the conventional implant technique. As per as the definition, I think now you are well versed with the definition. The implant is basically the alloplastic substance which can be partially or completely inserted into the bone, either for the diagnostic purpose or for the prosthetic or for the experiment purpose. Delayed implant placement is basically the implant which is placed in a healed bone. You have a good amount of the bone. It is the buccolingual, mesodistal, as well as the vertical. And in that, we can put a implant. And it is one of the most important criteria that is given by the brain mark, the complete healing of the socket before placement of the implant. But now the more advancement, modernization of the implant dentistry, the concept of immediate implant is more visible nowadays in a practice. The immediate implant placement, as such, the immediate implant placement means you have to remove the tooth from the socket, and in this socket, we have to place an implant. So if we go for the brain mark concept, the brain mark concept is the very old concept. Nowadays, nobody follow the brain mark concept because it will take longer time for the rehabilitation of the patient. Because according to him, first we go for the extraction, then we wait for 4 to 6 months for the healing post-extraction socket. Once there is a good amount of the bone, we have to place the titanium screw inside it. Again, wait for 3 to 6 months for the osseointegration. And once the osseointegration is completed, then we go for the prosthetic rehabilitation. The most of the time, it will take around 1 year to 1.5 years for the complete process. So the Hen et al. In 1980s give another concept that is called as emergency implant. Emergency implant is nothing. It is also called as the immediate implant placement. But there are some criteria given by the Hen for the immediate implant placement. First and most important is the atraumatic extraction. Once you go for the atraumatic extractions by the various means we discussed in the later slides, atraumatic extraction without any undue forces on the buccal side, on the palatal side, or any of the socket wall, you have to remove the tooth. That is the main criteria for the immediate implant placement. That is the first one. Second, once the tooth is removed atraumatically and you get a socket wall all around, then you place an implant in that particular socket. If you get a good amount of primary stability, most of the people, most of the literature said it should be 35 to 45 Newton centimeter for the initial primary stability. If you get this much amount of the stability, then you go for the temporary restoration, but it should be relieved from the occlusion if it is a single implant. And after the 3 months of the final temporary restoration, you can go for the final prosthetic rehabilitation. So this is the new criteria for the implant placement or the immediate implant placement, the atraumatic, then implant placement, then temporary restoration. And after the temporary, after the 4 months, you can go for the final prosthesis. Immediate implant placement, there are a lot of definition given by the Lazara. Then Panarocha, Diagno et al. Give a very good study. If you want to go through the net and read about this article, it is one of the landmark study in which he basically discussed about what are the result or the success rate after the immediate and the non-immediate placement of the implant. And they got around 97.7%. That means the 98% of the success rate they will get after the placement of the immediate implant after the extraction. Then the Swartz in 2000 give again the basically the definition, immediate implant placement in the dental implant socket immediately after the extraction. And it has been considered as the predictable and acceptable procedure because you are going for the immediate rehabilitation of the patient, and patient is happy, patient is satisfied once you remove the tooth and go for the immediate implant placement and temporary restoration. But why we go for the immediate implant placement? There are various advantages over the conventional or the delayed implant placement. The first and most important is decrease e-dangerous patient. Nobody wants in an anterior aesthetic zone without the prosthesis. If you are going for the conventional technique, you have to go for the implant placement first, and then after the 4 months of the implant placement, you have to go for the rehabilitation. But in cases of immediate implant placement, you can give a temporary restoration immediately after placement of the implant. Second, reduce the surgical morbidity. That means you are avoiding the surgery, second surgery also. On the same surgery, you can go for the extraction and you go for the implant placement. But in conventional, you can go for the second surgery also. Once you remove the tooth, then wait for 4 months, 6 months, and then again go for the surgery for the implant placement. Shorter treatment time, as we already discussed, according to the brain mark, it should be 1.5 years. But with the immediate implant placement, we can go and rehabilitate the patient within 4 months. That is very important because it will give the psychological effect to the patient also and patient satisfaction also. Preservation of the soft tissue and the hard tissue. That is again a very important concept because as a dental surgeon, as a postgraduates, or as a senior faculty of the dental departments, we all know once we remove the tooth, there is a physiological process of the resorption on the buccal bone or the palatal, all the bones of the socket. And it is more in buccal side as compared to the lingual side. In the maxilla, it is a centripetal resorption, and in the maxilla, it is a centrifugal resorption. So to prevent that bone resorption, we have to go for the immediate implant placement because it will restore the bone height and as well as the soft tissue draping. And last and not the least, the better patient acceptance and the high satisfaction. These are the few diagrams in which you have see the basically the immediate implant placement with the good soft tissue draping, and then the lower one, this is a diagram. If you place an implant immediately, it will restore the buccal and the lingual width, palatal width, as well as the mesodistal dimension. But if we remove the tooth and wait for the second stage surgery, if you see there is a conical defect on the buccal side because it is a physiological process of the bone and it will resorb and decrease the width of the bone. And in the second stage surgery, it is sometimes very difficult to place implant because the buccal bone is very, very thin. So the immediate implant placement, then definitely advantages over the conventional implant in cases of buccal bone preservation. Some of the disadvantage, because it is the more technique sensitive, because before going for the immediate implant placement, this is my advice. First, you go with the conventional implant. Once you confident with the conventional implant, because in conventional implant, you have a good amount of bone, you have a good amount of soft tissue drape. So once you place an implant in a conventional bone perfectly, then you start doing your immediate implant placement with all the doubts clear. Second, in the presence of acute and the chronic pathology, if you are not able to justify or you are not able to identify there is a pathology below the apex and you are not curated out, it will go into the failure. And the last one is the anatomical limitation. Sometimes it is a disadvantage for the immediate implant placement because in I think there is a lecture on the anatomical consideration of the maxilla and the mandible related to the implant, and that lecture will give you the idea about why the anatomical structure are very, very important before placing an implant. So if you know the maxilla, in the maxilla anteriorly there is a nasal floor, posteriorly it is a maxillary sinus, and the mandible there is a mandibular foramen and the inferior abdominal canal. These anatomical structure are very, very important before placing an immediate implant because in cases of immediate implant, most of the time the apex is very, very near to the vital structure. So always evaluate the socket first, evaluate the vertical height first, evaluate the width first before going for the any implant placement. This is the soft tissue. If you are not completely cured the socket and place an implant, this type of pathology, it will go into the failure. This is the limitation for the immediate implant placement. If you place an implant near to the nasal cavity, it is very painful for the patient because the nasal floor is lifted up. A patient is always complaining of pain near to the nostril or the canine area. Second, if it is close to the maxillary sinus, this is the maxillary sinus, if you see here, the roots are very close to the floor of the maxillary sinus. In these cases, you are not able to put immediate implant because you are directly perforated the indirect sinus membrane and there is no bone support. So it will go into the failure. And the last one, if you see here, it is the the implant is very close. If you are going to a drill and it is very near to the inferior alveolar canal, and if you are intentionally injure the inferior alveolar canal or near to the mental foramen, it is very cumbersome for the patient, and patient will have lot of pain, and the sometimes the paresthesia is also present if you are placing implant very near to the anatomical structure. So that's why there are in conventional implant also we have learned it should be always away 2 mm away from the vital structure. So that means whenever you're going for the implant placement in the immediate cases, you have minimum 12 mm of the bone for placing a 10 mm of length implant. That means it is 2 mm away from the vital structure. Come to the indication given by the Kant in 1991. Most of the time, if you see the cases of immediate implant are mostly traumatic injury. Traumatic injury may be because of the fall, maybe because of the interpersonal violence, maybe because of the trauma. It may these type of patient will comes to you for the immediate implant placement because sometimes the root tooth is fractured below the CJ and it is not restorable with the post and core also. So non-restorable traumatic tooth are the main case for the immediate implant placement. The second is grossly decayed non-restorable asymptomatic tooth. That means the tooth which are not restorable and there is no sign and symptoms, but it is coming into a aesthetic area, or it is not able to go for the functional loading, no role in a functional management. Horizontal and the vertical root fracture, periodontally compromised tooth, like in this case, this is the vertical fracture. If you're going for the RCT and not able to put a crown over it, there are after the some time it will go for the vertical fracture or the horizontal fracture, traumatic injury. Deciduous tooth, if there is a presence of the deciduous tooth, then definitely we go for the immediate implant placement. Periodontally compromised tooth, if the tooth is mobile and there is a good amount of the bone and good amount of the soft tissue draping, then again we go for the immediate implant placement. Contraindication, any acute infection or the chronic infection which is not subside, then it will not a case of immediate implant placement. Large osseous defect, that means Dr. Jasneet is already discussed about the different type of walls defect, 4-wall defect, 3-wall defect, 2-wall and the 1-wall defect. The most ideal, according to me, there is a different classification of wall defects I discussed in the later, but the 4-wall defect or the 5-wall defect are the ideal cases for the immediate implant placement. If the wall defects are 3, 2 and 1, these are not ideal cases for immediate implant placement. In these type of cases, you have to go for the augmentation first and then go for the delayed implant placement. Third is the lack of adequate bone apical to the socket. Because if you know about the implant dentistry, in the conventional, we have a good amount of bone. But in cases of immediate implant placement, we can get stability and especially the primary stability from below from the socket. That means apical to the socket. So minimum 3 to 4 of the bone you have below the extraction socket for the primary stability. If it is not there, it is not a case for immediate implant placement. Adverse location of the mandibular or the neurovascular bundle, again it is an anatomical limitation, and unfavorable dimension of the socket. If the socket is having not a good amount of the bone or interradicular bone in cases of the mandibular molars or the maxillary molar, then again it is not a good case for immediate implant placement. Come to the requirement for immediate implant placement. As in conventional implant dentistry, same in a immediate implant placement also, we have to need the evaluate the patient clinically as well as the radiographically, because the every case is not a case for immediate implant placement. The first requirement is the CBCT evaluation. The CBCT evaluation, you all know now, the CBCT is a gold standard for any of the procedure in implant dentistry, because it will give you the three-dimensional picture. Three-dimensional picture means it will give you the vertical height, it will give you the width, it will give you the depth. So all the 3 dimension you can get, and also along with that you can find out, especially in the immediate implant cases, how much is the buccal bone over the tooth, how much is the bone available apical to the apex of the tooth, and how much is the thickness of the palatal or the lingual bone. So this will give you the idea about how much bone we have available after the atraumatic extraction of the tooth. And second, how much the size, diameter, and the length of the implant we have required in this particular case. Second is the aesthetic risk evaluation. Again, the Dr. Jasneet give you the idea about that. Before putting any implant, you have to go about the aesthetic, especially in the anterior aesthetic zone. You have to find out the smile line of the patient, how much is the soft tissue draping, either it is the recession is there or not. Then there is acute infection is there, gingivitis is there or not. You have to soft tissue draping, adjacent tooth shade is stable and free of large restoration. It should be clear of all these things, and then you go for the immediate implant placement. Second, the as we know nowadays the implant dentistry is going in a retrospective direction, because implant success rate is depend on the prosthetic rehabilitation. So your implant selection and evaluation is based on the prosthetic rehabilitation. So you always go and discuss the prosthetic rehabilitation first before placing implant. So that means the retrospective evaluation is very, very important nowadays. Your implant should be prosthetic driven, not a surgical or the periodontal driven implant you have to place. You have to place implant according to the prosthetic department, because if the prosthetic is good and prosthetic is going along with the implant placement, your implant success will be more. If it is not, then implant failure will be more. Fourth, the primary stability of the implant. As already discussed in all the literature, if you achieve a 35 to 45 Newton per centimeter stability during the implant placement, it is good for the temporary restoration or the temporary crown placement. Last is the if above criteria is not satisfactory, if their CBCT evaluation is not giving the good idea, aesthetic evaluation is not good, ideal location of the prosthetic is not achieved, and the primary stability is not achieved, if it is less than 35, then you abandon the procedure and go for the augmentation. Clinical requirements. The clinical requirement again, absence of active infection for in cases of immediate implant, atraumatic extraction, preservation of the labial and the buccal wall is very, very important in cases of immediate implant. So that's why you have good clinical acumen or good clinical skill for the extraction of the tooth. Good mechanical anchorage, primary stability, use of appropriate implant design is again important, because I think it is already discussed various implant design and various surface, various threads. Some are sharp, some are square shape, then triangular. I think it is discussed in the previous lectures also, so I'm not discussing again. The surface, either it is a single edge or the double edge to increase the surface area or to increase the bone implant contact, and the proper implant position in terms of angulation and the position is very important for the success of implant. Now we come to that not all the extraction site lend themselves to immediate implant placement, because if above set criteria are not matched, then it is not a good case for the immediate implant placement. So basically with the literature, the extraction socket is divided into the three types. The first is the type 1. In this, if you see, the site is, this is the site of extraction. If you once after the extraction of the tooth, this is the tooth is extracted, we have a good amount of the bone on the buccal side and the palatal side, and the soft tissue draping is also good. So these cases are called as type 1, in which the bone as well as the soft tissue having a normal contour and architecture. So in these type of cases, having good regenerative potential and no grafting or no other adjunct is required in these type of cases, and these are called as the ideal cases for the immediate implant placement, because the aesthetically as well as the functionally, these are the very good cases. Type 2, if you see in the diagram again, if you see here, this is the site of the extraction socket and there is a discence. In the type 2, there is a discence. If this discence on the buccal side, if it is 3 to 5 mm, then again we go for the immediate implant placement, but with the help of GBR, the guided bone regeneration. Dr. Kala discussed about that, how we go for the GBR. Either we put a genograft or the mix with the autogenous of the genograft with stabilized with the membrane or the membrane tag. The most of the time, the graft material we choose, always which are resorbed slowly. So autogenous graft are resolved very quickly. That's why nowadays we are using the genograft more as compared to the allograft and the autogenous graft, or we use in a combination graft, autogenous with the genograft. It should be stay for at least for the 6 to 1 year for the proper bone formation around the exposed implant. In the type 3, these are the severely compromised environment. This is a basically 3 to 4 wall defect. And these type of cases, we are not able to go for the immediate implant placement. These are the cases for the bone augmentation and the conventional implant placement. Another classification given by the Allen et al. And according to the socket, the first is, if you see here, it is almost same like a previous classification. If you see, the bone level is at the CEJ level and the soft tissue is covered above the CEJ. So these are the cases which are ideal for the immediate implant placement. In the second case, if the defect is on the buccal side 3 to 5 mm and soft tissue is covered till the or above the CEJ, then again it is a case of immediate implant placement, but with the help of GBR. And C, the category C is again both the bone and the soft tissue are going below the palatal side. The level of the bone and the soft tissue is well below the palatal side. These are not a good cases for immediate implant placement. In these cases, we have to go for the bone augmentation first, because the soft tissue or the vertical augmentation is always difficult as compared to the horizontal augmentation. Then the treatment planning consideration, in cases of immediate, the bone available is already discussed about that. If you have a good amount of the bone, the apex of the tooth, then this is the case for immediate implant placement. Because if you see the first CBCT section, we have a good amount of the buccal bone, we have a good amount of the palatal bone, as well as the apical bone below the apex of the tooth. So this type of cases, we will get a primary stability from this bone. Okay. In the second CBCT, if you see, this is the sinus and the apex is very near to the sinus. So where we get a primary stability, because there is no bone available below the apex of the tooth, and the tooth is very wider. This type of wider implant we are not able to put, because we have a limited wider implant available in the market till 5 or 6 mm of the wider implant, but we are not able to put so much wider implant to get a primary stability from the palatal or the buccal side of the bone. So in these cases, we have to go for the augmentation first, or we go for the augmentation first and then we go for the implant placement. For example, in this third CPCT, this is the mandible, and the mandible, this is the mandibular foramen or inferior alveolar canal. In this case, again, we go for the immediate implant placement because we have a good amount of the bone below the apex. So this is the case for immediate implant placement because we get a primary stability below the apex. But if you see this CBCT, the apex of the tooth is very, very close to the mantle foramen. So this is not a good case for the immediate implant placement. So you always evaluate with the help of the CBCT how much bone we have, and according to that, you can plan out for the immediate implant. Bone width, again, bone width, we already discussed the buccal and the palatal width. If the bone is good on the buccal and the palatal side, according to that, we can find out the width and the length of the implant, because we have to put implant in immediate cases more palatally, not more buccally. If you put your implant buccally, it will perforate the buccal side, and as we know, the physiological resorption is more on the buccal side. So your implant should be slightly palatally as compared to the buccal in cases of immediate implant. In bone length, you already know about that. In the conventional implant, basically, this is the criteria. If you are placing an implant adjacent to the tooth, the distance between the implant surface and the tooth surface is minimum 1.5. Why it is 1.5? There are two reasons. One is infection control, because if there is any infection in the periodontal space, so according to the literature, it will go till the 1 mm or 1.2 mm. It will not cross that distance. So the minimum distance between the implant and the tooth surface should be 1.5. And between the two implant, it should be 3 mm. Why it should be 3 mm? Because if you are putting implant too close, there are micro fracture during the thread, or there are chances of more microfracture in the bone, and that will cause the necrosis of the bone, and there is no osseointegration around the implant, and it will go into the failure. So it should be normal. It should be 3 mm between the implant and 1.5 mm in between the adjacent tooth and the implant surface. Bone angulation, the initial bone angulation represents the natural tooth root trajectory. That's why we are using more endosseous implant or the tooth form implant or the root form implant, because it will give the same representation like the natural tooth root. Second, your implant placement should be perpendicular to the plane of occlusion. That it means, or it suggests that all the occlusal forces from the crown, it should be go along the parallel to the long axis of the tooth. So all the forces are distributed evenly, and there are less chances of marginal resorption as well as the less chances of force concentration on the one point. So your implant should be perpendicular to the plane of occlusion, which align with the force of occlusion and is parallel to the long axis of the prosthetic rehabilitation. It is a very important point. Second point is it will follow the Wilson's curve of Wilson and curve of Spee. If you see here, the curve of Wilson, if you remember the prosthetic part, your upper crowns are slightly buccally inclined and the lower crown are lingually inclined. On the same way, your implant placement is either straight or it is slightly palatal. And so your crown should be coming slightly buccally inclination and the lower crown should come slightly lingual inclination. So it will give a better occlusal forces, and it will reduce the force concentration on the one point. Second, it should always follow the curve of Spee. If you see here, the curve of Spee, basically the spine line, and all the implants should be follow the central fossa. So it should be on the either on the central crest or slightly lingual to follow the curve of Spee. Bone density is another important feature in cases of immediate implant placement. As we all know, we have a 4 type of a bone in a maxilla and the mandible. It is designated as a D1 to D4. D1 bone is a more corticated bone. And if you see the house fill unit here, it is more than 1250 house fill unit. That means in the anterior mandible, we have a lot of cortical bone and less amount of medullary bone. So once you place an implant in these type of a bone, you will get a good amount of primary stability, and you can give a temporization or the primary provalization in these type of implant placement very easily. So, if you see the D4 bone is the thin trabecular bone, and the house fill unit is only 150 to 350. And most of the time, this type of bone present in the posterior maxilla. The posterior maxilla is the main area of the failure of the implant because the bone is more porous. Second, because of the pneumatization of the sinus, the bone availability is also less. So these type of area having a more chances of implant failure, and these areas we are avoid to give a primary or the temporary restoration immediately after the implant placement. Or to overcome this, nowadays we have a various technique. I think Dr. Jesse already discussed about the osteodensification. So in these type of the bone, we have used osteodensification teeth or the lateral compaction technique with the osteotome to increase the density of the bone or the compaction of the bone. So we will get a primary stability during the implant placement. The next one is the buccal bone thickness. As we already discussed, the buccal bone is thinner than the lingual, and it is usually compromised during the extraction. So the atraumatic extraction is needed in cases of immediate implant placement. Second thing, if you remember the anatomy, the socket will get the blood supply from the 3 parts. One is the periodontal ligament or the blood vessels, because the tooth is attached with the periodontal ligament and there is their own blood supply. And the 20% of the socket supply is through the periodontal ligament. Second is the periosteal blood supply. It is the external supply of the bone. Everybody knows over the bone there is a periosteum, and these periosteum is supplied by the periosteal blood vessels. And this is the supply for the bone from the outside. And third is the bone, the blood, which is supplied by the internal or by the intrinsic pathway, or that is the alveolar bone blood vessels that is inside the bone. So these 3 are basically nourish the bone before the extraction. But once you go for the extraction, first of all, the periodontal ligament blood vessel supply is gone. That means the 20% of the blood supply is gone. Then during the extraction, you are reflecting the flap. So that will again compromise the bone. So 40% of the blood supply by the periosteum. So 40% again, once you reflect the flap, it will gone. So that means the 60% of the blood supply will go on after the tooth extraction if it is not handling it properly. This is the reason why the thin biotype and the thin buccal bone will always have a failure, more resorption, because the blood supply is gone after the tooth extraction. Now we come to the immediate implant placement technique. The first we discussed already, the clinical and the radiographical feature. Once you evaluate the CBCT, then the defect, what is the type of defect, how many walls are present. Then you carefully evaluate the buccal and the lingual wall after the extraction with the periodontal probe, evaluate the mobility and all these factors. Then we go for the atraumatic tooth extraction. So once the patient is selected for the immediate implant after the CBCT and the clinical evaluation, the second step is atraumatic extraction. Now there are umpteen number of techniques which are available in the literature for the atraumatic extraction, but the most commonly is to preserve the soft tissue draping and the buccal and the lingual wall or the all the wall of the socket. The basic criteria is that. So first, we use the scalpel blade. If you are going for the atraumatic extraction, the scalpel blade we just use to break the fibers around the tooth structure. So it is a clavicular incision which are giving around the tooth from the mesial side or the palatal side of the buccal and the distal side all around the tooth to separate the periodontal fiber. And then we try to remove the tooth either with the periotomes or with the atraumatic condition. Second, if the tooth is wider, if you see there is a molar tooth is very difficult to extract in toto. So we have to separate the roots. In cases of maxilla, we have to divide it into three parts because we have three roots, the mesial, buccal, and the palatal. So we give a T-shaped incision or the T-shaped cut in the maxillary area, and then we remove the buccal bone separately, mesial root separately, the distal root separately, and the palatal root separately. And then the third one, we remove that bone without disturbing the blood supply and the bone supply or the bone of the buccal and the lingual side. Periotomes, everybody knows, I think, about the periotomes. The periotomes are very thin. It is a blade-like structure, and we are just putting in the periodontal space. According to the wedge principle, it will expand the socket, it will break the fibers, and the tooth will come out very easily. Once the fibers are break, then you can use a forceps to just mobilize the tooth or just to remove the tooth without any pressure on the buccal and the palatal sides. Luxators again having the same function. Again, these are the fine instruments inserted into the periodontal space. These are coming in the various number with the fine tips and the broad tips. And according to that, we can use with the angulation. If you are going most posteriorly, then you use the angulated luxator. If you are in the anterior area, then you use a straight luxators. Thus, the lifting the tooth out of the socket, once you break the periodontal fiber, it will lose the tooth and then it will coming out. The next is the use of the conventional forceps. The conventional forceps is only used for the delivery of the tooth. Once the tooth is loose with the help of the periotomes or the luxator, then you just hold the tooth and rotate it and pull it out. Don't put any pressure on the buccal and the lingual side. Next thing is physics forceps. I think always all of you are heard about that, the physics forceps. It will be basically having a buccal bumper. So these buccal bumper are placing on the buccal side, and with the help of that, the one of the side is going on the palatal side, and then we put a buccal pressure we give a pressure on the palatal side, and tooth will be delivered without doing any trauma to the buccal tooth. Other than that, there is one more treatment modalities nowadays, the use of magnetic mallet in cases of atraumatic extraction. I'm not able to put that diagram. So magnetic mallet is also again function as the same like a luxators or the periotome, but it is a electrical driven thing. So electrical energy will convert it into the mechanical one. And again, it will expand the socket, break the fibers, and tooth will deliver without causing any trauma to any of the wall of the socket. The next thing is evaluating the anatomy. Again, in the case of molar, if you see there, the molar having two roots, again, we separating the two roots and then deliver the mesial and the distal root separately without causing any trauma to adjacent structure. The most common step in immediate implant placement is the curating the extraction socket, because we already discussed if there is any pathology behind after the extraction of the socket, extraction of the tooth, it will go and lead to the implant failure. Curating the extraction socket is very important. Why? To remove the remnant of the periodontal ligament, the bacteria residual infection, if there is any granuloma is there, any pathology is presented there, dental material, sometimes because it is the RCT treated tooth, maybe the gutta percha is there, sometimes the tooth fragment is there after the extraction. So all these are basically hamper the osseointegration process after the implant placement. So we have to clear it very dedicatedly. Then curating the extraction socket with the serrated curate or the spoon. And why we use the serrated? Because the serrated spoon or the curate basically create a bleeding point inside the socket, and these bleeding point are basically responsible for the faster healing and faster osseointegration once you place an implant inside it. Fourth is evaluating the extraction socket for the remaining walls. With the help of the probe, you have to check it, all the walls. You check either you feel on the buccal side the probe is going in the soft tissue or you have a bone inside it. Once you identify that, then you're going for the implant placement. So I search in the literature, the classification of the bony defect is given like the 5 wall defect. According to this immediate implant placement, the 5th wall is the apical part. There is the buccal, lingual, mesial, and the distant, and the apical, because in cases of immediate implant, we need a bone apical to the extraction socket. So that's why the 5 wall extraction socket is ideal for the immediate implant placement. The 4 wall having a thin buccal wall, or there is a dissense on the buccal wall. In that particular case, we can go for the immediate implant placement, but after the along with that GBR and the bone graft and the membrane placement. So this is the basically the treatment chart in which cases we are going for the immediate implant placement. The first, no treatment. That means if the extraction socket having a 1 wall, 2 wall, or the 3 wall defect. If it is a 4 wall defect, then along with the bone grafting, we go and go for the immediate implant placement. And the last one is the immediate implant placement if there is a no bony defect and it is the ideal case for immediate implant placement. Flap design. Now there are a lot of studies are going on the flaps. There are mostly we are using a 3 type of flap design. One is flapless, because you are removing a socket, we're removing the tooth from the socket, and there is a good amount of the soft tissue draping around it. So you can directly put an immediate implant there and close it if it is possible. Second, minimal flap reflection, because sometimes we have to find out the buccal and the palatal or the lingual side of the bone, what are the margins of the bone. In that particular case, either you give a U-shaped incision, you can give a crestal incision, and minimal exposure till the buccal edge or the palatal edge of the bone, and then you have to place the implant, because minimal flap exposure also preserve the blood supply on the buccal and the palatal side of the bone, because you are not stripping the periosteum too much. But in cases of the open flap, if there is no wall on the buccal side, you have to open it up, because in these cases, you have to go for the bone augmentation also. You have to go for the advancement of the flap also for the primary closure. So in these type of cases, you have to give 2 releasing incision, or in a layman term, we can say there is a 4 wall flap or the trapezoidal flap. There are 2 releasing incision on the adjacent side of the tooth structure and 1 crestal incision. You open up the flap till the defect, curate it well. If there is a deficiency of 3 to 5 then you go for the immediate implant placement. If it is more than that, you abandon the process, go for the augmentation, go for the membrane and close it back, and then you place the implant after 4 to 5 months. Implant osteotomy. Nowadays, digitalization is more going into the implant practice, and I think Dr. Gaurav sir will take a lecture regarding the digital implant dentistry. So I am not putting more focus on the digital implant. Most of the time, most of the dental surgeon, most of the implant placement are going freehand, especially if you are placing an implant as a single. If you are placing an implant for the full mouth rehabilitation, definitely these guides are very, very important. These guides are very important in cases where you have put an implant very precisely in a very precise location, in a very precise angulation. Then you go for the digital dentistry, digitalization, or the custom made tooth supported guide. But if you have a good amount of exposure, you have a good buccal and the lingual side of the bone, you have a good mesodistal distance, you can go freehand implant placement also. So this is the first diagram which is showing the digital implant placement with the splint, because this is the tooth bone, it will get support from the tooth, and this is the site for the implant placement. You can directly go inside it and place an implant. This is the freehand implant placement. You expose the socket and implant placement in a good angulation for the better prosthetic rehabilitation. Next thing is heat generation. Always remember whenever you put implant, either it is a conventional or the immediate, because in immediate cases we have a very limited amount of the bone. If you generate more heat and the heat is more than cross the 60 temperature of 60 or 70 degrees centigrade, there are more chances of thermal necrosis of the bone. It will hamper the osseointegration and your implant will be going into the failure. So to prevent that, we have to go the copious amount of the irrigation during the drilling. Second, your drilling should be go in a pumping motion. It not go straight and you doing a drilling. You have go up and down. So the irrigation will go inside the osteotomy and remove all the debris, and it will also decrease the heat inside the osteotomy site. So always use, if it is possible, use a normal saline, normal temperature saline, or the cold saline during the osteotomy preparation. Second, the perforation of the membrane, perforation on the buccal side, because we know the buccal side is more thin. You always put one finger on the buccal side during the osteotomy. If the osteotomy is going palate more buccally, you feel on the buccal side the vibration of the drill. So in that particular case, you avoid it, you stop your procedure and put your drill towards more palatally. Ideal depth of the implant, it should be already discussed, Dr. Kalra. It should be 3 to 4 mm below the free gingival margin for the better aesthetic. Um, uh, jumping distance, this is called as the jumping distance because the socket is wider and we are putting implant less than the diameter. And most of the time, this implant is going on the palatal side. So this is the distance which is from the implant surface and on the buccal side of the bone. This distance is called as jumping distance. If this distance is more than 2 mm, then you go for the grafting. Why you go for the grafting? Because it make the contact between the implant surface and the buccal surface, and it help in the new bone formation after some time, because these type of graft are basically stand there and make a scaffold around the implant surface, and basically responsible for the new bone formation, because these type of bone xenograft and all these type of graft having a slow resorption power. So with that time, these bone graft are resorbed, and these bone graft, instead of these graft, the new bone formation around the implant, and it will give the good bone thickness on the buccal side of the implant. A Linderman drill. This is very important in cases of immediate implant, especially in during the osteotomy, because these drills having a lateral cutting edge. Other drill in the implant system or the implant kit are the either it is a round burr or it is a pilot drill. These cutting are at the apex. So in the molar region, if you see, if you remove the tooth, there is an interradicular bone. It is triangular is above and base is wider. So once you put a drill over that, it will slip out. So these drills are basically putting a groove on the plan osteocyte. Once the groove is formed, then you go through that and put your make your osteotomy wider and place the implant. Second, if you want to change the osteotomy side, because once you start doing the osteotomy with the normal conventional kit or the normal conventional drill, it will follow the path of the extraction socket. But if you follow the path of extraction socket, you are not getting a good amount of the native bone for the primary stability. So these drills are basically help to change the osteotomy site, especially in cases of the anterior aesthetic zone, where you put your implant slightly more palatally as compared to the buccally. So these drills are very important in that. Maxillary anterior position. This is the basically the 3D section of the CPCT. If you see here, there are 3 dots. Okay, the first dot is osteotomy should be initiated within the palatal wall. Why I am putting the my osteotomy in the palatal wall? Because I want more native bone, and that is, if you see the most of the tooth are inclined buccally. The buccal side of the bone is very thin. If you are putting your implant on position in this position, you definitely perforate the implant on the buccal side. So we are putting implant on the palatally side, and once you start drilling, and slightly inclination on the buccal side. So your implant apex is more on the palatal side, and coronal section is slightly 10 to 12 degree on the facial side or the buccal side. So this will give you the good emergence profile once you rehabilitate it with the prosthetic component. Minimum torque should be 35 to 45 mm for the immediate loading and for the primary stability. Taper versus parallel. The taper implant is always better as compared to the palatal for the parallel because these are the root forming implants. Implant surface should be roughened for the increase the surface area, and it will provide the good osseointegration after the 6 month of the implant placement. Implant stability, you can check with the various tests. The percussion. For the percussion, it is a very sensitive and a specific test. Once you place an implant with the help of the back end of the mirror, you can percuss it. If you have a high pitched sound, that means the primary stability is good. If there is a dull sound, that means the primary stability is not good. Then perio test. This is again one of the instrument used in the perio for the check the stability of the implant. And if it is basically give the inconsistent results because of the variation, because of the saliva contamination in the mouth, because of the soft tissue touching. So the best technique for the implant stability to check is the wrench ratchet. If you get a 35 to 45 Newton centimeter of the stability, it is a good primary stability. Second, the resonance frequency analysis. It is based on the piezo mechanism. If the radio frequency analysis is more than 60 or 70, that means the primary stability is very, very good. This is the resonance frequency analysis. If it is more than 75 or 70, you can immediately load this implant. That is not a problem. Gingival membrane of the graft. If the grafting of the jumping distance is more than 2 centimeter, you can put a graft there, either the genograft or the combination of the graft, and put a membrane over there to prevent the migration of the bone graft material into the soft tissue. Second, the closer. Closer is again a very difficult in cases of the primary immediate implant placement if you are not reflecting the flap, because if you imagine the molar and you are placing an implant inside it, the primary closure is very difficult until and unless you reflect the flap and advance it and close it back. So in these type of cases, we are either going for the primary closure if you are not immediate loading. Second, you can put a collar plug over it and suture it back. Second, you can put a wide gingival former into over the implant. It will cover the whole socket. And the last is the new technique that is called as the socket sealing abutment technique. In this technique, basically what we do, we put an immediate implant inside the bone, and over that we can put abutment, and around the abutment we are flow the composite and light cure it. So it will basically give the good emergence profile. It will make the patency of the socket and the soft tissue draping. So after the 3 months, once you remove this abutment, it will give you the good emergence profile for the final prosthesis. After so many discussion, you can ask this, "Are tum kya kehna chahte ho itni der se?" So I want to say the implant is not a machine. Implant is basically it is basically a device, not a device. It is a alloplastic material which can replace the function that will be lost by the missing of the tooth. It can give a good functional aesthetic, give the aesthetic look if it is missing in the anterior zone, and also it will give the good psychological and the patient satisfaction after its placement. But we need a proper clinical acumen and the radiographical evaluation before placing an implant in a cases of immediate. This is the summary where we go for the osteotomy for the maxillary, more lingually, and then for the molars, we are going in the lingual socket or the interradicular bone. Most of the time, you have to place your implant centrally or slightly lingually or slightly palatally. After this this discussion or this explanation, most of the people who are putting the implant will said we are a best implant placement or we are going for the more than 1,000 implant and all this thing, and he think like we are अंग्रेजों के जमाने के jailer हैं. But the complication will occur in and out. Either you are placing a very good implant, the complications are not maybe coming once a while in the time. So, and during that time, we are like Sanjeev Kumar of the Sholay. We have no hands. What we do? So, for the complication, we have to discuss how to manage it. It is already discussed by, I think, Dr. discussed about the various complications. I just rushed through it. The recession. In the recession, basically, we have to go for the soft tissue grafting. If the poor quality of the bone is there, we have to pack the graft, or we use the osteodensification. If there is a overheating of the bone because of the surgical trauma, should be avoided with the irrigation. Infection is there, you have to curate the socket. If there is an anatomical violation of the structure, minimum 3 to 5 mm of the bone we have to need below the socket. Penetration of the discence, we are going for the putting the membrane. Implant stability is always good in the cortical bone. Remember, if the bone is non-corticated, more medullary, the implant stability is not good. You have to go for the second stage surgery. Malpositioning of the implant is that going into the failure because the forces are not going along the long axis of the implant, and it will go for the failure. And anesthetic outcome, if you contour healing abutment, basically in immediate cases we have to go for the immediate temporary restoration to give a good emergence profile and a good aesthetic. This is the case. This is the case. If you see, it is a periodontally compromised case, upper and the lower. So we are planning to we go for the all the tooth. We have to remove it. Atraumatic extraction was done, and then both the arches are flat with the Lindemann burr or with the help of the acrylic burr. And then we are place the implant and try to place implant freehand. And this is the post-op OPG. If you see, we are putting a 6 implant in a upper and 6 implant in the lower. That is the basic criteria for the full mouth rehabilitation if you want to go for the immediate loading. Second, we come to the immediate loading. Immediate loading, as we already discussed, the artificial crown is attached to the implant within 44 hours or within 2 weeks of the implant placement. That is called as immediate loading. This is the diagram in which you see there is an implant placement, and then we give a temporary restoration or the final restoration to the patient immediately within the 2 weeks. Immediate loading, if the implant is functional, implant in function within 2 weeks after their placement, the no distinction was made between the occlusion and the non-occlusion loading. Early loading, if you put a functional loading between the 2 weeks to 2 months after the placement, and conventional loading if you are placing or giving a prosthetic rehabilitation after the 3 to 6 months. So these are basically 3 loading protocol: immediate, early, and the conventional. Various imaging loading protocols is also available in the literature. Immediate functional loading, there is called as the direct occlusion loading, and these type of loading we are going in a full mouth rehabilitation. Please remember, functional loading is always going in a full mouth rehabilitation cases. For example, the all in 4 cases, all in 6 cases, gygoma cases, or the pterygoid implant cases. It is never going into the partial edentulous patient or the single implant cases. Immediate non-functional loading protocol, indirect occlusal protocol, where the restoration make no direct contact for the opposing dentition. So it is basically we are doing in cases of single tooth rehabilitation. For example, in the aesthetic upper maxillary, if you want to put a immediate implant, over that we have to give a crown or the provisional crown for the aesthetic purpose, not for the occlusal purpose. So there is no occlusal contact at the anterior zone, and this is called as immediate non-functional loading protocol. Then progressive loading, especially these type of loading protocol we are using in the posterior mandible or the maxilla for the molars. In these cases, what we do, we are putting an implant, and over that we are putting a temporary crown that is not under the contact. And then with time, we are gradually increasing the occlusal surface, and within 3 years, we are complete the occlusal contact. So this is called as progressive loading of the molars. Early loading protocol, the implant is restored into the function or the non-functional from the 4 to 3 weeks of the post-surgical phase. Why we doing so? Why we going for the implant immediate loading? It is depend on this curve. I think this is already discussed in some of the lecture. The implant stability. The primary stability of the implant is basically coming through the mechanical stability because of the bone, what type of bone it is. If it is a more cortical bone, you will get a more primary stability than the design of the implant and also the surface of the implant. So this stability is called as the mechanical stability, and we will get a good amount of the mechanical stability in cases of D1 bone with the square thread implant and the threaded implant or the conical implant. We will get a primary stability. So if you see this graph, there is a time and the stability. If you see here, initially once we place an implant, we have a good amount of the primary stability, but it will go down and drip once the time is going on. So this mechanical stability is very less within 1 month. So after the 4 week of the implant placement, the primary mechanical stability is very, very less. So in this time period, within the 4 to 6 week of the time, never load your implant. Okay, because there is a more osteoclastic activity, more the bone resorption is going on, and less osteoblastic activity, and this will lead to the failure of your implant. So your implant should be load temporary before 3 weeks, or then after the 3 months, not in between. If you see the orange line here, the biological stability, the biological stability means the healing of the natural healing of the bone surrounding the implant, that is also called as the osseointegration. So with time this stability will increase, and this stability is maximum within the 2 month or more than 2 months of the implant placement. So the implant, the final prosthesis is always placed after the 2 or 3 months of the implant placement. This is the functional loading. Again, this is the repetition. Then the concept of the implant stability quotient. If the ISQ value is more than 70, always go for the immediate loading. And if it is less than 60, never take a chance and go for the delayed loading. Benefits of immediate loading: faster treatment time, because patient can have their new teeth within 1 or 2 days or within 2 weeks. Improve aesthetic if it is specifically in the anterior zone. Reduce number of the procedure, because we are doing the prosthetic rehabilitation or the temporary restoration in the same sitting, so there is a reduced number of appointments. Then no second stage surgery is required in cases of immediate loading. Then soft tissue, and the soft tissue draping is also good, and it will give you the good emergence profile if you give if you load the implant immediately, because it will prevent the soft tissue recession once you give a temporary restoration. Disadvantage of the non-functional immediate implant placement is because there is a micro movement of the implant that can be loss of the failure. If the more micro movement between the implant and the bone surface, there are higher chances of the failure. Second, if you are not close the implant properly, or there is no primary closure is there, the most of the time there are sometimes there is a food lodgement, there infection will go into the implant side, and then it is one of the cause for the implant failure. Second, the parafunctional habit. If the parafunctional habits are more, then are more chances of implant failure, because there are more eccentric and the lateral forces are putting on the implant or the abutment. This will lead to the implant failure. Second is the require careful patient selection is very, very important in case of immediate implant and immediate loading. If the patient is smoker, patient having a bone disease, patient is not follow the instruction, then these are the patient which having a higher failure rate of the implant. And if there is no feasibility of the implant placement, don't go and do your heroic work. And please try to understand, if it is not fit into the criteria of immediate implant placement, don't go for the immediate implant placement and the loading. And then you abandon the procedure and go for the delay implant placement. This is one of the case. If you see there is a good amount of the soft tissue draping. We put a gingival former there. After the gingival former, we take an impression. Then we put a this the prosthesis, and this is the progressive loading prosthesis. First, we give a prosthesis without occlusion, and then later on we give a occlusion in the occlusal contact with the adjacent tooth. Immediate loading when it is feasible. Definitely, in the cases of anterior teeth, can we give immediate loading for the sentinel and the latent incisors successfully with certain precaution. We are avoid the contact with the adjacent tooth or the opposite tooth. Do not use it with the canine. It is always remember, if it is a single canine tooth replacement, don't go for the immediate loading, because it will go for the failure, because you are very difficult to control the lateral forces of the canine during the movement, during the mastication or during the other movements. And in cases of the posterior teeth, I'm not recommended. It is my personal experience. I'm not recommended the immediate loading with the contact, because there are higher occlusal forces which are going on the implant surface, and there is very limited the laminar bone formation. Basically, take at least 3 to 6 months for the proper laminar bone formation around the implant. If you are putting an implant, posterior implant under the occlusion, the heavy forces may concentrated on the one interface of the implant and the bone, and it will lead to the implant failure. Primary guidelines given by the Turnow: the maximum immediate loading should be attempted in the edentulous cases where you are putting multiple implants. Please, this thing you record in your mind. Immediate loading is always for the edentulous cases in which you are putting a maximum number of implant. Implant should be at least 10 mm long. Never do immediate loading on the short implant or the implant which are less than 10 to 8 mm of the size. Then diagnostic wax-up is always important before going for the provisionalization or the temporary fabrication. Digital medical casting should be used wherever possible. Always give a screw retained provisional restoration if it is possible, because if you are cementing restoration, you are giving as a provisional, it is very difficult. Sometimes it is very difficult to retrieve it. Sometimes the cement will go inside it, and it is very irritant for the patient also. And all the implants should be evaluated either with the perio test at the stage of surgery or with the RFA. And whenever you give a immediate loading to the implant, always avoid the pontics and the cantilevers. Never give cantilevers and the pontics. If you give a pontics and maximum pontics and the cantilever, your implant will going into the failure. Decision, again, the same thing. The implant number, more the surface area, the more basically adapt the immediate implant loading. Second, implant size. Implant should lengthwise, it should be more than 10. And always put an implant with a wider diameter if the bone is available. And because the wider and the good length implant is also having a good surface area and good adaptability for the occlusal forces. Then the high stability in the D1 bone. Now we know they're having a good stability because most of the time it is a cortical bone. D4 bone having a very less initial stability. So you can load the implant in cases of mandible, but in cases of maxilla, you have to need a cross arch stabilization for the immediate loading. Bone to bone contact, more the bone implant contact is again more in a cortical bone than in a D4 bone. And ideally, the laminar bone takes 1 year to mineralize around the dental implant after the dental implant placement. So this is again the same explanation. D1 bone having a 85% of the bone implant contact, so you can load immediately. And in D4 bone, it is 30%. So initial healing, so we can avoid the immediate implant in cases of the posterior maxilla. Patient factor is again an important factor. If the patient is bruxism or any clencher or having a these type of parafunctional habit, always avoid the immediate loading in these type of patients. Implant position, again, the more the number of implant you are placed. In cases of maxilla, because we know there is a D3 or the D4 type of bone, you have to place maximum number of the implant in the anterior of the canine and the premolar area for the cross-arch stabilization if you want to go for the primary for the immediate loading. In cases of the mandible, the 4 to 6 implant are maximum if you want to go for the immediate loading. If you are going for the all-in-4, definitely the interforamina, you have to place 4 implant with the angulation or the tilted concept, and you can immediate load. All the 6 implant, if you are placing 6 implant, always put 2 implant in the canine area, 2 in the premolar area, and then according to the need, either you go for the interior segment or the posterior segment if the bone is available to increase the anterior posterior spread. So, but minimize the pontics and the cantilever during the immediate implant loading. These are the various techniques given by the Udatak here for the temporary anterior crown fabrication. First technique, if the patient comes to you for the immediate implant placement in the anterior area, make an index before extraction, then with the putty, then you have to extract the tooth, place a peak abutment, and then you go and put this index again with the bis acrylic resin and make a crown over that, and it is a screw retained crown you have to give immediately after the implant placement. Second technique is use of polycarbonatic cells. We are using in a prosto department, the pediatric department, for the crown replacement, for the temporary crown replacement. Again, the same technique, remove the tooth, put a peak abutment along with the implant, take a polycarboxylic cell crown and put it with the bis acrylic resin or the temporary crown material, and making a new crown and polish it and screw retain it. Prosthetic shell, if the patient coming with you with a fracture crown, remove the initial internal part of the crown from the natural crown, from the metal ceramic crown or the zirconia crown, and this crown we can use as a template or the temporary crown in cases of these type of patient. Then laminate veneer is also used as a basically the temporary restoration material. So this is regarding the single tooth immediate loading, and the concept regarding the immediate and the partial edentulous. Basically, most of the patient enough remaining teeth in contact to function. The transitional restoration is primarily for aesthetic and implant processes, is completely out of occlusion. The non-functional immediate teeth concept, the N-fit concept, is basically given by the call mesh for the immediate loading. That means your posterior tooth should be in a non-contact. If it is a partially edentulous area, it should be non-contact. And if you want to give in a contact, then you go for the progressive loading. So gradually you can increase the occlusal surface and make it contact within 3 months. And after the 3 months, you can give a final restoration. So this is one of the delayed case. We place the implant in the posterior area. The RF is almost 83%. Then if you see here, we put an abutment. And over the abutment, we are trying to go for the socket shield abutment technique. So we are putting a composite material around it, and it will light cure. Once it is light cure, it is the infraocclusion. It is almost like a crown. And then we progressively loading the crown and going for the occlusal surface. Complete edentulous patient, basically the protocol is you have to put a maximum implant and you go for the cross arch stabilization for the immediate loading. So this is the case in which there are 6 to 8 implant are placed then we put a transfer coping over there, then the abutment, send it to the lab. There is a temporary fabrication of the abutment, and this is the final processes. The advantage is in edentulous patient, there is a full mouth function of the new tooth, natural cosmetic appearance, very less discomforted, and long-term edentulism can be eliminated, and additional appointments are reduced. Disadvantage is more chances of failure, because if the forces are not in a correct direction, the more chances of failure. If the patient is not maintain the good oral hygiene, there is a peri-implantitis and high chances of post-operative problems if the patient is not cooperative. In all 4 concept, minimum torque we have to achieve 35 Newton per centimeter. There is no significant parafunctional habit if you are want to go for the immediate loading. Maxilla and the mandible width should be 5 to 10, 10 height and the 5 width. Favorable bone densities are always D1 and D2. And for the immediate provalization of in 4 cases, the ISQ should be more than 70. So if these criteria matches, then you go for the immediate loading in cases of 4 technique. So this is the case in which the primary denture we are using for the provalization or the temporary restoration. All the implant are placed, the multi-unit abutment in position, the cylinders are placed, and these cylinders are fixed with the primary denture. And this is the primary restoration of the 4 case. And after the 3 months, we are going for the full mouth rehabilitation again. Then immediate loading, post-operative instruction, especially the diet and the oral hygiene. This is already discussed by the Amit Bhardwaj sir. Because if your diet should be it should be on the soft diet at least for the 3 to 4 months, and maintain the oral hygiene with the chlorhexidine mouthwash and the other treatment model. Then final processes after the 4 months of the intramural removal, and the final impression is obtained to give a final processes. So in the end, I have to say that the immediate implant placement and the immediate loading is not a work of the single person. It is a combination of the 3, basically the perio, oral surgery, and the prostho department. It is a teamwork. If you see this picture, I think everybody knows this picture. I think the Ajay Devgan is very famous with this. After this stunt, he is very famous. But if these 2 side people are not there, then this stunt is not possible, because these people are getting more credit, because these people are running a motorbike with the same speed, with the same height. Because of these people, this stunt is possible. So on the same way, the implant dentistry will be a success if we are going on the work in a team. If the prosthetic, if you are putting implant according to the prosthetic work, or the prosthetic driven implant, if we are placing, it will give a more success rate. And in the end, the conclusion we can say, we have to know the proper concept of the immediate implant placement and the loading. For that, we have to evaluate the patient thoroughly, we have to evaluate the radiological radiograph thoroughly. Second, the meticulous selection of the patient, because not every patient is a patient for the immediate implant placement or the immediate loading. We have to meticulously uh, see the patient, either it is a good patient for the immediate implant placement or the immediate loading is there or not. If it is not, then you go for the delayed loading and the delayed implant placement. And regular maintenance is a key factor for the long-term success in cases of implant dentistry. Either it is a conventional implant or is a case of immediate implant placement. And thank you so much for the patients listening. And if any question is there, then we have to give answer.
Thank you so much, sir. Any of the participants have any question, you can write it in the chat box or also can ask.
It was truly an honor to have you with us today, sir. Thank you so much for sharing your time, knowledge, and making this session so enriching.
Sir, one of the participants want the surgical slide protocol again.
Okay. So can I put on the chat box or what?
Sir, you can just display it. They can take the screenshot.
Okay. It is coming or not?
No, sir, it's not visible. We are still stuck on the first slide only.
First slide.
Whosoever wants can take the screenshot of this slide.
Now it is visible?
Yes, sir, it's visible.
Yes.
Thank you, sir.
Thank you. Thank you so
So
much,
there is
Ashish.
a question.
Thank you,
What is
sir.
the
Thank you,
cause
sir,
of...
for a very informative lecture, sir. Thanks a lot, sir.
Thank you. Thank you.
So there is a question. What is the cause of pain in immediate implant even after 10 days in lower premolar
Yeah.
area?
I think after this PPT, this doubt should be clear. Either the implant is very placed very close to the anatomical structure. That is one of the cause. Maybe the infection is inside after the tooth socket if it is not curated properly. Third thing is maybe the patient is not managing, not follow the instruction given by the doctor. That is another cause also. So we have to check with the radiograph. We have to take the X-ray again after the implant placement. What is the basically the etiological factor behind it? Either it is very close to the vital structure, if it is a mandible, either it is near to the mandibular foramen or the inferior alveolar canal, or it is near to the nasal cavity. Sometimes it is anterior, and if it's very close to the nasopalatine duct, again the patient having a lot of pain. If the implant is near to the sinus membrane, again it is a chances of more pain. So with the X-ray, I can find out what is the reason for the pain in this particular condition.
Thank you, sir.
And if you if you any doubt, I put my email ID and the mobile number. You can directly contact to me if there is any doubt regarding the immediate implant and the loading part. Okay.
Thank you, sir. Thank you so much.
Thank you, Ashish. Thank you so much.
Thank you, sir.
Thank you for inviting me as a one of the speaker on this platform. If any doubt, then I think everybody take my screenshot regarding the mail and the mobile number and directly DM to me.
Thank you, sir.
Okay, okay, Ashish.
Thank you, sir.
Thank you.
I'll ask Dr. Anshika to please introduce our next speaker.
Good afternoon, everyone. We are delighted to continue with our fifth lecture of day 2 on the topic Digital Implant Dentistry by Dr. Gaurav Isar. Dr. Gaurav Isar is the head of Department of Prosthodontics and Crown and Bridge at the Institute of Dental Studies and Technologies, Modi Nagar. He brings with him over 14 years of academic experience along with numerous clinical and academic achievements. He is an active member of the Indian Prosthodontic Society and a diplomat of the World Congress of Oral Implantology at Japan. Dr. Isar has also played a key role in organizing oral implantology sensitization courses using various implant systems such as Bioner, ERIN, and CWM for undergraduate and postgraduate students as well as interns. It is truly an honor to have you with us today, sir. We extend a warm welcome and look forward to an insightful and enriching session. We welcome you, sir.
Thank you so much for the lovely introduction, Anshika. And just let me share my PPT with you all, then we'll start. One second. So is my PPT visible to all of you?
Yes, sir, it's visible.
Good afternoon to all the enthusiastic participants, and thanks for taking out time on a Sunday for gaining more knowledge. As rightly said by many people, you have to strive and learn new things every day just to excel. And this stands true, especially for uh, medical profession, because there are new things coming up every day. So we need to be updated quite frequently just so that we can give the best treatment to our patients. Now, starting with my PPT, the topic for me today is digital implant dentistry. So, first, I would like to give you a brief intro about me. This is my dental college where I am heading the Department of Prosthodontics since last 3 years. Before this, I was working in ITS Dental College, Muradnagar, where I was heading their implant center for good 5, 7 years. And Dr. Amit was a really great colleague of mine there. Hi, Dr. Saab. You had a wonderful session today.
Thank you. Thank you so much. I just want to say, always I say Dr. Gaurav is my guru for the implant.
I didn't
And
know, Dr.
I
Saab.
learned a lot of things from the Gaurav, and thank you so much for that. Thank you, Gaurav.
You are most welcome, Dr. Saab. And this is my private practice in Kalkaji. And also, I am owner of one of small labs in Delhi by the name of Capital Dental Labs. So this is just because I wanted to have fast delivery of my prosthesis and make accurate prosthesis for my patients. So that was the vision behind this lab. Now coming to the topic for today, which is digital implant dentistry. So it is a technological driven approach to replacement that uses 3D imaging, intraoral scanning, and CAD/CAM softwares to plan, execute implant procedures, and it enables virtual planning, computer guided surgery, and often same day provisional prosthetics, which lead to higher accuracy, improved patient experience, and reduced surgical time. So, with the advent of all these modern technologies, nowadays we can even show the final result of the treatment we are planning to our patient before even starting it. which gives them confidence to go forward with the procedure. So, but the main question which I always ask all my students and colleagues is, who will take the responsibility of the case? As happens with every case, a surgeon will always say that implants were successfully integrated, but they failed because of excess loads. While the prosthodontist, he says that the implants were poorly integrated and so they failed under even under normal. The one you have a patient whom you are taking for any procedure and you have to act like a team leader, and the team leader is responsible for ensuring appropriate communication for a successful outcome. So now coming to what is digital diagnosis and treatment planning. These are few subheadings under which we can divide our diagnosis and treatment planning for a perfectly digitally oriented treatment case. So first, we have to thoroughly do patient evaluation, followed by CBCT analysis. Then we have to go in for an intraoral scan, which is followed by data integration, then prosthetic planning, implant planning, virtual simulation, and then surgical execution. Then comes digital diagnosis and planning. It involves patient's evaluation both digitally as well as clinically. So I'll not be going into details, but we have to take a good medical and dental history, followed by a thorough clinical intraoral examination, soft tissue, which most for aesthetically concerned patients are nowadays, which is concern because of all the social media, place a good clinical judgment by a dentist. So first of all, what we have to do when a patient comes is we have to take a pre-treatment intraoral scan. It helps us to see all the soft tissue structures which are present around our implants, and thus it provides crucial information regarding the anatomical, prosthetic, and aesthetic parameters which are required for a successful implant placement. So, how does an intraoral scan help us? It helps us with understanding the anatomy and pathology about keratinized gingiva, emergence profile, ridge anatomy, and mucosal thickness. In prosthetic planning part, it helps us with a virtual diagnostic wax-up, arch relationship and occlusion, smile line and aesthetics, and also for space analysis. This intraoral scan is very important. On around the surgical side, it helps us in planning the implant position in an ideal location. Also, parallelism between the implant and the adjacent tooth is very important, and we can drive our planning according to the final prosthesis we are going to deliver. So, how does this intraoral scanning differ from a conventional impression? In digital intraoral scanning, we create STL 3D models, while in conventional, we get a physical cast. Intraoral scanning is highly accurate for single units and short span implants. Otherwise, conventional impressions also have good accuracy, but the risk of material distortion and errors during pouring and cast fabrication can lead to changes in the final diagnostic cast we have. Other advantages are no gag reflex, no, it is non-invasive, faster, and has better patient acceptance in comparison to conventional impressions. It has immediate results. You can show and discuss your scanning with your patient immediately after doing it. There are no lab steps involved. And also, this intraoral scan data can be seamlessly integrated with CBCT DICOM data and CAD/CAM planning for planning the future even before you have started your treatment. So, next step in this digital implant dentistry is taking good photographs and doing a smile analysis. Why? Because earlier our implant dentistry was more concerned about function, that how will the patient be able to masticate and do other activities properly with the implant. But now the focus has shifted from mastication and other functional things to aesthetics because of the new generation, which is more aesthetically conscious. So here, aesthetic success of any implant depends on the tissue loss present at the initiation of treatment. This is where our pre-treatment intraoral scan comes into action. The successful integration of an implant is not sufficient to declare success. Implants placed in poor restorative positions may result in unesthetic restorations. So, for an aesthetic outcome of an implant restoration, it is dependent on many variables, which include patient selection, smile line, tooth position, root position, biotype of the periodontium, the bone anatomy of the implant site, and position of the implant. So, coming to patient selection and the smile line, all of us know this great actor, but he has a low smile line. So, how does it affect our treatment planning in implant dentistry? In such a case, if we are not taking into consideration his soft tissue analysis, then it might be slightly saving for us. Why? Because when he will smile, only the lower one third of his teeth will be visible. So, any uh, miscalculation in placement of the implant or any FP2, FP3 where gingiva is visible, if is done in such a case, then it is a forgiving one. Patient might be satisfied because it's not coming in his smile. But what about this another gentleman? He has a medium smile line. So what does that mean? We'll have to do a few soft tissue procedures to get the apex of all our cervical lines together, and still it is manageable with a FP3 prosthesis. But imagine what will you do in this guy? He has a lot of gingiva, which is visible when he smiles or talks. So, seeing the smile line of the patient, you should always understand that what kind of procedures or what kind of aesthetic procedures, secondary procedures we might have to do later just to give them a looking procedures, aesthetic looking prosthesis. Because if we don't take this into consideration, then what happens is later when the patient is unsatisfied, we might have to do more number of procedures which were not told to the patient and neither was their cost explained. So later on, when those are explained, the patient might feel cheated. So always we should give a lot of emphasis on the smile and aesthetic lip line of the patient. Next step after deciding the aesthetics is doing a radiographic examination, and believe me, cone beam computerized tomography or CBCT, as all of us call it, is one of the safest and the most uh, accurate way of measuring and recording the bone in which we have to place our implant. So always, even for a single implant, try to get this CBCT done because it will only improve our treatment outcomes. So, as it will help us decide the right size and dimension of the implant, and also we can be ready and prepared for any complications which might occur due to shortage of space later, and which might be helpful for making our treatment more successful. So, the CBCT might be avoided or treatment planning can be slightly lesser in case of a single implant. Why? Because here, as all of you can see, the mesiodistal space helps us in guiding what is the center position of our implant. And it is slightly forgiving if our treatment planning is slightly off the balance. We'll be able to rehabilitate. But what about such a situation? Here, if we don't do the meticulous planning, it might lead to functional as well as aesthetic failure because in such a long span bridge, you have to have accurate positioning of your implant so that it can take up the loads properly. And also, you have to take care that the screw access hole or other anesthetic restoration on the buccal side are avoided. So, for such a long span case, always remember you have to do lot meticulous treatment planning, and CBCT and digital implant dentistry by the way of surgical guide becomes of real importance. So now comes the question, what is a surgical guide? A surgical guide is a template which is used to assist in proper surgical placement and angulation of a dental implant. Advantages are it assists in diagnosis and treatment planning, facilitates proper positioning of the implant, and decreases the clinical and laboratory complications. Requirements of a guide are it should be stable, rigid, and dimensionally accurate. As according to the classification, these guides can be non-limiting guides, partially limiting guides, or completely limiting guides. Now, non-limiting guides are those which only provide an indication to the surgeon to the proposed implant site in relation to the prosthesis. And they are also known as location guides, as all of you can see in the figures given in the slide. So this design indicates implant position from where the access hole will come, but there is no emphasis on the angulation. Thus, there is too much flexibility in final positioning of the implant, and it might have less amount of buccal bone if we try to use this kind of non-limiting guide. So therefore came the advent of partially limiting guides. These accurately guide your pilot drill in the right osteotomy position, and the remaining implant can be positioned with the help of increasing the diameter of the drills following the path which was selected by the first pilot drill. And for this purpose, radiographic guides can also be used as surgical templates if you want to fabricate partially limiting guides. And this is how it looks when you are trying to make a partially limiting guide for a single implant case. So followed by that, partially limiting, because it is limited only to the pilot drill, comes the third and the most accurate type of guide, which is a completely limiting guides. These are CT or CBCT based guides, and the entire osteotomy procedure for the implant placement is done through these guides. And they control depth, angulation, and position of the final implant. So, how do you prepare these surgical stents? Comes three words. First, you have to scan, then plan, and then drill through these surgical guides. Surgical guides can be fabricated in many ways. So, coming to the different procedures, the most accurate one is a dual scan protocol in which the patient wears the guide during the patient scan, and then the guide is scanned separately. Okay, I'll be giving you a case presentation also where I'll be explaining how to use this dual scan protocol for your patient. Another way to fabricate a radiographic guide is by placing radio opaque denture teeth into the guide, and these teeth will ultimately be visible in the scan so that the implants may be planned accordingly. Always remember, practitioner must be able to understand when it is important to utilize a radiographic guide. For a single implant, as already I told you, with adjacent teeth on each side, it is often not necessary to use a radiographic guide because enough adjacent landmarks exist in order to surmise the future location of your crown. All in an edentulous patient who is going in for a removable RP3 or RP4 type of overdenture prosthesis with 2 or 4 implants, there also it is not as necessary to use a radiographic guide because the clinician has a freedom in positioning the implant as their positions will be covered with the help of a denture. But these guides are very useful and essential in edentulous patients where we want fixed metal ceramic restoration in which the abutment screw access holes must open through the occlusal surface of posterior teeth and singula of the anterior. So What is the fabrication process of surgical guides for a completely computer-guided implant surgery and prosthetics? First step is clinical diagnostic, examination and impression, taking of study models. Second is a diagnostic tooth setup for fabrication and clinical validation of diagnostic tooth setup after confirming the right vertical dimension. Third step is fabrication of a radiographic guide. Fourth is digitization by CBCT scan, where we do the dual scan protocol. As all of you can see in the image, in the first scan, the patient wears the radiographic guide with fiducious marker and goes for a CBCT scan. Second scan, we don't require the patient. We stabilize the prosthesis with fiducious marker and just scan the prosthesis. And third is translation or fusing of both the scans for fabrication of our surgical guide. After you have done that, then you have to plan in the software position and angulation of all your implants, keeping in mind the anatomical and prosthetic perspective, which is followed by the guided surgery, which is insertion of implants through a custom made manufactured surgical template based on the treatment plan. And finally, during that planning time also, we can select the prosthetic prosthesis we are want to deliver to the patient before the surgery. And we can also decide whether we will be going in for immediate loading or for a delayed loading protocol, depending on the position of implants and the height and the masticatory load those implants can take, depending on the bone and the planning we did during our uh, guide for fabrication. But always remember, even in guided surgery, errors can occur. The steps where these errors can occur are during image acquisition, during data processing, during the surgical template production, while we are trying to place the template in the patient mouth. Mechanical error also may be caused by the burr cylinder gap. And in template assisted surgery, the height of template necessitates very long burrs. And imagine in a second molar area, the mouth opening is less and the length of these drills are very long. So the force and the less mouth opening can also cause errors during these guided surgeries. So, and these errors can be assessed at the entry point, measured at the center of the implant, at the apex, where they are measured at the center of the implant at apex. Also, these errors can be angular in nature and also in the height. Computer guided implant surgery complications may be classified into early and late, wherein early complications include surgical and prosthetic complications, while the late complications are implant failures or prosthetic complications. So here's a case in which we did guided surgery. It was a full arch implant planning for a rehabilitation of a maxilla. So first, when the patient came, the objective was to plan a case for implant-supported rehabilitation of maxilla in a conventional manner. But when we did the clinical steps of impression making, establishing jaw relation, and fabrication of an interim prosthesis and a radiographic through OPG, we found that the amount of bone which was present was very less, as was visible through the OPG. So we tried to arbitrarily make our implant positions marked on the cast. And these positions are judged according to the interim prosthesis which was fabricated, as shown to you in the earlier pictures. So after this, when we found the bone was less, we marked the anatomic structures on the OPG just to see the amount of bone we had. Since it was less in the posterior region and the bone was also thin, we decided to go for a guided surgery instead of placing conventional implants. So for guided surgery, the first step, the temporary prosthesis was induced with fiducious markers. These are radio opaque material which is uh, impregnated into the temporary prosthesis at different points and positions so that it can mimic, it is visible after the CBCT is done. So as all of you can see, these white dots which you see on the buccal and labial surface and also on the palatal surface, these are the fiducious markers which were induced. After this, the patient was asked to wear this and get a CBCT scan done following the dual scan protocol, wherein the patient wore the prosthesis and a scan was done. And later on, the denture was seated on a platform and only the prosthesis was scanned. After this, treatment planning and angulations of the implants were decided, and we got this stereolithographic guide. And as all of you can see, there are metal cylinders which are placed in this guide, and they are color coded, telling us what will be the final dimension of our implants placed through each one of these holes. This is the surgery guided surgery kit which was used for this case, and it comes from the company named Into Guide Universal Kit. Okay. So now starting with the surgery, first the guide was stabilized in the patient's mouth using stabilizing pins, followed by tissue punch, which were pressed through the holes present in the surgical guide. Then the surgical guide was removed, and these tissue had to be carefully removed. Why this is important is, if we don't remove the guide and thoroughly remove this tissue, then some part of this tissue might go into the osteotomy we have prepared and might cause infection and failure of our implant later on. So, to avoid such surgical complications, after we have done the tissue punching, we have to remove the guide and then carefully remove the tissue which has been marked through the guide. After removing the tissue punches, the guide is again stabilized in the same position, and then with the help of uh, long long handheld hole modifying drills, we use and start preparing our osteotomy. Once we are done with the osteotomy and the guide is removed, this is how the implant placement looks through after the guided implant placement. This was the post-operative OPG, and as all of you can see, because of the narrow bone of around only 2 millimeters in the anterior region, we were not able to place anything between canine to canine, but rest of our implants were all stable and firm, ready for taking the masticatory loads. This is the prosthesis in the patient's mouth. So after the guided surgery comes next part of digital dentistry, which is CAD/CAM or fabrication of a prosthesis. So what is CAD/CAM? It is computer-aided designing and computer-assisted manufacturing or milling of the final prosthesis. The steps involved in this CAD/CAM procedure are intraoral scanner or physical impression, which is sent to lab, where if a physical impression is received, it is again converted into a digital format using extraoral scanner, which is then fed into a computer where we design and check the occlusion and dynamic as well as static occlusion of our prosthesis, followed by either milling or 3D printing of our final prosthesis. So now comes the next question. Why do we need CAD/CAM? We have been making prosthesis for our patients since long. So why invest into such expensive equipment and then also give our labs more money for CAD/CAM fabrication of a prosthesis? The answer lies that in conventional steps of manufacturing dental crowns and bridges, there are in each step there are a lot of chances of errors. For example, during impression making, due to the shrinkage of the impression material, error can occur. In the second, while pouring, there is shrinkage of the impression of the stone, die stone, which might cause inaccuracy in the cast we are getting. This is followed by, if we make conventional wax patterns with free hand, then we don't know the thickness of the wax we are giving in one area. And also this wax will have its own shrinkage, which will lead to error. Followed by casting, which again has shrinkage. Then the casting furnace, when the metal cools down, further shrinkage will occur and which might again cause error in our final prosthesis. While finishing also, if any burr or anything is used more, then it might lead to exposure of the tear of the metal framework. And if we layer the same, then it will lead to failure or fracture of the porcelain later. So conventional prosthesis fabrication is a very long and cumbersome process and also not so accurate as there are inaccuracies which are building in at each step. But thanks to computers, this whole process has been digitized now. So what is CAD/CAM, this digitization? It has majorly three steps: scan, then you design your prosthesis, and then a machine manufactures it. So what are the components of CAD/CAM? First is a scanner. What is a scanner? It scans the dental model and converts it into virtual image on which planning and designing can be done. These scanning can either be through with the help of a lab scanner or an intraoral scanner. An intraoral scanner is used by the dentist directly in the patient's mouth, and the data is then transferred to the lab. While in case of a lab scanner, a physical impression is made by the dentist, which he poses and then sends to the lab. And there, the physical cast is digitized with the help of an extraoral scanner, which is also known as a lab scanner. Once this is done, then you design your prosthesis on the softwares available on your computer. And after that comes the milling part, computer assisted milling or manufacturing. This milling or manufacturing can either be a additive process wherein it is known as 3D printing, or it can be a subtractive process also known as milling. So what is a dental milling unit or a CAM unit? These are the production workhorses of dental CAD/CAM systems. Choosing a milling machine. These dental mills have lot of uh, components depending on the number of axes in the milling machine, which can either be a 4-axis or a 5-axis, or the type of milling, whether the machine can do dry milling or wet milling. How to choose a mill? There are number of questions you have to answer. What are the number of cases? How many cases your lab wants to handle? What kind of softwares you are aware of, and what kind of prosthesis you want to design? And also, the mill depends on the materials you want to mill, whether it's zirconia, which requires dry milling, or you want to do titanium milling or PMMA, which require water just to cool down the drill so that there is less fracture and less damage to your machine. So these PMMA and Emax crowns, they require wet milling. So depending what is the requirement, you have to choose which milling machine will suit your case. Another thing, how to select number of axes of milling machine. See, all of us are aware about the three axes in which a drill can move. They are x-axis, y-axis, and z-axis. And the x represents the horizontal axis, the y depth axis, and the z-axis is the vertical axis in which the drill can move. But for milling, you require another axis. Why? Because if your drill is only moving in 3 directions, how can you mill the undercut areas in your prosthesis? So, what is the fourth axis which comes in a milling machine? As all of you can appreciate in the diagram, X, Y, and Z axis are in the drill, but the fourth axis is in the milling holder. So it can rotate 360-degree by itself, which is the fourth axis. And it helps us to even finish our prosthesis in the areas which would otherwise have been very difficult to uh, fabricate. And the fifth axis is if your milling block holder can also rotate in 2 directions. So now how is it working? The three axes are located in the drill, wherein the drill can move in 3 axes, and the two other axes are the rotation of the milling block holder, which can again move in 2 directions, A and B, represented in this diagram. So this A axis is rotational axis, while the B axis is rotational axis, while the A is a perpendicular axis to this rotational axis for further complicated prosthesis. Just like the benefits of these five axes is the tilt and rotatory axes work in unison, and any facet of the milling component can be oriented upward with sudden ability to orient any facet towards the milling tool, while X, Y, and Z axis control the spatial relationship. So no geometry, no matter how intricate, is not now beyond the machine's capability to move, especially in case of full arch hybrid titanium cases or in cast partials, where the complex geometry of the prosthesis is such you require only a five-axis machine and the four-axis machine is not able to support you that much. This table is showing you the possible manufacturing abilities and the difference between a four-axis and a five-axis machine. So now coming to the next step, we have chosen we have done our surgery and planning with the help of digital CBCT, intraoral scans. Then we have designed our prosthesis. Now, how to take the patient's impression with the help of digitization. So first we'll have to understand the basics. Implant impressions are detailed three-dimensional negative copies of implant fixture and the surrounding oral tissues. And this is crucial for fabricating accurate implant restorations, as they serve as a blueprint for creating the final implant crown or bridge and ensuring a precise and comfortable fit. This impression can either be taken in a conventional manner or a digital manner. So, a small walk through the conventional part. How do we make implant impressions? And how are they different? All of us during our undergraduate time have taken impressions of removable partial dentures or fixed partial dentures with the help of alginate, putty, light body. But implant impressions are different because the implant is embedded inside the bone. So something innovative needs to be done to capture the implant position for fabricating of prosthesis, since the implant is embedded in bone and we cannot send anything inside the bone to take its impression. So what we have to do is, once osseointegration has taken place, what we have to do is we have to expose our implant and do a stage 2 surgery, wherein the cover screw comes out and a former goes inside in its place. What is a former? It gives shape to the gingiva. And the main two features of a former which you have to keep in mind are height and diameter. So when we use the correct kind of former with the right height and diameter, can you all of you appreciate the good gingival cuff which has been formed? And this will protect our implant for long from peri-implantitis or any mucositis from occurring. And also our implant prosthesis will look more natural and aesthetic. So this is a small video showing you the normal stage 2 surgery which can take place. But in this type of stage 2 surgery, you have to remove a full thickness flap which divides the bone of its periosteal blood supply for the second time. So there might be some amount of bone loss in such a case. To avoid this, there is another type of stage 2 which can be done, that I'll show you in the second video. So now what the dentist is doing, they are removing the cover screw after full thickness flap reflection, and it is being replaced by a former. And then you have to again do suturing and wait for it to heal. So this causes a lot of bone loss and inconvenience to the patient. So the other type of minimal flap reflection stage 2 is a crisscross method, wherein you locate the cover screw and then just make a cross over it, and you don't reflect rest of the mucosa. Once this cross has been made, you just have to locate the center point of your cover screw and gently tease it out through this crisscross incision which you have made. And through this crisscross incision only, then you place your former. The advantage is that the bone around the implant was not devoid of its blood supply, and also it will lead to better and more keratinized mucosa around your implant, which will lead to a more aesthetic and a pleasing uh, profile. So how do we capture this implant position once stage 2 is done? So for implant impression, conventionally, the impression can either be fixture level or abutment level. Fixture level implant impressions include closed tray and open tray impressions, while abutment level include indirect impression and direct impressions. So for fixture level, we can either use closed tray impression technique or open tray. So what is the difference? In closed tray impression copings, they have smooth sides. They are screwed over the implants, and then like normal FPD and RPD impression, we take a impression, and then once it is removed from mouth, we place this uh, closed tray impression coping in the mouth. So here is a small video showing the same. First, he is removing the former, then he is attaching a closed tray impression coping there. Once this is done, it is very important to take an X-ray to confirm that the impression coping has properly fixed. Once you have confirmed with the help of an X-ray that the coping is fit, then what you have to do, you have to apply light body on the occlusal surface and around the closed tray impression coping, avoiding any air bubbles by keeping the tip of your light body syringe inside the impression material. This is followed by loading the putty in the impression tray, and then which is placed over the light body, which was spread over the teeth and the impression coping. Once the light body has set, you have to remove the impression tray from the patient's mouth, unseat the impression coping, attach. After unseating the impression coping, you have to attach the gingival former back inside the patient's mouth to maintain that gingival cuff. After you have done that, then you have to attach your impression coping to a digital analog. Once this is done, it is followed by placing this impression coping back inside the impression. And then you have to pour a cast. I will show you in forward slides how to pour a dental implant cast. But this was a good way to record impression for a single implant. But various authors have reported about positional inaccuracies which are inherent in such type of closed tray impression technique. So there was a modification of the closed tray impression technique, and the second type of impressions were introduced, which were which were also known as snap-on implant impressions. Herein, the closed tray impression coping was covered with a snap-on type of plastic component, which was engaged into the impression, in which the closed tray impression coping was then placed. Here is a case of such a snap-on impression technique. This is the Noble Biocare implant which was placed. So in this second diagram, we remove the gingival former, and this is the snap-on kit which used to come. So this is the snap-on part. First, we have to attach this metal fixture in the over the implant with the help of this prosthetic screw, over which then this snap-on impression coping is attached. As all of you can see, this is the fixture in the closed impression coping in the patient's mouth, over which we have placed the snap-on plastic component. Then we take an impression, and that slap-on in plastic component is picked up in the impression. Then we tighten the closed tray impression coping, which we take out from the mouth with the analog, which is placed inside this plastic snap-on. This is the final prosthesis on the cast as well as intraorally. Still, what the issue was, published literature states that up to 5 degrees angulation difference, these closed tray and snap-on impression trays technique were accurate. But beyond that angulation, some other technique was required, even for a single implant. So remember how difficult it is to make it 100% parallel inside a patient's intraoral cavity, where there are many other factors which involve your placement, which include less mouth opening, movement of tongue, saliva, patient's movement. So it is really very difficult to place uh, implant parallel to the tooth, which doesn't even have a deviation of 5 degree in a single implant. So if it is not possible in a single implant, imagine a situation wherein you have to place two. So because of the two implants, the degree of angulation further increases. And as the literature states, there will be inaccuracy and less passivity of your final prosthesis. But still it is manageable up till two implants to take help of a closed tray impression coping. But what about such a case where the resorption of maxilla and the bone, presence of bone in the angulated form results in placement of implants in such uh, vivid angulations? How will a closed tray impression coping able to take impression for such a patient? Therein comes the open tray impression technique. Here, you don't have to reseed the impression coping after you have your impression material is set. It is picked up along with the impression material. So these are the open tray impression copings, and as all of you can see, they have a lot of undercuts. How do these undercut help us? They help us in engaging the impression material properly, so that when after setting we remove the impression material, these copings, because they are engaged in the undercuts, through their undercuts in the impression material, they are picked up along with the impression. So as all of you can see, first of all, we have to engage the impression copings in the patient's mouth. In the B diagram, you can see we have to make a hole in our impression tray through which these long screws should be visible. And from here comes the name of this impression coping, which is open tray. So for taking this open tray, we have to make hole and open our tray so that these long screws are visible. Once we check intraorally that the long screws are coming out of the impression tray through these holes, then we have to load the impression material in our tray and then let it set. During the setting only, we have to expose the long screws through the impression material. And once the impression material is set, we have to unscrew the long screw so that the engagement of these impressions copings with the implant can be removed. And then when we remove our impression material, the impression copings are picked up along with the impression. So advantages of these open tray technique is it has less deformation of the impression material, and there are no risk of inaccuracy while placing back the coping into impression, which had to be done in closed tray as well as snap-on impression techniques. But still, it has disadvantages. There are more number of components you have to control. There is rotational movement of impression coping while unscrewing the analog. And also there you might end up having a blind attachment of the analog to the coping. These can further result in inaccuracies. So now see what are the steps involved in a full arch open tray impression technique. First of all, you have to tie all the open tray impression copings with the help of a dental floss. Then you have to cover it with a composite just to give it a body so that when we put pattern resin over it, it flows properly. Once that is done, then you have to take your putty light body and let it set. After unscrewing, this is how all your impression copings are picked up in the final impression. After this, you have to attach the analogs, and now your impression is ready for pouring the cast. This is the final prosthesis of the patient. Now, this is how you pour a implant impression in a lab. Just have a look. Here you can appreciate the digital analog is already attached to your impression copings. So first you have to spray a separator, then you have to attach gingy mask, which will mimic the gingiva surrounding your implant, uh, which is there present in the mouth also. So once you have applied the gingy mask and it has set, then you have to cut and remove any undercuts in the gingy mask. Once you have made sure that now the gingy mask has no undercuts and dental stone will not engage anywhere, you have to pour the cast. And you have to make sure that the analog is completely covered with this dental stone or dye stone. After this comes the step of fabricating a jig. So, what is a jig? It is a verification of your impression. You have to connect all the implants with a rigid material so that if you try to fit this jig in the patient's mouth and it fits accurately, then you don't need to, then you are confirmed that your impression was 100% correct. But if there is any issue while placing this jig in the patient's mouth, then if you would have made the prosthesis, all the effort and time and cost of the prosthesis would have failed. So this is how a verification jig looks like in the patient's mouth. If this jig is sitting perfectly, since it was made on the impression you had taken, you can be 100% sure that your impression was accurate. And then if you proceed with your fabrication of your prosthesis, it will also sit in the patient's mouth. But always remember that you have to verify your jig trial with X-ray and see that all the impression copings are seating in the implants properly, just as you had taken an X-ray after seating the impression coping in the patient's mouth. After this jig verification comes the step of prosthesis design. This is very important, and you have to let your lab know that what kind of a prosthesis you are planning, because according to that only they will make a jig. For example, if you are planning to join all your implants in a single prosthesis, then the jig will also be a joined one. But if you are trying to split your prosthesis into two parts, then you have to inform the lab that so that they also make the jig in two parts according to the design and planning for the final prosthesis. Some of the key points you have to remember during jig trial are that your jig trial should be passively seating. Also, ask the lab to send a custom tray along with the jig trial so that if some issue is there in the seating of the jig, the impression can be repeated at the same appointment. Also, if even if you are taking a digital impression, ask a lab to send a custom tray to facilitate a repeat physical impression in case the jig trial is inaccurate or not seating properly. So another thing to remember is there should be a space of 2 mm between the jig pattern resin and the mucosa. Why? Because if you have to take a repeat impression, there should be space for impression material to flow under the jig and which will help in accurate picking up of the prosthesis. If this space is not there, then when you will try to take a repeat impression in case of failure of jig trial seating, uh, there again can be movement of your impression copings and again leading to inaccuracies. Also, another point to remember is accept verification jig on UCLA abutments at never accept verification jig on UCLA abutments as they can bend and give false positive because they are made of plastic. And also never splint implants with composite resin alone or flowable composite or acrylic resin. Why? Because they are not very rigid and they might fracture or they might bend, giving you a false positive for a accurate impression. I am telling you all these lab steps because being a prosthodontist and being owner of a lab, I like to tell all my dentist friends that the more support and the more accurate your impression will be, later it will be easier for all of you, and for the dentist as well as patient to adapt and deliver the final prosthesis. So we should be very meticulous with our impression. With all the inaccuracies, now we are going to discuss digital aids in implant rehabilitation, which include intraoral scanner, implant scan body, digital analogs, 3D printer, and planning softwares. First comes the intraoral scanner. It is a handheld wireless device used by dentists to scan a patient's teeth, gums. It creates an immediate 3D impression of your teeth, gums, and dental bite that can be viewed by both dentist and patient on a chairside real time. So after this comes the implant scan body. What is it? It is a scannable abutment which is usually made of plastic material such as teak with titanium metal interface that is used to aid in digital construction of a dental restoration. All this will be well understood by you once you see a case, which I will be a video, which I'll be showing you after explaining about these components. Third component for digital impression is a digital analog. It is intended to be used as a dental implant replica inserted into a 3D printed or a milled model to duplicate the location, orientation, and restorative platform of a implant placed in mouth during CAD/CAM fabrication. What is a 3D printer? It is a machine which uses additive manufacturing to create dental parts such as aligners, dentures, and crown to create custom parts that match patients' anatomy. Dental providers use a tool called intraoral or extraoral scanner, which creates image of patient's teeth and record them in the form of a CAD file. Then the next thing is a CAD planning software. It is used for to aid in designing a prosthesis, and they are frequently used by different types of engineer and designers. These CAD softwares can be used to create either two-dimensional pictures, or they can also be used for creating three-dimensional models. So now coming to the digital protocol for final prosthesis fabrication, the first step is scanning, which can either be intraoral or extraoral, followed by designing on a software to get all the cusps and occlusion correct. In this software, they have inbuilt capabilities to check both dynamic as well as static occlusion so that patient is more comfortable with the our prosthesis. And then once the designing is done, either we can do milling through a subtractive process, or we can do 3D printing, which is a additive process. And both these milling as well as 3D printing give us our final prosthesis. So here's a small video showing you intraoral scanning of an implant. So first of all, we have to just scan the arch in which the implant is there after removing the former. Here, all of you can see the former has been removed from the patient's mouth because we want to record the soft tissue profile of that area. Once that is done, the software gives us an option of digging a hole. This hole is dug for placement of a scan body. So once we have checked that all the hard and soft tissues have been recorded properly, then right now they are scanning the details which were missing in the first uh, go. Can all of you appreciate the soft tissue profile around the implant? That is work of a gingival former to give that collar, gingival collar. Once that is done, You have to dig a hole in that area. This is followed by placement of a scan body. Now the software will ask you to place a scan body in the patient's mouth. This is a digital scan body which has to be placed. Okay, and you have to record this flat surface, which will help us. So now this scan body is in place, and then you have to confirm its seating with the help of X-ray, so that any prosthesis you make will only fit if this scan body is completely attached to the implant without any gap. So this is the tightening of the scan body with the help of a prosthetic hex. So this is the X-ray they are taking to confirm the proper seating of the scan body. So this is how it should look. The scan body and implant should look like a one piece. Once this is done, then you only have to scan the scan body on all buccal, lingual, mesial, and distal sides. Once you have done that, you have to check in the software that all the parts of the scan body have been recorded or not. If not, then you can repeat the procedure. So once that scan body is completely recorded, then you need to remove it and scan the opposite arch. So this is scanning of the opposite arch, which is very important to know the correct static and dynamic occlusion. And once that is done, then you take the final bite of the patient. This is recording of the bite. See how quickly both the maxillary and mandibular scans correlate. And you are done with your scanning now. You can send it to the lab. For full mouth rehabilitation, a few key lab points which you need to know are: you should discuss your vertical dimension with the lab to plan the restorative options. Some of the prostheses require more amount of restorative space in comparison to others. So before committing to the patient, what kind of prosthesis will you give him? Whether a hybrid will be okay, or a screw retained PFM, or you will go for a palo malo type of bridge. All these prostheses have different vertical dimension requirements. So that VD should be discussed with the lab so as to give the correct prosthesis to your patient. Also, custom tray should be ordered for a open tray impression along with the jig trial. Also, you should tell the lab whether you will give a single prosthesis or you will give it in two or three parts, so that the jig trial can be designed as per the prosthetic needs of the patient. And you should also ask lab to send a occlusal rims for establishing a jaw relation, because we need to know the right vertical dimension of occlusion, which is very important for proper mastication as well as taking good care of temporomandibular joint health. Because sometimes if we don't keep this vertical dimension in mind, we might cause more damage to the TMJ of the patient. And as all of us are aware as dentists, if such situations occur, then the patient can have very severe pain and also result in failure of our rehabilitation. So, as I already told to you, discuss VD vertical dimension to plan your prosthesis. Also, ask your lab to give you a screw retained wax bite to establish jaw relation. Why it should be screw retained? Because if it is not screw retained, then over the tissue, there might be a movement of this rim, which might lead to error in recording the right vertical dimension. Okay. Followed by a screw retained teeth trial. Because if this is not screw retained, then when you are placing your teeth trial in the patient's mouth, because of movement of the tissue, the midline might look shifted and you might change it. And later on, when the screw retained prosthesis comes, the midline is not same as that was present in the teeth trial. So it is important to always ask your lab for a screw retained teeth trial. Now comes designing and what are the prosthetic options available with the help of this digital CAD/CAM technology, how it has modified the prosthesis designing. ho- It has caused enhanced precision, more time efficiency, improved aesthetics, better patient experience, predictable outcomes, seamless integration with other digital technologies. So enhanced precision comes because of elimination of potential errors which are associated with traditional implant techniques and resulting in more accurate and well-fitting restorations. Time efficiency, of course, it is increased because the physical impression model and the time consuming steps of traditional techniques are eliminated with the help of this technology. Aesthetics are also improved because customization of prosthesis shape, size, color, and resulting in natural looking and aesthetically pleasing outcomes has become a standard with the help of these digital tools. Patient experience is also enhanced because there is no discomfort or gag reflex which used to be present when we used to take physical impressions of the patient. And this has also reduced the number of dental visits, saving patients time and reducing his anxiety. Moreover, the precise fit of CAD/CAM restoration improves patient comfort and functionality. Now, with the help of these softwares, we have more predictable outcomes as we can visualize, plan restorations in a virtual environment before even fabrication has started. And this allows comprehensive treatment planning, evaluation of occlusion, and assessment of aesthetic outcomes. The ability to mimic digital adjustments and simulate final result increases predictability and facilitates better communication with the patients. Also, these digital technologies can be integrated with one another. For example, a CBCT data can be infused with a CAD/CAM software to get the final prosthesis depending on the planning in the CBCT you have done for your implants and the fabrication of prosthesis, and which increases the overall, enhances the treatment planning, improves implant placement accuracy, and overall digital workflow, makes it very easy and very systematic. Now, CAD/CAM technology has revolutionized the prosthetic world, which is also known as prosthodontics, as it includes from designing and fabricating bridges, implant restorations, complete dentures, and removable partial dentures. So, implant restorations, where what all can be done with them is customized abutments, improved fit and adaptation, efficient workflow, shorter turnaround time, improved aesthetics, long-term stability, enhanced patient communication, compatibility with digital workflows. So first comes customized implant abutments have become a regular feature in our practices with the advent of these uh, CAD/CAM technology, and they have more anatomical margins which are in tandem with the soft tissue present in the patient's mouth, just which help us in avoiding any peri-implant mucositis or peri-implantitis from occurring. These customized abutments can be made in these various material options, which include CAD, casted, DMLS, Syntron, milled cobalt chromium, milled titanium, milled PEEK, and pre-mill abutments. Screw retained crowns have also improved with the help of this CAD/CAM. They have better stability, predictable aesthetics, ease of maintenance and repair is also there. Then comes the hybrid dentures, which have improved in aesthetics in cases of patients who have low smile line. They help in bone preservation, improved oral health, and minimize palatal coverage to give more natural feel to the patient. These are the various material options for hybrid dentures. Then comes implant over dentures. They have also improved drastically with the help of CAD/CAM technology. These are the various materials options for implant over dentures. Then this is a very interesting prosthesis, Palo Malo Bridge, which is very, very aesthetic. And also it requires fewer number of implants and is more suitable for patients who have less bone and more resorption has occurred. Another advantage of these is aesthetic and functionally they are very good. They improve quality of life. And even if one of the crown fractures, you don't have to replace the entire prosthesis. You can just replace that single crown, which has some chipped ceramic, and thus the patient's functionality is not disturbed even during repair work is going on. So that is the advantage of Malo Bridge. These are the various materials which are available for Malo Bridge. Again, now crowns and bridge with the help of these CAD/CAM technologies, we have dearth of different materials and different fabrication procedures for our crown and bridges, which were earlier not there. And as growing students of this implantology and digital dentistry, I would like you all to go through each type of prosthesis. Each one of them has different indications and different uses and advantages and disadvantages. You should be aware of all of them, because if you are aware of all of them, only then you will be able to give best suiting prosthesis to your patient depending on their needs, their monetary situation, and their masticatory loads, and also aesthetics. So the different materials are milled wax, PFM, 3D printable castable resin crowns, which after the fabrication of the with the castable resin, the conventional fabrication has to be done. Another is milled PFM, where straight away with the help of printing, 3D printing, metal printing, you get the metal crowns. Now only the porcelain layering has to be done over these PFM copings. Then there is milled titanium, wherein the from a titanium block you mill the abutment as well as the connection for precise placement over your implants, which is very good for palo malo kind of prosthesis. Monolithic zirconia for withstanding masticatory forces, and it has good aesthetics, more biocompatible. It reduces production time and enabling quick delivery to the patient. Also, it eliminates the potential weak points and avoids any ceramic chipping which might occur. Layered zirconia for aesthetic areas, for extreme shade matching, and through these layered zirconia, the light passes similar to what how it passes through natural tooth, which makes it very aesthetic. And they have good longevity, and there is excellent margin blending because there is no black complaint of black margin, even if there is recession of the tissue. Then there are glass ceramics, which have excellent aesthetic, strength, and durability. They have precision fit. And the most important thing is they can be given with very conservative tooth preparation, which was one of the principles of tooth preparation while we were doing our undergraduate, which was conservation of what is remaining is more important than replacing what is missing. Now, coming to a few clinical cases. First, a digital implant rehabilitation of 2-3 implants using digital technology. So herein root stumps were present, which were taken out and immediate implants were placed. After that, after 2 months of healing, scan bodies were placed in the patient's mouth and intraoral scanning was done. This is how the intraoral scan looked on the computer. This was followed by fabrication of uh, STL models for making the prosthesis in lab. This is how the models looked once they were 3D printed And can you appreciate the pink gingiva, which mimics the patient's pink gingy mask, which mimics the patient's gingiva? This was followed by making jig trials on these 3D models, which were placed in the patient's mouth and X-rays were taken. This is the screw channel or the access hole and the direction of the access hole, which helps us to decide the final prosthesis so that they are more aesthetic also and functional. So this is followed by designing of the final prosthesis on the software. These are the final prostheses on the 3D printed digital casts. The same prosthesis in the patient's mouth when the X-ray were taken. And this is how aesthetic and blended the restorations looked in the patient's mouth. Another case of full arch maxillary rehabilitation with screw retained prosthesis following digital protocol. Herein, first, after osseointegration has taken place and stage 2 done, after 1 week of that, scan bodies are attached to the implants and digital scanning is done. This is how the 3D printed cast with digital analog looks. And on the right side, you can see the pattern resin jig with temporary cylinders attached. This is the clinical verification of the pattern resin jig intraorally. And always remember, you have to take an X-ray in this step to confirm that the jig is sitting perfectly and it should be passively sitting. What do you mean by passive sitting? You should not apply any pressure while you are seating this jig in the patient's mouth. Why? Because whatever said and done, there is slight amount of flexibility even with this pattern resin. So when you put pressure, it might flex and sit. But when the metal prosthesis will come, it will have zero flexure. So if you are trying to press hard and seat your jig there, then your final prosthesis will not sit. So what should be done? You should just place it there and screw it. You should not apply any forces while you are screwing this verification jig in the patient's mouth. This is the screw retained wax bite on the left side, both occlusal as well as intaglio surface. And on the right side, you can see the screw retained teeth trial. This steps helps us in taking uh, patient's view also in our treatment planning. At this stage of teeth trial, you can ask him whether he likes the size, shade, shape of the teeth, whether he wants any gap anywhere. And when you ask your patient for his opinion during the treatment, he becomes part of the treatment. And once he becomes part of the treatment and he has a role in decision making, then what happens is he feels involved and he will be better accepting your prosthesis. So once this teeth trial has been approved by the dentist and the patient, then we start designing the final prosthesis. So after initiation of the designing prosthesis, we transfer the bite and the teeth trial we had done to the designing software. This is the framework, metal framework designed of the final prosthesis, and this is the CAD design of the final prosthesis after ceramic layering will be done. Here you can appreciate the metal trial, both occlusal and intaglio surface of the metal bridge, metal substructure for porcelain layering. You have to do a metal trial at this stage and again confirm with an X-ray. This is the final prosthesis on the cast as well as intraorally. And this is the lovely, wonderful smile our patient can have with the help of this digital designing. Now, coming to recent advances, all these digital designing and planning softwares. This was a case which was done yesterday in my college by my students only. So here what we have done is this patient didn't have any bone. So we got a CT scan done and then we designed a patient specific implant for this patient because she had a lot of periodontal chronic. She was a chronic periodontal patient. So uh, and still she wanted a fixed prosthesis. So this is titanium printed patient specific implants which were done in two parts. And this is how it comes. For in the first image on left side, you can see these are tools to help us make undercuts in the bone where this prosthesis will sit. Can you appreciate these holes which were there in the bone where the TMA and the prosthesis is sitting? So this is a guide just to make those bone cuts. And then this is the final placement of this titanium PSI implant intraorally in the patient's mouth. This is a small video showing the surgery and everything. So this is my team, my Department of Prosthodontics and IDST with all my colleagues and my postgraduates. They are the working uh, hands. I would like to thank all of them because all the cases and all the videos you are seeing in this presentation, all of them helped me a lot in making this presentation. Thank you all for your patient listening. This is my email ID and my mobile number. If anybody has any queries, feel free to contact me. I really love helping anyone with any clinical or lab procedure or any prosthesis they want to fabricate. Thank you so much.
Thank you so much, sir. Is
Thank you,
anybody
sir,
having
for
any
the
doubt?
wonderful lecture, sir. It was a very informative lecture, sir. Thank you, sir.
Thank you. Thank you. Anybody has any doubts, most welcome. You can ask me or you can even DM me later. I know it has been a tiring day since you have been listening to so many lectures throughout the day. I understand. So anybody has any doubts, you can always contact me at a later time also. Okay,
Thank you, sir.
Ashish,
Yes,
then
sir.
I
We
can
don't have
leave.
any lecture. Yes, sir. We don't have any questions
Yes,
further.
sir.
No issues. Thank you so much. Thank
Thank
you.
you, sir. Thank you, sir.
Thank you.
We are incredibly grateful to Dr. Gaurav Isar sir for sharing their expertise on digital implant dentistry today. Thank you, sir, for sharing your knowledge with us.
Thank you.
Thank you, Dr. Anshika. Next, I would like to request Dr. Chaya to introduce our next speaker for the day.
Good afternoon, everyone. We are delighted to present the final lecture of day 2 on the topic Latest Advances and Future of Implantology by Dr. Atriya Rajgopal. Dr. Atriya Rajgopal is an eminent oral and maxillofacial surgeon and an intentionally renowned facial cosmetic surgeon. With over 13 years of clinical experience, he has a certified implantologist with advanced training in facial cosmetology, cleft, and craniofacial surgery from international institutions. He has worked with leading institutions such as Max Healthcare and has extensive expertise in implantology, orthodontic surgery, facial aesthetics, and complex maxillofacial procedures. He is also actively involved in training dental professionals in advanced facial cosmetology and implant techniques. It is truly an honor to have you with us today. Sir, we extend our warm welcome and look forward to an insightful and forward looking session. Thank you.
Thank you so much for the warm introduction. First of all, I would like to take this opportunity to thank Cynodent, Dr. Ashish, and Dr. Anmol and the entire team for having me here. Secondly, everyone else who's logged in online on a Sunday, and Sunday being one of those days where, if we usually take the days off, and what can be better than utilizing it to absorb some knowledge and some points that we can all take home. And you had a wonderful presentation, which I was listening to right before by Dr. Gaurav, and it is actually life changing. Implantology has actually reached a new stage, and I think if I can put in some surgical things into the complex thing that we're doing, I will be able to put some points across. Can I have the sharing rights? I'll try and share the screen if possible. Otherwise, we can have it.
Yes, sir. I'll make you the co-host. Yes, sir. You can try once, or else I'll share them.
Is my screen visible?
Not. Yes, sir. It's visible.
Perfect. So, we're going to
Yes,
be
sir.
talking about all the surgical, advances that we have in implantology. I'm not going to waste too much of time. You've been hearing a lot about implantology, but how far have we come in implantology? I'm of the school of thought. I believe in the conventional implantology concepts, and which is a concept based on uh, osseointegration. There is a second school of thought which some practitioners are using, which is based on mechanical retention more than osseointegration, which is basal implantology. I'm not a very big fan of it, but sometimes if the need is there, then yes, that is an option that can be utilized. But as in the previous presentations, in complex cases, we can even use patient-specific implants, which has actually changed a lot of things. So, what kind of complex cases do we get in routine implantology? It can be okay. First, coming on to the technology, you have three things in front of your screen. One is something that everyone knows: the straight hand piece micromotor, bread and butter. Every day we use it for something or the other, surgeries or prosthetics or whatever. The second thing that you see on your screen, which is this one, is known as the magnetic mallet, which I started using in 2018. What it does is it condenses bone. It doesn't cut any bone. And this third thing, I have three of them in my practice. You know what it does? It is the piezotome. It actually cuts only bone and does not work on soft tissue. Why? Because it is based on the effect of cavitation. So it only works on mineralized tissue. Why would I want to, use all this? Because at the end of the day, I want to do the best for my patients. And if I can add some more technology and get things going to help my patients, that's the best thing possible. So yes, you would want to, get the newest technology under the roof. It simplifies your work, and it actually helps you do cases which you might not be able to do with the conventional micromotor handpieces, and in the best possible manner with efficiency. So I'll show you how this works. New technology gives you precision, power, safety, and any surgery. Always remember, it is never going to be a straight line. It is always going to be a zigzag line. But our aim is to stick as close as possible to the treatment plan, and that is what a surgeon actually does. Whenever you perform a surgery, it's not going to go the way you plan. It never does. And if it does, you should just thank God and say that, oh, what a wonderful day it was. But we try and stick as close as possible. And technology actually helps us. In front of your screen, you have a pathology histograph, we call it, between an osteotomy that was done with a drill that we use with our implant drills, and the other one with a mallet. Now, the shade of pink that you see here actually shows the amount of bone that is there, viable bone. When we use our drills, because of the heat and the amount of bone that we destroy, the time period required for the new osteoblasts to come in is almost 8 to 12 weeks. And that is why when we place an implant, we are doing a lot of immediate implantology as well, which is there. But in compromised cases where you're actually having to drill a lot more, or bone which is D1 quality, devoid of blood supply, it takes a lot more time to actually, the bone turnover rate is much higher. So when we use the mallet, there is no cutting of bone. And if you can see the histograph, the bone is maintained and intact. So it actually can help with immediate loading, so that the bone actually forms much faster, and the immediate loading can be actually something that you can do routinely. So that is how if you can also see the tip, the magnetic mallet does not have a sharp tip in the front, and all our drills have a tip which is either side cutting or front cutting. So imagine condensing bone and imagine drilling through bone. So I'm sure we can all figure out where the healing will be faster. Like in this case, an immediate implant with two fractured anterior implants. First of all, aesthetic zone is very, very crucial. We need to be very crucial, very, very to the point when we do aesthetic zone implants. When the labial plate is thin and your extraction, so the magnetic mild also helps you not just with implant osteotomies, but it also helps you with extractions in popping out root stumps and all these things very easily. It just widens the PDL space and makes the tooth pop out. So if you can see this case, very thin labial plate. Now I have the roots out. I've taken out both the teeth. And so if you can see, I would want to put some, GBR there. I would want to do some guided bone regeneration there. Why? Because if my bone and my labial plate thins out, my soft tissue is going to collapse inward. And what will happen is exposure. Not just the implant, you will start seeing a hue coming between your crown and your implant, and that's how the peri-implantitis is one of those things that can come across, and that's where the implants start failing. And the aesthetic zone is one of those things where you want good amount of soft tissue, healthy soft tissue, keratinized mucosa with good amount of bone there backing it up. So if you can see my parallelism for my implant osteotomies which I've made, and it's a very well documented fact. If your jumping distance is more than 2 millimeters, you should graft it, because that much amount of alveolar collapse will be prevented if you actually put in the graft there. So this is the grafting that I'm doing. I'm actually putting in more and more graft onto the labial plate, so that even after resorption, I am still going to have a thick and healthy labial plate there. And then you put the membrane, and this is the closure. You want tension-free closure there. And this is the patient after 4 months. And I think we were able to do a decent job for such a patient. Aesthetic zone, as I said, is always a complex area. So you need to focus a little more. You need to know the smile lines. You need to know your mucosal tissue. You need to know your gingival show. And all this in totality helps you with a better outcome. Ridge splits. Now, what if you don't have enough width of bone? But always remember, the pattern of aging for the maxilla and mandible is such. In the maxilla, it will collapse in a way that you will actually have a curved, concave kind of a labial plate, but there will be enough bone down below. In the mandible ages in an obtuse manner. So again, the anterior pattern will be concave, but down below again you will find bone. But if the area has been left without teeth or functionality for a very long time, you will very commonly find a knife edge ridge. Now, this knife edge ridge is something that you can actually deal with the help of ridge splits. Ridge splits basically mean that we create a crestal osteotomy and two vertical osteotomies. You can use a saw or a piezotome. And let me see if this video plays. If you can see the video, this is a saw that I'm using, and I'm doing a posterior implant placement. See how thin the ridge is. But I do have bone down below and I have height. So I'm using a saw here very carefully, and I'm doing my alveolar osteotomy, which is the horizontal osteotomy. And after this, I will do two vertical osteotomies and then do a monocortical fracture for my labial plate. Then split the ridge open so that I have enough place to place two decent sized implants. And you need decent sized implants because these are the molars. You can't do with thin implants. They are not able to take the load that you would want to. And see the amount of bone that I have on the labial and the lingual plate. And that is how you can actually do a split. Then you graft the labial plate on top and put a membrane there and close. And this is the X-ray of this patient. We were able to put one 4.5 and one 4.510 and one 412. And that is a decent size to take the load of the molars. What is the other thing? You can have highly pneumatized sinuses. So in these cases, you will have to do something known as a sinus lift. Sinus lift is of two types. Highly pneumatized sinus means you don't have width and you don't have height, actually. And you have the maxillary sinus, which is very low lying. So in these cases, what you usually do is you will either want to do a direct sinus lift or an indirect sinus lift. If following the Karl-Misch protocol, if there is bone less than 5 millimeters, you would want to do a direct sinus lift, which is a lateral window approach. And if it is more than 5 millimeters, you can directly go ahead and do an indirect sinus lift, which is with the use of a densa or a pisotome or an indirect sinus lift kit. There are multiple ways that you can use. You can use an osteotome as well. So in this case, you need a good exposure. You make sure that you've actually calculated the amount of bone height that you have there. Make sure that your window is about 2 millimeters above the residual bone height. And this window, I actually create a lateral window, which is with the help of a dome. Or if I want a wider window, I will use a pisotome. And after that, I just make sure that I'm putting in the grafts. And these grafts, I usually use a combination grafts. I use a Xeno with a beta TCP, or you can use any synthetic graft also if you want. But the Xeno is very important. Why? Because the Xeno graft is going to stay there much, much longer, and you want graft there to survive for as long as possible. You can see the implant in place and the good amount of puff of bone all around the implant, and that's how the sinus lift is performed. So the window is almost 2 or 3 millimeters higher than the residual bone height. This is the residual bone height, which is about 3 millimeters, right? So my window will be approximately at 5 millimeters from where I push in the graft. Then I place my implant, and then I put in more graft, and then I put a membrane and close the graft. This is with the help of a pisotome. So you can make a bigger window with the help of a pisotome. We have this round tip that that you see is known as the elephant's foot. It's actually going to just put some pressure onto the bone and lift up the membrane from the attachments on the sides. Make sure you scrape the margins. Don't put any pressure on the membrane. It is the easiest procedure to do. Trust me. And doing a direct sinus lift can actually help the patient out, because you can actually create bone in areas of highly pneumatized sinuses very, very easily. And it's something done very routinely. See this X-ray now, this 3D DICOM file of this patient. How much residual bone height do you see? You will not be seeing more than 2.5 millimeters in some areas and about 3 millimeters to 4 millimeters in some areas. Now, there are 2 teeth missing here. What is our plan? We obviously want to do a direct sinus lift, but would we want to place the implant simultaneously, or would we want to wait? Both school of thoughts, there's nothing wrong in it. If you think there is a pathology there or the bone levels are too low, you would first want to graft. You would first want to graft inside the sinus and the vertical also. Otherwise, you will lose vertical. So the crown height ratio or the crown implant ratio will be way off. So vertical grafting and direct sinus lift will be the way forward for this. See the CBCT of this one. You're actually, the radiologists actually, if you see, taking nothing away from them, see the way they mark it. It shows that they don't have too much of clinical knowledge. Why? Because they've actually marked the alveolus and they marked a vertical saying that there's 4.3 millimeters of bone. Can you see 4.3 millimeters of bone here? No. The only amount of bone is about 2 millimeters. So this radiologist should have actually marked the width as 8 millimeters, but the residual bone height is only 2 millimeters. Instead, what the radiologist has done is they've shown that there are 4 millimeters of bone. There is not 4 millimeters of bone. So again, here he marked 3.2. There is a crater there. So this is pretty much less than 3 millimeters. Now, in this case, I would obviously want to do a direct sinus lift. You can see my window there. I do a crestotomy to even out whatever is, the granulation tissue and all this ingrowth that was there, and this is how the membrane integrity looks like. In such cases, you would want to check, you would ask the patient to perform the Valsalva maneuver. See how easily the sinus membrane is moving in and out. And that's where you come to know you can even use a flush. It's a normal saline spray. You'll check and get a lot of bubbles coming out if there is a tear. If there's a tear, do you abandon the procedure? No, you don't. There's a way of placing a membrane, then placing a graft, and then going ahead and placing the implants. So these are very routine procedures. In the previous case, as you can see, we grafted, we placed the implant, even with 3 millimeters and 2 millimeters of bone, we placed the implants because most of this bone is cortical. So if you can get under osteotomized and get your torque is about 35 to 40 NCM, you can actually do well. And then we place the membrane on top so that we don't have any graft loss. That's the closure, tension-free. In 7 days' time, you can see how well the gingiva has healed. And that's the post-op X-ray. If you can see the good amount of puff around and over the implants, all this is going to become firm and healthy bone. Again, it's pretty much the same case of direct sinus lift. If you can see the amount of residual bone height, it is negligible. You have less than 2 millimeters of bone. But again, performing the same thing, but in this case, I was using a magnetic mallet. So I grossly under osteotomized, did my direct sinus lift, and simultaneously placed my implants there. See the amount of bone now, what I will get around my implants. So that's the beauty of creating bone where there was no bone. And procedures like these, like guided bone regeneration, direct sinus lifts, bridge splits, can actually help you achieve a lot more. This is a case of a bilateral direct sinus lift, but the biggest challenge was the bite. So we have to make sure that we have enough interocclusal space. If you can see, the bite is collapsed. So performing the same, direct sinus lift, but making sure that these videos, I don't know whether they're playing or not. Again, I'm using combination graphs here, and see the next slide. Yeah, those are the freehand implant placements. Good amount of parallelism there, good amount of distance there, and we will be able to get good 3 crowns there to rehabilitate this patient. That's the post-op X-ray of this patient, and see the parallelism, and see the way we're able to generate bone in cases where residual bone height is less than 2 millimeters. And that's how you perform direct sinus lifts. And trust me, it's way easier and under direct vision to do a direct sinus lift, because in indirect sinus lifts, you can never be certain that you've not torn the membrane. And the sinus is also a beautiful thing. There will be regeneration happening every 2 weeks. You will see if there's a tear or something, the clot forms and the regeneration happens, and the sinus membrane comes back completely in 4 weeks' time. Whenever you do a direct sinus lift, be careful that the area of the 7 will have something known as an antral vessel. This comes in through the bone, and this is above the second molar. Don't be worried. It bleeds a little bit. See, everything in the body will bleed, and bleeding is good. Never be scared of bleeding. The only thing is, you should be certain that pressure and packing solves 90% of your problems. You won't have to do anything more than that. But would you want to put too much of pressure there? No. What would you want to use? You would want to use something known as a roller gauze. A roller gauze, an autoclave roller gauze, you should keep with you. And if you have a bleeder like that, it'll be a proper spurter. The patient's mouth might be getting filled up in seconds, and that's a very normal thing that happens. You just need to put your roller gauze there and keep it there. Just keep it soaked with a little bit of finger pressure with your finger, and it'll stop in less than 7 minutes, 5 to 7 minutes. Everything will stop. And then you again proceed with your procedure. And in this case, if you can see again, direct sinus lift with residual bone height of 2 mm, look at the amount of bone that I have on top of my implants. Even if it resolves, I still have enough. Doing a good extraction is very, very important in indirect sinus lift cases like this. So sectioning your tooth, making sure you have preserved the bone. Using a magnetic mallet, make sure that you actually preserve your residual bone instead of letting go of it, and you just push it up. And if you see, I've utilized the interarticular bone, and that itself acts like a graft when you place the implants, when you use something like a magnetic mallet to condense the bone. So imagine how fast the implant actually heals and osseointegrates, and that's the implant in place. Using of grafts are very, very important, but nothing beats autologous grafts. So what you see on the picture are osteotomies done with the piezotome. This is from the ramus, and this is from the chin. These are commonest sites for intraoral block graft harvesting. Block grafts are very, very important. If you don't have labial plates, your implants are not going to survive. And no GBR will survive if you don't have a good cortical block there. So yeah, beyond the cortical grafts, you will have cancellous grafts. So you take a fair amount of cancellous graft also, because the osteogenic potential is in the cancellous graft, not the cortical graft. And then coming on to some complex cases like these, this patient had a huge keratocystic tumor, which we took out. And then the defect was pretty big. So we got two options. We can either use iliac graft, or when we let it heal, we can either use a chin graft also. So using the chin graft, and if you see after the healing phase, the defect was pretty much 60% less than what it was. Then we just go ahead, put chin graft there, block, put a xeno there, put some synthetic membrane there, and then put a membrane there, then close, place the implant, because now you have enough bone there to place an implant. What is more important than bone in implantology? It is always soft tissue. We always have to respect soft tissue more than bone. Bone we can create, soft tissue we cannot create. So the concept of beg, borrow, steal stands true for soft tissue more than hard tissue. Then other routine cases like, doing a periapical cyst enucleation and then placing block grafts. It's a very easy procedures that everyone can do. And then you go ahead and place an implant. Look at the amount of gingiva there. That's the quality. That is your success rate. The crown to gingiva connection is the most important. If there is any inflammation, it will all start collapsing. Then there can be bigger cases where the tumor was very big. Then in that case, we take bone from the iliac. Now, leaving 2 centimeters from the anterior iliac crest, we take a good chunk of bone, as much as we want, from the iliac, which gives us cortical and cancellous bone, and then we rehabilitate. If you can see, this is like a block taken from the iliac. Then you restore this in the defect, and you go ahead, close, and later on you can place implants in such cases. Or cases like these. The lower one is a basal implant. I don't place in basal implants. It was done by someone else. They attempted basal implants in the maxilla also, but it failed. Then the case came to me. No width and nothing there. This is the ridge. What would you do for such a case? There is no bone there. So remember what I told you. The knife edge ridges will always, if there's height, you are, very, very, it's very possible that you'll find a good amount of bone down below, and that is what I was expecting. And the CBCT also showed me that, but the knife edge ridge was too prominent. What did I do? I used my magnetic mallet here. Using the mallet actually made sure that I can do my osteotomies and change my osteotomy and be very, very precise without letting go of a single speck of bone. And look at the amount of implants, all those 8 implants with good stability, and then GBR and membrane is all that I need to do, instead of going ahead and doing zygomatic implants or pterygoid implants, which we do very routinely for cases where we don't find bone. But in this case, if you find bone, you will find it because it's there. You've got enough height. So there are multiple options. So you'll have to think like that to actually restore in the best possible manner. Or atrophic maxillas like these. Can you see any bone there? No. And these are actually very compromised cases. So then we find bone, place the implants, do the GBR, and after this is a nasal floor lift. So what I've done is I've lifted the nasal floor just like I lift the sinus floor. So I can get about 2-3 millimeters there as well, and then I push in my implants there. I'd use a lot of platelet-rich fibrin to actually help faster healing, then put my membrane there. You can go through this article that can actually help you out with this kind of a surgery. And that's the closure. This is the CBCT post-op. If you can see all my implants in place and doing pretty well. Then this is like, when cases where we do not have any amount of alveolus or, very, very compromised, then we go ahead and do things like these, which are zygomatic implants, pterygoid implants. If you can see, I've placed 2 zygomatic implants for this case. This case was a case of mucormycosis, but the zygoma and the alveolus was intact. The biggest problem was soft tissue. So if you can see, I have an incision which is on the palate. So I've rotated the palatal flap onto the labial aspects so that there is no orointral communication there happening. And in due course of time, with granulation, the palate will close, and that's what that happened. So soft tissue was a problem there, and we got good closure, and even if it contracts, we still have enough soft tissue. That's the post-op CT. Now coming on to something, there was a case of PSI put across in the last presentation. I am very impressed by patient-specific implants because being a surgeon, I get a lot of these complex cases. In total, I have done over 201 patient-specific implants, that is enough to make a case series on its own. I've had 2 failures till date. I'm talking about time period of 8 years now, since we started doing a lot of PSIs together. And trust me, it is worth it because you can actually restore these complex cases, give them the ability to, restore and give them the ability to chew, give them the functionality. It has actually changed a lot of things. Cases like these, severe atrophic maxillas, you have no bone there. You have fractured implants because everything has been attempted. Even the zygoma won't rest because the zygoma also needs an alveolus to rest upon. So split design PSIs like these. This patient did not want to wake up without teeth, so we did the PSIs and did an immediate loading before. If you can see, the patient is intubated, and before the patient woke up, we had already given him, around a fixed teeth or a temporary denture on the PSI. You can also use a lot of 3D prosthetic planning here. You can use your scanners, you can use digital implantology, because the analogs can work as any implant company. You just have to mimic the prosthetics, just like a routine implant after that. Cases like these, mucormycosis, there is a huge defect inside. So usually what people are doing is they're giving obturators in such cases and all. No, so we need soft tissue here. So like I said, so first we did a flap for this patient, and then if you see the eyeball levels are not the same, so that means there is something known as inophthalmos, which is volumetric loss of the orbital volume. So we made a 3D model for this patient like this. This is the surgery where I use the zygoma and the contralateral alveolus, and this is a mesh that I've placed to support the eyeball so that we can give back some volume. And that's the patient on the second day post-op. And you figure out that this is the same patient who underwent this and has the PSI in place, and this is the second day. That's how fine you can actually do your surgery. Suturing techniques are very, very important. And fixed prosthetics in 2 weeks' time is what the patient got. Fixed teeth. That's the beauty of patient-specific implant. That's the patient in about a month's time from surgery. And he's doing very well. Now it's been almost 6 years since we did this surgery for him. We've been regularly following up. Doing very well, very, very well. One more mucormycosis case, there was an orbital exenteration also done. So again, a split design, extraoral incisions using the pretty much this ones which were there before. Then intraoral planning, you can, as I said, you can use whatever you want. You can use multi-units, you can use castable abutments, you can use anything you want, and restore. And we even gave a prosthetic eye to this patient, and he was pretty happy. Or cases like these, like vanishing bone disease. So this was an older design of the PSI, very old design. This years back we did. So if you see, this is one piece, and this does not have implant analog. So, and obviously, if it does not have, so you need to put titanium copings and put cement there. So we've stopped using the use of cement anywhere. It's all screw retained now. And in the lower jaw, we use conventional implants, and that's the post-op X-ray, normal impression copings and prines, and that's the patient. And it's already been about, again, 5.5 to 6 years since we did this case. Or cases like these RTAs, this patient, I only operated one day. And after 4 months, we had to reoperate him because the first surgery was to save his life. Then this, we had multiple fractures on his face, but he was intubated for a very long time because this patient had a head injury also. We couldn't do much other than just fixing the fractures and saving his tongue. So the lower jaw underwent osteomyelitis, and he had a collapse of the anterior maxilla. So if you can see, the osteomyelitis debridement was done, and there was a big defect there. So we had to use the iliac to use as a block graft to maintain some continuity in the lower jaw. And we also use the iliac in the maxilla like this and put some cancellous bone there to help normal bone formation. Again, the soft tissue was the problem. So what soft tissue can we get in the lower jaw? We hardly have any options when we use, when we want to cover up in the lower jaw. We can use a buccal myomucosal, but very difficult for it to rotate and cover this defect. We used a tongue flap. If you can see, the tongue flap was done to generate some tissue. My endpoint will be to do a PSI. So after 4 months, once I get soft tissue, I did the PSI for this patient. And maxilla, if you see, all the other plates are still there. Some of the plates are removed. These were done years back because for the fractures that he had, which I only fixed. If you can see, I was able to put normal osseointegrative implants because of the amount of grafting I did for the maxilla, and the PSI in the mandible acts like a dynamic compression plate. At the same time, it gives, you can rehabilitate the patient with teeth. This is how the patient looked before, and all the impression copings and attachments. And that's how a happy face looks like once you're able to rehabilitate complex cases like these. Selfies never hurt if the patient is sending them to you. So cases like these, again, compromised cases, you can use modified split designs like these. These are also PSIs for the mandible. Maxilla, we still have options like the zygoma and the pterygoid and all these other things. Do we have any other options for the mandible? No, we don't. Either you use basal implants or things like that. I am not a firm believer of basal implants, if you ask me. So I straight away go ahead and do my PSIs. And that's how the PSI looks in the mandible. You can do segmental PSIs also, smaller areas like this. This was a resection case again. So mandible again, when the nerve is very high, how short an implant can you place? Probably 5 millimeters, 6 millimeters. There's no implant shorter than that, right? Will it work? the crown height ratio is, again, crown implant ratio is too much. So the chances of failure is very, very high. So we can do a PSI if you can see the nerve is higher, the screws are lower, and this rests on the alveolus. So again, you can actually do cases like these as well with the use of PSIs. And that's the prosthetic in place. And then when you have failed implants like these, again, split designs, very fine designs now we have. And if you can see, that's how the PSI looks like. The cutting guides in place, do the osteotomies. And another one, this case I did just a week back. If you can see, again, hardly any bone there. So we can keep doing as much grafting as we want, but this soft tissue is a major problem. So looking at that, we went ahead and this was the planning. And that's how it looks on the guide. That's the cutting guide. So that's the amount of bone that we had to remove. That's the implant in place. I always use vancomycin on my implants. I learned this from the orthopedic guys, and their implants were doing really well. So use of vancomycin in such cases on your implants is very, very important. So what I would say is, we have come a long way, and cases like these are complex to a nature, and there's so much to learn that every day we're finding a new way to rehabilitate, restore, form, function, and a lot more. And most of all, the confidence of the patient. Surgery is the mainstay, but the patient has come for teeth. So don't undermine the importance of prosthetics when it comes to implantology. There's no point of me being a great surgeon or a good surgeon and doing a good surgery, placing implants there, if I'm not able to rehabilitate that. So that is why every planning should have in consideration the soft tissue, the hard tissue, and most of all, the prosthetics. So all these, I definitely do believe that, I am my own competition and I'm only competing with myself. What I've done before, I just want to do it better tomorrow. And that's one philosophy what my boss taught me, and it's been with me since ages. I have to progress, and that is what all of us have to learn. We all have to do well and better than what we did yesterday. So I would just say that I'm very grateful to all of you for being here and patiently listening. And this is my contact information. If you want any information or you want to get in touch, please feel free. I would be more than happy to take up any questions if there are any. Thank you.
Thank you so much, sir, for such a wonderful lecture. Any of the participants, do they have any questions? You can ask in the chat box, or you can turn on your mics and ask any question if you have.
I think we might probably have some questions coming up later. Everybody is now going to enjoy the Sunday.
Maybe, sir. Nobody's.
As I said, questions will pop in later.
Thank you, sir. It was a very informative lecture, sir.
Thank you,
sir.
Dr. Thank you so much. Thank you.
So with this, we wind up with our Osseointegration Mastery Conference. I would thank you all for joining, and I hope you all understood a lot about implants. We'll see you soon. Take care.